for our chairpersons and other things. So till that time, students, UGs, I think, or PGs. Okay. So this is just for fun, nothing else. Okay. So our romance friends know about this. So I'll be just asking you a few things. You have to recognize. Okay. I have put over there. So till sir comes, chairpersons, we will have this interaction. So this is just a quiz. In that one, there are two parts. One, you have to recognize the personality, and important thing, what medical disorder does that person have? That is the first question. Okay. So who is this? Disease, please. Anything else? Hepatitis B. Good. Our rheumatologist know? Yes. Correct. So hepatitis B, myasthenia gravis, colitis. I am not talking about his trauma which he has underwent. That's a different issue. Okay. So these are the things. Who is it? This is. You stole my words. Okay. Exactly. Okay. Fine. So the next one. Louder. Sonali Bendre. Yes. Good. So I don't know. So Lisa Ray. Yes. This is please. Huh? Exactly. So I am very happy that all our rheumatologists know about this. So I want you to also have an idea about those things. So it is just why I am highlighting all these things is diseases and disorder doesn't spare anyone. Okay. So who, what and how, whatever they may be, obviously it is not going to spare anyone. Okay. So you can give examples if at all if your patient asks you, sir, why me? So you can say, so why not him? Okay. So Lisa Ray, multiple myeloma, correct? So anyone remembers the films or other things acted by her? Very famous song. Anyone else? Chengappa. No. Offrey song you have heard of? Water is a famous movie. Huh? Sonam Kapoor. This is please. Type 1 diabetes. Consultants knows. Exactly. Exactly. So I am getting more answers over here. I am happy for that one. People are aware that the celebs can also have diseases. Wasim Akram. Again. So diabetes, type 1 diabetes basically. Okay. So diabetes not at 50 years of age, it's around 20 years of age. Type 1 diabetes. That's only I have highlighted. Jaunty roads. Yes? Sir, you are beautiful. I am happy. You are not allowing me, no one allowing me to give the answers. Good. Who is it? Yuvraj Singh. Okay. What cancer? Right? You can't say that. Okay, yes, this is a teratoma like whatever this is. Yes, mediastinal seminoma. Beautiful. So his story is like that. Which country is he from? New Zealand. New Zealand. Beautiful. I am very happy for the answers. So he wanted to become a player basically. So unfortunately developed. This is 1980s. He developed rheumatoid arthritis. He is famous for his cricket fingers. So yes, absolutely correct. So Brian Lara. This is Ashtakam. Good. At least I have to answer one. I can. Yes? So he is Hep B positive. So no one remembers.
Michael Atherton.
Who is it?
Michael Atherton.
Your staff? No. Student? So this is please. Mike Atherton from?
England.
England. Exactly. This is So till this time, okay, before Yuvraj and all those things, I was discussing about general diseases, okay, in general all those things. So it is rheumatological disease. So can anyone guess? Because of that disease, again he left playing. Huh? Exactly, and spot. Yes. Beautiful guess. And I should give it to you. So, my other turn. Okay. So, and spot. Yes. Yes. Hotel California. Okay. This is no. Okay. So he is the founding member of the rock group Eagles. Okay, so he had arthritis along with ulcerative colitis, that is IBD-related arthritis. He died because of pneumonia secondary to immunosuppressive drugs. So the famous song is Hotel California. Yes, now, so no staff should answer this. First this one. Who is he? So you should see both the pictures. Okay. So the first picture and the second picture. So you tell me in the second picture what is the significant thing? Huh? Unfortunately, he has to stop all his surgeries because of RA with deformities. Okay. So I will leave it for your thoughts. That so not only players, actors, okay, so even doctors, majority they have some other problem, okay, so, okay.
Jagrants, Venus Williams, Jagrants.
Venus Williams, not Serena Williams, exactly. So, Jagrant syndrome, because of that she left playing because she had extreme fatigability because of the disease, okay, I think, yeah. So can anyone elaborate the story? Yes?
She received a transplant from...
Yes. So she had lupus nephritis and she underwent renal transplant. So after that also, she is like this. It all depends on what is the follow-up, what is the regularity of Yes, absolutely yes. So after renal transplant with all steroids, all immunosuppression, whatever she should be on, sure, this is, you can think before, you can think this is after. So we always think about post-transplant, whatever the transplant, steroid and all those things. So we can give an example of this. This is now. Ball is in your court. So at least I have got another one where I can answer. Yes? Whole family has got psoriasis. Okay? So whatever it may be, so psoriasis. So can you name another person recently who had myositis? Who had myositis? You are a big competitor for me. I researched everything. Yes. Myositis? Okay. I have not put that picture. So you remember the second sister Babita in Dangal movie? She had myositis. Okay, she had myositis. She died because of secondary infection, because of mostly immunosuppressive treatment, whatever it was given. So she had a very bad, most probably lung infection, and she died because of that. So that is the recent one which we can remember. Okay. So now also she is acting, so you can think about those things. So if I am correct, she was treated with IVIG upfront most probably. So I don't know the exact treatment or whatever it was given, but she was treated with, that's what I read in the article. So she was given as fast as possible the IVIG and other things, and she recovered from that one. And again she is back in the industry. Okay. So just this is for fun plus information that so diseases, whatever the disease is not going to spare, whatever the celebrity or whoever it is there. So we can go on discussing all these things long time. Sir, okay. Yes, sir. Yes, sir. I thank Dr. Lokesh sir, Lokesh AJ sir, which I think we knew each other long back, nearly a decade. Okay, so I'm very grateful to him because for inviting us as a rheumatology team and in person contacting me as a first person to conduct the CME. Okay, and this is not the first time we are conducting CME in Kodagu Institute of Medical Sciences. So this is the second time which we are conducting in the institute as such. So the first CME when we had just come from our post-TM courses and other things. So we had our CME in 2018 in the same hall. So at that point of time, most probably the college was started at that point of time, mostly recently, and sir had been appointed as HOD of Medicine Department, if I am correct. So he gave us an opportunity to interact with the faculty over here, and this is in 2018 July, August, I think so. So we had our team at that time. We had a day CME in 2018. So we had different speakers at that time also. So some of us are over here. So me, Vikram, Subramaniam, Nagaraj. So we are all here again. So I thank AJ Lokesh sir again for giving us the opportunity to interact with each other. I would like to accompany me over the dais for thanking purpose. And this was the last CME, like that time we had different faculties at that time. So thank you very much. So now we start.
All the dignitaries, esteemed faculty members, senior clinicians, delegates, postgraduate students and everyone present here. I, Department of General Medicine, Kodagu Institute of Medical Sciences Madikeri, in association with the Karnataka Rheumatology Association, it gives us immense pleasure to welcome you all to the CME on case-oriented approach to rheumatological diseases. Rheumatological disorders often challenge clinicians with their diverse presentations and overlapping symptomology. Through this CME, we aim to move beyond textbook description and focus on a case-based, practical approach, fostering clinical clarity, interdisciplinary understanding, and evidence-based decision-making, ultimately enhancing patient care. To begin this academic program, we have a session that addresses one of the most common yet challenging complaints in clinical and introduce our speaker.
Good morning, all of you. First of all, let me apologize because we are slightly delayed because of the travel. And I'm sure you had a beautiful display of all the people around. That means to say even your so-called the most important people in this world also can get diseases. I have the pleasure of introducing Dr. Chengappa. He must be from Madikeri, I suppose. Chengappa, I think, is the name inbuilt in Madikeri itself. He has finished his MD and DM from a very prestigious institute of JIPMER. Presently, he is a consultant immunologist and rheumatologist in Mysore. He was the associate professor of clinical immunology in JIPMER. He has a lot of awards. Applar Young Rheumatologist Travel Grant to 23, International Travel Scholarship from Science and Research Board, Government of India 2023, Best Oral Abstract at the 25th Asia Pacific League of Association of Rheumatology Conference 2023. 2023 seems to be a very good year for you, Dr. Chengappa. Best Scientific Work in Indian Journal of Rheumatology 2025. He has more than 80 publications in high-tech journals and of 1,303 citations. It's a very good number. and his special interest is lupus, myositis, and allergy immunology. Now, all that is for them. For the common man, for a clinician, what is important is how do we approach a person who has joint pains. And everything looks the same. But one thing Sir William Osler said, you remember, you know William Osler? He is the father of modern medicine. He said, you remember this always. If you have time to spend with the patient, in all probabilities, at the end of your discussion with him, probably he'll end up telling you the diagnosis. It is more so in the field of rheumatology where history is important and investigation may or may not be specific. So with these few words, let us listen to Dr. Chengappa, and he is going to enlighten us as to how to approach a patient, adult, with a joint disease. It can be single joint, multiple joint, small joint, bigger joint, symmetrical, whatever. He is going to tell us. Over to Dr. Chengappa.
Explain how we approach arthritis and try and learn together. So before that, let us start off with a question. How many of you actually sit in a clinic, see patients? Hands up please, show of hands. Show of hands. OPD patients. Okay, great. So, try to answer this to me. When you are sitting in an ortho OPD or a medicine OPD, what percent of your daily patients are females between 20 to 50 who keeps coming again and again with migraine? Is it less than 5%? What is your take? More than 30%. Is that right? Yes. Great. So I think we are starting off at the right place. Then the next question to especially students is, when you hear the term arthritis, what is it? Is it a disease? Is it a symptom? Is it a mindset? Or it's just a figment of your imagination? Disease, how many for disease? One for disease, but too many voices. What else is it? It's a symptom. Fantastic. So arthritis is a symptom. It cannot be a disease. It can be a rheumatoid arthritis when it becomes a disease. Yeah. So what is arthritis? Arthritis is nothing but inflammation, itis in the joint, arthro. Yeah. This inflammation can be because of maybe 1,000 reasons. Tomorrow you fall, hit your knee, you'll have arthritis there. That is post-traumatic. So arthritis is a symptom which includes pain, redness and warmth, swelling and decreased range of motion, or in other terms, loss of function. This is the pillars of inflammation that has been told. You know, Arthur, Ruber, Galler and Functionalizer. That is pain, redness, warmth, swelling and decreased range of motion. But the patient will not tell you all of this. What the patient comes to you is with pain. That is why you see about 30% of people coming with migraine over the OPDs. So we will try and decipher how do we do this. So when somebody comes with pain, our first thing would be, where is the pain? Is it joint related? Is it because of structures that are surrounding the joint? There are muscles, there are tendons, there are bursa, lot of things around the joints. Or is it just a muscle and a bone pain? Or is it a nerve or a blood flow issue? You know, all of this can cause pain. So when patient complains of pain, it is our duty to find out, is it because of the joint issue or an issue that is outside the joint. So if somebody comes, we try to first identify the source, then we try and identify what type of arthritis it is, if we know that the source is from the joint. And finally we try and identify the red flag signs where patient might need early referral or early intervention. Is that okay? Great. So how do we really say them apart? Very basic slide. If it is a nerve or a vascular issue, then you will have some burning sensation along with pain. You might have some claudication pain. That is, when the patient walks, there is a constant pain in that area, or patient works with the hand, then they have this muscle catch like symptom. Along with that, they'll have some sensory deficit, some pulse deficit, all these things. Then if it is a muscle or a bone pain, there might be weakness, and the pain is usually deeper. It's not superficial. When you examine, there might be some loss of muscle power, and there can be diffuse tenderness all along the limb. And then when it is peri-articular structure, this is where we most of the times fall flat. If it is peri-articular structure, if it's a tendon issue, if it's a ligament issue, then the pain is mostly while we do one type of an activity, or the pain is aggravated at one angle of the activity. Suppose if it is a shoulder pain, the patient says that I can't put my hand behind. So that is not arthritis, it is mostly a peri-arthritis. Had it been arthritis, the pain would have been all through the range. From up to down to side to inside, everything would have caused pain. So if the pain is at a particular angle or a particular movement, if the pain is absent while you are doing passive movement, then it is mostly a peri-articular lesion and not the arthritis. So you know how to identify if it is a joint or not joint? Yes, no, maybe, slept off. So once we have this, once we know this, so if you look at the causes of arthritis, there are plenty. We usually classify them as acute, chronic, whatever. We'll deal with them one by one. So it is very complex, but it is very logical. How do we approach arthritis? It is like how we approach any other complaint. Suppose you have a patient with fever. What are the questions you would ask the patient? What is the first question you would ask? Yavaginda ide, how many days? Fantastic. Same thing for arthritis. Second question, how many joints? Because in fever we ask what type, no? Is it continuous, intermittent, remittent? We ask this. So here we try and find out how many joints and what pattern, which are the joints that are involved. Then we find out what is worsening, what is improving joint pain. Is rest worsening, is rest improving? When you sleep and get up, is it better, is it worse? These are the questions we ask. And finally, what are the associated symptoms? So same thing we ask for fever. If you can just look back, these are the same questions we ask for fever. So we look for number of days, we look for extent of joint involvement, we look for aggravating and relieving factors, and finally we look for the associated symptoms. So why do we ask for the duration? So based on the duration, in arthritis, we classify if they are chronic or acute. So if somebody has a arthritis for less than 1.5 months, that is less than 6 weeks, we consider it to be acute to subacute arthritis. So our workup will be way different. And then if it is chronic, that is more than 6 weeks, then we start thinking of more of autoimmune conditions and other degenerative conditions. So in acute arthritis, we try to see how many joints are involved. So the cutoff is 4 joints. If it is 1 joint, it is monoarticular, no-brainer. If it is 4 or more joints, then it becomes polyarticular. So anything between 1 and 4 joints is what? Oligoarticular. Fantastic. A weak with very florid arthritis, most likely it is infectious, para-infectious or malignancy. So don't start doing your rheumatoid factors and other things when people come with hyperacute arthritis. Wait for it to not become chronic, but to find out what it is. So what was the next question we wanted to ask? After how many days? How many joints? No? How many joints? And you answered that. Mono, oligo, polyarticular. And after how many joints, what is the pattern? So in chronic arthritis, we have all these conditions. I'm sure you know all the names. Psoriasis, if it is associated with arthritis, we call it psoriatic arthritis. Commonest form of autoimmune arthritis that we have is rheumatoid arthritis. Then we have reactive arthritis. We should know that all connective tissue diseases can have arthritis. All vasculitis can have arthritis. It's not that, if there is arthritis, it is only one of these classic arthritis predominant conditions. And some of the infections can also have arthritis, some of the malignancies can also have arthritis. especially chronic ones. So after how many days, we said that we'll also look at how many joints, monoarticular, oligoarticular and polyarticular. Don't try and remember all this, not necessary. Next most important is the pattern of involvement. When somebody has arthritis, you ask, how did it start? How did it progress? If somebody had a knee arthritis, then it went down to the elbow, then the small joints of hand, while the others were present, then it is called additive. Yeah, it is adding on, one after the other. Then you have migratory arthritis. What is the cause for migratory arthritis? No? Acute rheumatic fever. Classic teaching. Right? Acute rheumatic fever has migratory arthritis. What do you mean by migratory arthritis? Yeah. But additive is also from one joint to another.
It resolves in the
Previous joint resolves completely. Like how the birds migrate from Africa to India. When they leave that place, it is gone. It goes to a new place altogether. So that is migratory. Another is episodic. So there can be a confusion between migratory and episodic. So episodic might happen in the same joint again and again, whereas migratory is almost in a continuum. And episodic will have some time between these two episodes where the patient will be symptom free. So patient will have knee pain for some days, after that 20-30 days will be absolutely fine, then we'll have again another attack. Whereas migratory, the knee pain will come to elbow pain, patient is never pain free in between. Yeah. So some of the conditions that can present with these kind of arthritis are listed here. Additive classic example is rheumatoid arthritis. If spine is getting additively involved, we think of spondyloarthritis. And if there is migratory, the classic teaching is acute rheumatic fever along with reactive gonococcal, Whipple's disease. Intermittent and episodic, classic example is gout. Palindromic rheumatism is another. Inflammatory bowel disease is another. And rarely, most of our connective tissue diseases can have episodic, fleeting kind of an arthritis. So then the next question would be aggravating and relieving features. So we want this question to identify if the arthritis is because of an inflammatory condition or a degenerative condition. Have joint stiffness. So is it arthritis? No, it is not. If the if the stiffness lasts for 30 minutes or more, that is when you have suspicion that it could be arthritis. That is the first criteria. That early morning stiffness is for more than 30 minutes. Second is, if the patient rests, the arthritis worsens. That is, overnight sleep is going to worsen your pain and swelling and stiffness. This means that during the rest, something is getting accumulated in your joints and causing more inflammation. So this is an inflammatory kind of arthritis. So you can imagine the opposite one. Somebody has a knee pain because of osteoarthritis and you climb the stairs. Is the pain going to improve or worsen? Worsen. So on activity, if it worsens, it is mostly a degenerative or a mechanical kind of an arthritis. As opposed to if it was a inflammatory arthritis, like a spondyloarthritis patient, will have hip pain. He'll get up in the morning. After doing some activities, he gets better. So that says that this is mostly an inflammatory phenomenon. So activity relieves the pain and rest will aggravate the pain or stiffness. This is another feature of an inflammatory arthritis. And of course you have these lab values, ESR, CRP, which can be elevated but they are quite non-specific. Let us not believe them so much. So what are the causes of inflammatory arthritis? Same old causes. You know all these names. Rheumatoid arthritis, spondyloarthritis, most of the connective tissue disease, vasculitis, adult Still's disease, some infectious causes and some paraneoplastic causes also can cause. Whereas if you look at non-inflammatory causes, classical being osteoarthritis of knee, hand, then there could be fibromyalgia where there is diffuse aches and pains along with some joint pain. Then there could be post-trauma. Then there are inherited collagen disorders like Marfan syndrome, yeah, where the joints are hyperlax and you keep working and you keep increasing the load on the joint and it keeps aching more and more, which is a kind of a non-inflammatory arthritis. So these are the only 4 questions we have to ask, and the last question is what are the other symptoms? That I'm sure you know how to ask, right? It's very simple. You ask for constitutional features. What are the constitutional features we ask? Fever, Appetite, weight loss. Yeah, these are the constitutional features we ask usually. Then we examine the skin, neck and hair. We look for non-joint pain, musculoskeletal features which will come to, and other systemic examination. So these are the constitutional symptoms. In skin, we try to look for some skin rash somewhere. It could be skin tightening like this, or it could be the classic mala rash. But patients don't read textbooks, they can come with any kind of rash. But look out if there is an abnormality in the skin. Then you look for systemic, is there cough, are there cramps, is the heart fine, is the kidney fine, is there any seizure history, stroke history, are there any mouth ulcers, is there redness of eye? All these examinations, what we usually do in a general physical examination. And then finally, this is something we all miss out, a musculoskeletal feature which is not because of arthritis. Can you all identify what this is? What is this? Middle finger swelling. Great, dactylitis, sausage digit. So this is not only arthritis. No, arthritis would have been limited to this place or this place. But this is not only arthritis. It is arthritis along with some soft tissue involvement. Then what is this if there is pain here? Tennis elbow, somebody was telling. What is it?
Lateral epicondylitis.
Epicondylitis. It's also called as enthesitis. Enthesitis is where the muscles get attached to your bone, enter the periosteum. That complex is called enthesial complex, and enthesitis is seen in most of the spondyloarthritis phenotypes. Spondyloarthritis are ankylosing spondylitis, psoriatic arthritis, and reactive arthritis. There are two more, but that's okay. So this is dactylitis, this is enthesitis. Fine? So we are going to solve cases. Are you all ready? You know the 4 questions to ask, right? Let us solve questions. So here we have a young male who presents with a fever of 5 days, rashes of 3 days, and multiple joint and back pain for 2 days. This is associated with significant morning stiffness and responds excellently to painkillers. So when you look at the fever chart, definitely there is spiking fever, and when you look at the body, there is a rash which is red. So let us answer this systematically. Is this acute or chronic? Acute. Is this monoarthritis, polyarthritis? Polyarthritis. Is it inflammatory, non-inflammatory? Is it what are the associated features? Rash and fever. Fever. So this is acute inflammatory polyarthritis with fever and rash. What could it be if it is acute?
Viral infection.
Viral infection. Fantastic. So this is viral infection, most probably dengue. Yeah. So at the end of your examination and history, you should be able to tell this in one sentence. Is it acute chronic, mono oligo polyarthritis, inflammatory, non-inflammatory, and what are the associated features? That itself will give you 80% of your answers. So acute or hyperacute arthritis is mostly infection and malignancy. Don't become too liberal with immunosuppression in such cases. Next question. A 62-year-old female comes with multiple joint pain, swelling of small joints of hand, wrist, elbow, ankle since 8 years. It has been adaptive, it is symmetrical. Along with this, the patient has mouth dryness, and when you examine, the chest is showing bilateral clefts in the lung. The patient complains of EMS is early morning stiffness of 2 hours, and it usually partly relieves with activity. Can we answer? Is it chronic or acute? Chronic. Number of joints? Poly. Inflammatory, non-inflammatory? Non-inflammatory. Yeah. Is it inflammatory, non-inflammatory? So EMS of 2 hours. 30 minutes is our cutoff. Early morning stiffness. And what are the associated features? Mouth dryness and? So what does this patient have? Jogren? Who said Jogren? Somebody said no.
Secondary job.
Sir said Jogren. Secondary Jogren. Fantastic. What is the primary disease? What else does the patient have? With that?
Secondary job.
With that?
ILD.
ILD, interstitial lung disease. Lung is involved. That matters for a treatment decision. So, this is rheumatoid, deforming rheumatoid arthritis. So, there is no doubt about rheumatoid arthritis. If you show your teachers this hand, they will tell it is rheumatoid arthritis. We are just making it easy for you. Okay. It is a rheumatoid arthritis with secondary Sjogren with interstitial lung disease, and detecting the interstitial lung disease is very important for you to plan treatment. So, in an autoimmune disease, especially if it is long-standing, especially if it is classic rheumatoid arthritis, look for extra-articular manifestations more closely. Next case, 32-year-old male who comes with a joint pain and swelling of 4 joints, which was right knee, bilateral ankle, right elbow since 8 months. Also has some inflammatory back pain with restriction of neck movements. Has epicondylitis and what is this? Dactylitis, solved for 6 months. The joints have been additive and symmetrical. The early morning stiffness is about 1 hour. No response to steroids when you give oral steroids. Is it acute or chronic? Chronic. Is it, what are the number of joints? 4. What? Is it inflammatory, non-inflammatory? Inflammatory. What are the associated features? Dactylitis and enthesitis. Do you want to look for something else? Yeah. Huh? Tell, it's okay. What other organ would you want to look for? Eyes. Heart. I would want to look for skin, because when there is dactylitis and enthesitis with an asymmetric arthritis, we have to look for reactive or psoriatic. Yeah. So we searched, and around his umbilicus there was this small patch of scaly lesion, which he also didn't know. We had to discover it. So it was a case of psoriatic arthritis. And in psoriatic arthritis, steroids work but not to a great extent. And giving hydroxychloroquine might be detrimental because it will worsen the skin lesion. So it is a spondyloarthritis phenotype because it has dactylitis and enthesitis. Spondyloarthritis is because of psoriatic arthritis. So before starting steroids, especially in a seronegative, what we call now, we have to be doubly sure, and we have to look deep. Yeah, so seronegative arthritis itself is a red flag. So don't believe if there is a diagnosis of seronegative arthritis. That means that we have not looked deep enough, that's all. So be a little careful. Next question. 65-year-old male, multiple joint points with swelling for 8 months, which was symmetrical with an early morning stiffness of 1 hour, non-deforming, relieves partly with activity. There has been some skin rashes that were like this on his shin. And on respiratory examination again there is crepes in the lung field. Is it acute or chronic? Chronic. Number of joints involved? Multiple, poly. Inflammatory, non-inflammatory? Inflammatory. What are the associated features? Skin rash and crepes. What are these skin rashes? Fantastic. They are erythema nodosum. Now you have a patient with arthritis, erythema nodosum and lung lesion. What could it be?
Late onset RA.
No. What could it be? Yes, please. Sarcoidosis is one. Next is, we are in India.
TB.
So this was a case of TB with epics, involvement. And this kind of arthritis is called Ponson's disease, which is a reactive process to the tubercular bacteria. Goes off with only giving ATTs. We give symptomatic treatment during that time, but after the ATT is completed, it goes off. So if more than one associated feature is there, if there is only one associated feature, fine, you can be a little lax, but if more than one is there, then be extra careful, because it could be infection, it could also be a CTD, which is mimicking a rheumatoid arthritis. So be a little careful. Next, similar case, a 52-year-old female with multiple joint pains, swelling of 8 months, with early morning stiffness of 1 hour, additive symmetrical, relieves with steroids. Fever has been there for 6 months, and rash, this kind of rash on the back, has been there for 4 months. The arthritis is non-deforming. Is it acute, chronic? Chronic. Number of joints? Poly. Inflammatory, non-inflammatory? Associated features? Rash and fever. You have seen such a case before, no? But what is this? Okay, psoriasis will not have so much fever. What are these rashes? Okay, at that same place but not short sign. Okay, fine.
Subcutaneous lupus.
Subcutaneous lupus. Fantastic. So this is a case of SL. So what I mean to say is, if there are more than one systemic or extra articular features, then it is mostly something else. Be a little careful. Just dryness of throat, it still could be rheumatoid. But if there are more than one extra articular features, then it could be infection, malignancy, or connective tissue diseases. Malar rash. But patients don't read textbooks. They can have any kind of rash, and malar rash should have come and gone. So we had a patient recently who was telling that they had put makeup, and after that there is some allergy. So you will tend to believe that, but that was a malar rash. Yeah. If patient says that she has allergy on the face, then be a little careful. Yeah, that's what I meant to say. But CTD, patients don't read textbooks and come. They come with all the symptoms at different time points. Depends on our luck and the patient's luck when they have reached us. Okay, last couple of slides. This is a 52-year-old patient, very similar case. Multiple joint pains, swelling for 4 months, symmetrical, with significant early morning stiffness, with fever and again skin rash. This was the skin rash. And this is the fever chart. So I am making it a little harder for you. ANA was positive and rheumatoid factor was positive in this patient. What are these? Is it acute chronic? Chronic. Is it, what are the number of joints? Inflammatory, non-inflammatory? Associated features? Fever and rash. What are these rashes? What are these rashes? Polyarthritis nodosa. Vasculitic. You mean to say it is vasculitic rash. Somewhat similar, very close. What are the skin rashes in infective endocarditis? What is in the eye? Janeway lesion and osmosis. So though antibodies are positive, these lesions are suggestive of an infective endocarditis rash. Because we know connective tissue diseases will not have such isolated rashes. It is more like a vasculitic because it is embolized and sat there. That is what it looks like. So this was a case of infective endocarditis. So what is the take home here? If you have multiple associated features with multiple autoantibodies, again be a little careful. Multiple autoantibodies that are positive could mean something else. This is a 42-year-old male who was obese, alcoholic, joint pain, swelling, erythema, involving the MTPs and knees for last 5 years. Episodic attack initially. Now it has become multiple joints and the joints look something like this.
Gouty arthritis.
Yeah. So the duration is it is chronic, but it is episodic. Yeah. It was episodic. Now it has become chronic, polyarticular, non-episodic, additive. Yeah. So the problem with gout is a diagnosis for life. If you make a diagnosis of gout, it is a diagnosis for life. If you only treat the episodes and leave them, they go on to become polyarticular gout like this. So you have to counsel. It's very difficult. They are probably the toughest patients to treat. They don't come back. But you have to counsel them for a chronic lifestyle modification and treatment. And 24-year-old male who comes with joint pain for 2 weeks. 2 weeks is acute, bilateral knee and left ankle joint pain, oligoarticular, early morning stiffness of 1 hour, had history of loose motion 3 days ago, and now comes with this kind of a skin rash along with pain. What is the skin lesion? Fantastic, keratodermoplenological in a case of post loose motion, not gonococcal. Gonococcal does not cause loose motion.
Campylobacter.
Whatever, E. coli also can cause. Okay. So, post gastroenteritis was there, after that developed inflammatory arthritis with skin lesions, most likely reactive arthritis. So, not all acute arthritis are infectious, some could be para-infectious, means infection is gone, especially chikungunya. patient has fever for 2-3 days, but after that continues to have arthritis. Though it is acute, it is para-infectious. So what are the red flags we learned? Basically in arthritis, I think it is simple, no? Just 4 questions to be answered in arthritis. And at the end of your history, you'll have to frame it in a sentence. That itself will solve a lot of problems. So if arthritis has got more than one associated feature, then start thinking of connective tissue diseases, start thinking of infection or malignancy. If rheumatoid arthritis is there for a long time, look for extra-articular manifestations. Seronegative arthritis or multiple seropositivity, both are a problem. Be a little careful. If there is explosive onset or multiple very severe pain very early on, then most likely it is an infectious process. And if there are poor response to painkillers or steroids, again then be a little careful. A diagnosis might be wrong. We have to take a step back and reanalyze. So to summarize, identify the source, identify the type of arthritis, identify the red flags. I think if we do this, mostly we don't go wrong. And at the end of our examination and history taking, we'll have to put it out in a sentence. This is a chronic, symmetric, additive polyarthritis with fever. So this is at least the thing that we have to write at the end of any arthritis history. After this it becomes easy. You ask ChatGPT, it will also give you all the answers. Yeah. Thank you so much.
Questions or doubts regarding this? Anybody?
Is there any
Oral contraceptive pills. No. There is no association of using OCPs. With thrombus, yes. In primary APS, we ask them to avoid certain type of OCPs. I think Vinod sir will build on that further, but not with arthritis.
just one more question. With the lifestyle changes now and with the changing diet, has it caused an increase in incidence in any of all these autoimmune conditions?
More than the lifestyle changes, I think yes. We don't have data to say that. More than the lifestyle changes, I think our country is aging now slowly. So we know that most of these inflammatory arthritis peak at around 45 to 50 years. That is when it peaks. And in India, we are still seeing the peak at 28, 30, 40 years. This is our peak right now. So you can imagine when the bulk moves up there to 40, 50, the demography changes, then I think there's going to be more and more autoimmune diseases that come up. I think more than lifestyle and other things, this is also important.
Chengappa, now many of patients in the rural side, they go to the general practitioners or Ayurveda doctors. Generally they treat with non-steroidal anti-inflammatory drugs. So what is the take-home message? When do they suspect and refer to the rheumatologist? Like maybe from orthopedician or a general practitioner, when should they refer to a rheumatologist?
Yes. So if it is a classic autoimmune disease, yeah, they can refer to a rheumatologist for one opinion to see what is there, and then.
No, classic autoimmune disease means general practitioners should not.
No sir, classic rheumatoid arthritis, which is with the usual classic typical deformity and all. Just refer for evaluation and then you can manage it mostly. If there is a patient who is not responding at your third visit, then I think it is time to refer. If the patient has got more than one extra joint manifestation, then I think the patient should be referred. So I think these are some of the scenarios which we commonly come across. That patient has been going to the same practitioner for about 2-3 years, never had a response, but never referred also. So that is the commonest scenario that we see. So if somebody is refractory, you think it is refractory, we need to step up treatment. Before that, it's better to take it.
Because some of the patients here in the rural belt, they have been told some food intake restrictions and although they put non-steroidal and food, especially food they advise general practitioners. So these things happen and they come to the rheumatologist very late. Then they go to orthopedic surgeon. From orthopedic surgeon will also treat, partly treat, then we may refer to the rheumatologist. This is the common
Yes.
scenario I have.
Yes, this is the common pathway, sir. True. And especially if there is overemphasis on food and underemphasis on treating. So this is what the patient takes home at least. Patient knows that you should not eat kaal tinbardante, musar tinbardante, alugande tinbardante, but still joint pain is not going. Patient is suffering, has left out all these things. So nutritionally also patient is poor, no. Inflammation wise patient is rich. So I think that is a gap in the access we have in this part of the country. That will eventually improve.
Dr. Chengappa, I have. See, you told about diet, right? What diet we should advise for patient with rheumatoid arthritis? No diet. They can
Only
have.
if, yes, they can have everything. Only if they have comorbidities, you manage that. So have anything does not mean that you overeat.
No, because many times you get the patient that I had yesterday, I had chicken. Now
Because that is the common belief that is sitting inside the head.
Okay.
Everybody thinks that, you ask anybody, even before they have a flare, they know that it is going to cause of it.
But that's what they tell. You told Carl, the sprouts and all, if they eat, no, they come with exaggerate pain.
That is because it is the condition is poorly managed.
Okay.
Yeah. If you have adequate immunomodulation and you have reached the goal of treatment, they should not flare.
Okay. One more thing, this post-viral arthralgia, can you elaborate about that? Because we are getting patients, they have viral fever.
Yes.
After the 3 weeks, 4 weeks, they will get multiple joint pains, but RF factor anti-CCP will be negative. How to treat this patient? How to manage them?
Is there I think there is a session.
No, there is no session.
So
manage.
post-viral arthralgia, if it is early, within 3 weeks, we say just give painkillers. The rationale being the infectious episode might not be completely cleared. So you give steroids and it is going to further get prolonged. And there is some evidence to say that if you give steroids upfront, the whole process is also going to get prolonged. So only NSAIDs, full dose NSAIDs. Then over 1 month, if the patient has ongoing thing, you can add either an injectable steroid once or give low dose oral steroids. In 15 days, if it is not controlled, you can add on hydroxychloroquine. After that, you just treat like rheumatoid arthritis.
Sir, regarding the post-viral arthritis, can you elaborate on chikungunya, post-viral chikungunya? How does it differentiating from treating other post-viral arthritis?
Vikram sir is the champion there. So chikungunya is typical in the sense that it has some chronicity chances. Whereas the post-dengue does not have so much of chronicity. So that's what I was telling. If chikungunya arthritis,
Severity wise, chikungunya tends to be, once they come to you, they will not come to you again.
Yeah.
Because that is one is the severity.
So combination, if it is, if you think the patient has crossed the infective episode, maybe 3 weeks or further, I usually give a deposteroid at that time and leave. So 60% of the patients do well with that. Others come back with another flare, then we start treating it like a rheumatoid arthritis.
It might last up to 1 year.
Yes, it might last.
So more chances that you don't meet that patient again. So another one is regarding acute flare of gout among the alcoholics. Any particular thing like this much of beer or this much of whiskey or percentage of alcohol which can flare?
So beer will definitely cause a flare because of the increased amount of purine in it. There is no this much amount, because what you must understand is gout is happening because of a mismatch between production and excretion. Now we don't know what is that mismatch in that particular patient. So the patient will know himself, and I think over time, as the uric acid builds up, I think even a little amount will cause flares. So we really don't know what is the threshold.
I think we are stepping into the next father of rheumatology, I would say. He made rheumatology easy. I listened to him. 25 years now, since then. I'm hearing Dr. Chengappa, making it more simpler. I think that's what CME is all about. I think we should have more of them. I thank Dr. Lokesh for the co-chair people. Thank you very much.
Token of appreciation to our speaker. Clinical lens. We are delighted to invite Dr. Prakruthi Jahadev, consultant rheumatologist, Narayana Multi-Speciality Hospital, Mysore, to speak on joint pain in children, a rheumatologist's perspective. We request the chairperson to please invite and introduce our speaker.
Specialty Hospital, Mysore, various levels, and she was a associate consultant rheumatologist at the Department of General Medicine at the NOI Medical College, Bangalore, and she has also worked in Tata Memorial Hospital, Mumbai for a few years, and she did her graduations from Mysore Medical College, Mysore, and MD Internal Medicine from Chengappa Institute of Medical Sciences, Bangalore, and she has also done DNP Internal Medicine, and she is a basic life support and advanced clinic life support provider as well as instructors, and she is a member of American Heart Associations, and she has done fellowship in clinical immunology and rheumatology, Chandler Rheumatology and Immunology Center and Research. So over to you, ma'am.
Thank you, sir. Thank you for the kind introduction. Good morning, everyone. It's an honor to be here, and thank you for the opportunity. And more so, an honor to be talking while Dr. Sydney is chairing the session, whom I consider one of my inspirations. Like he rightly pointed out, talking after Dr. Chengappa is like coming to bat after Sachin Tendulkar got out. A good time. Anyway, two disclaimers. I'm not a pediatrician, and this is my perspective as a rheumatologist. And second, pediatrics is not general medicine in miniature. It is totally different, especially so pediatric rheumatology. Why, you will be seeing in the next 20 minutes. So, when a child comes to you with joint pains, some of the obvious causes that you will see in the OPD is, one, it can be an infection or trauma, malignancy, which is not so common in adults, but when a child is coming to you with joint pain, malignancy is very much a possibility in a child, and it can be other systemic diseases. But most often, juvenile idiopathic arthritis tend to be hidden, and you need to be very aware of it for you to identify it. Like we know, the eyes do not see what the mind does not know. So let us go through the slides to understand what juvenile idiopathic arthritis is and how you should identify. Step 1, like we have already learned what is inflammatory and non-inflammatory, the same applies here. You have to identify if the child presenting to you is having an inflammatory joint pain or not. For all practical purposes, I am starting my presentation assuming that the child is having a joint pain itself. So we are not talking about anything periarticular, muscular, neurological, etc. So the inflammatory point is the same. There will be morning stiffness, improves with movement or sometimes with a hot bath. There is persistent swelling. There may be systemic features. Now this child may not be able to communicate the same with you. So most of your history comes from the parents. Most often very anxious parents. So you need to be very observant. Also, it puts the parent's skill of observation of their own child's activities into test to identify whether it is inflammatory. Most often JIA children are like 5-6 year old, and parents might come to you telling the child does not like to go to school. So early in the morning he is always cranky, does not want to go, is always crying. By afternoon he is very happy and playing when we don't send him to school. So this could be a presentation. Sometimes they do present with very obvious swelling and pain, but most often it is either the child used to eat in the right hand, but of late he is trying to pick stuff up or plays more with the left hand. These are observations that the parents come to you with. So identify if it is inflammatory, especially if there is morning stiffness. They are very cranky and crying in the morning, get better by noon. Otherwise, it can be mechanical, it worsens with activity and more so in the night. The usual growing pains that we label most children with is something that happens during evening, which tends to improve with massage. But not so in the case of inflammatory arthritis. You do any kind of massage or pressing, the inflammatory arthritis always flares up and the child is going to scream in pain. So the key differentiator is stiffness that improves with movement is the hallmark of inflammation. The same as for the adults. Now step 2 in children is directly into ruling out the mimics. Here the mimics are, one is infection, it can be septic arthritis, or it can be if it is single joint and acute, or it can be other infections like Lyme disease if there is an endemic history, osteomyelitis. Sometimes tuberculosis can also present as monoarticular pain in children as well. Then comes malignancy. Have a very astute radar for malignancy, because most of the hematological malignancies and lymphomas, they usually present with joint pain. And if the pain is very disproportionate and child has night pains, as in wakes up in the middle of the night screaming with pain, and there is disturbed sleep, if there is any kind of cytopenias in terms of evaluation, make sure that you're ruling out malignancy first. There may be trauma, or in cases of bleeding diathesis, there can be hemarthrosis. All of these, plus if it is, we discussed about the associated features in arthritis, right? The step 4. If any of that is present, then all these go into the category of CTDs, that is systemic involvement. If on evaluation you identify that there is just a raised LDH with reduced WBC counts, or if there is thrombocytopenia, make sure that you are ruling out leukemia before labeling the child as juvenile idiopathic arthritis. So with these 2 steps, you need to have 3 criteria fulfilled to label the child as JIA. 1, the duration should be more than 6 weeks, and the child should usually, the onset of symptoms should be less than 16 years, and all other associated possibilities for joint pain, like the one which we discussed, infection and inflammation with systemic features, malignancy and trauma, has to be ruled out. JIA is a diagnosis of exclusion. Also, it is not a single disease. It's an umbrella term that is used for a group of arthritis that I will be discussing in future slides. So the first filter, you have identified there is a child with joint pain. You have made sure that it is not mechanical or benign, and it is inflammatory. You have also looked for the red flags, some kind of a disability. So moving on. Now, International League Against Rheumatism has classified or identified certain criteria for the child to be labeled as JIA. Why it is important is it homogenizes the population into the classification, and it is easy for you to tell whether the child is going to progress into an adult with rheumatological disorders, or will it be better, and how long should they take treatment. All of that depends on which subtype the child goes into. Each of these subtypes are mutually exclusive, and most often the child can move into one subtype to the other. So as soon as you have diagnosed, at diagnosis you have to go through the classification criteria and identify if the child belongs to one particular category. A child who presents as oligoarthritis eventually might become polyarthritis. So you are going to apply these criteria at each follow-up, and it tells us about the progression of the subtypes as well. Do not just classify into oligoarthritis, JIA at the diagnosis and then leave it at that. Follow-up is far more important than just diagnosing the child. So the types that come under juvenile idiopathic arthritis are oligoarthritis. It can be persistent or extended. By that I mean oligo is less than 4 joints. If it has remained in less than 4 joints for more than 6 months and eventually, it is called persistent. If it has included more number of joints, like more than 4 joints, in the next 6 months it becomes oligoarticular extended. And it can be polyarticular at presentation itself if it is rheumatoid factor positive or negative. Again, there are 2 subtypes. And then there is psoriatic arthritis, enthesitis related arthritis, as well as arthritis with systemic features. If there is a child who does not fit into, each of these have their own exclusion-inclusion criteria. I'm not going to dwell more into detail. If a child does not fit into any or fits into more than 2 categories, it is usually termed as undifferentiated arthritis. So you're classifying it based on the clinical signs and symptoms in the first 6 months, but it can turn out to be a different subtype later on. Keep an eye out for it. So a word about the red flags. When you should worry and immediately refer and do more is if there is bone pain, if it is severe, interrupting sleep, and if it is not related to movement and present all the time, it could be malignancy. Always rule out. It is always better to be safe than sorry when it comes to children. Systemic symptoms, if there is weight loss, night sweats, anorexia, again malignancy or a chronic infection. If it is a very hard joint, as in it presented with sudden onset, single, severely erythematous joint, then it could be septic arthritis. Like I said, a medical emergency. So with all that, we have concluded or established that age should be less than 16 years, duration of symptoms should be more than 6 weeks, and you should have excluded other causes like infection, malignancy and trauma. Then you would classify the patient or the child as GIA. And sometimes if it is oligoarthritis, the investigation does not usually support. ESR-CRP may not be very, very high if it's just one joint. Okay, if you have seen one joint and inflammatory markers are way off the chart, then reconsider your diagnosis. Moving on to subtypes, I'm just going to mention the classical features of each subtype. So oligoarthritis, this is something that I want you to take away 1 point from this talk is if you find a child with oligoarthritis, always do an ANA. If they are positive, they have very high risk for developing uveitis. The uveitis that appears here in children is something very different from adults. They're usually asymptomatic and the child will not be able to tell you that it is seen differently, and the eye will not appear red. It looks white, asymptomatic. Unless you are screening for it, it is very difficult to identify. But if you don't identify and treat, the child could become blind. So if you find a child with oligoarthritis, make sure that you're screening. Whether or not you're referring to a rheumatologist, please refer to an ophthalmologist. Get the eye screen with slit lamp examination at least once in 3 months up until they reach 10 years of age. So the joints will be less than 4 in number in the first 6 months. They can be asymmetric, usually affects the lower limb joints, ankles or knees. There is early onset, as in before 6 years of age. They can be ANA positive. The invisible risk here is they develop anterior uveitis. So it is mandatory to do an ophthalmological screening every 3 months. Moving on to polyarthritis, if more than 5 joints are involved, you will call it as polyarthritis, and it could be rheumatoid factor positive or negative. Again, if rheumatoid factor is positive, you have to redo the test after 3 months again to confirm that it is persistently positive, because some of the infections in children might trigger rheumatoid factor to become positive, which might later on be negative. Or you could do anti-CCP to see that it is confirmedly rheumatoid arthritis. The polyarticular rheumatoid factor positive variety is something which mimics adult rheumatoid arthritis. The rest of them are quite different. If it is rheumatoid factor negative, it sometimes resembles the early onset oligoarthritis, has variable outcome, may be asymmetric involvement. On the other hand, there will be erosive changes, symmetric arthritis, just like adults. 2 varieties, enthesitis related arthritis as well as psoriatic arthritis. They are the spondylophenotypes. Here in enthesitis related arthritis, boys more than 6 years, they tend to be HLA-B27 positive, and usually lower limb joints are involved with enthesitis. Sir already mentioned what an enthesis is. Psoriatic arthritis, always hunt for psoriatic patches, no matter what, until you're sure that there is no psoriatic patch. And if you have a child with dactylitis, keep in mind that hematological disorders like sickle cell anemia can also present as dactylitis. So if you're not finding psoriatic arthritis, do a blood workup, confirm that the patient or child does not have sickle cell anemia as well. Ask for a family history. Usually, if the psoriatic patch is not visible right now and the child is presenting just with arthritis, they may develop eventually. A family history is quite significant when it comes to psoriatic arthritis. Moving on to systemic juvenile idiopathic arthritis. This is the one with the cytokine storm. It has a clinical triad of quotidian fever, very high fevers touching baseline every day, and evanescent rash, which is salmon pink and appears with fever. This rash is peculiar that it shows dermographism, as in if there is any kind of trauma to the skin, it appears over there. Sometimes, like if you're monitoring the child with BP cuff regularly, every time the BP cuff inflates and goes off, the rash can appear over there. Then there may be arthritis. Sometimes the systemic JIA child does not present with arthritis itself. There may be arthralgia. Again, there are 3 different types of classification criteria with major, minor, etc. But just remember these 3 things. If there is a quotidian fever, rash, arthritis, suspect systemic JIA. And why this is important is, this could lead into macrophage activation syndrome, which is a life-threatening coagulopathy. Sometimes MAS is the first presentation of a systemic JIA child. So be very wary. And like I already mentioned, if there is inflammation, you expect the ESR and CRP to be high, platelets to be high. If the child is looking sick but the ESR is coming down, total count is normal, platelet count is normal, then you should always consider this as a possibility. Don't be happy that the child is probably, usually these kind of children are admitted in the ward, you've provided with multiple courses of antibiotics, and just because the lab reports say it is normal and the child does not look well, think again, it could be MAS. So the clinical algorithm goes, suspect, have a pattern recognition, exclude the mimics, investigate, classify into particular subtype, and then you will manage or refer for further management. A word about laboratory investigations. Treat the child, not the lab investigations, more than adults. This holds good for pediatrics, quite a bit. So here I told oligoarthritis, do ANA. Should you look further with ANA profile and what kind of systemic CTD is present? No. In oligoarthritis, we are doing ANA just to see whether they are at a high risk for uveitis or not. The ANA, if it is positive, screen for uveitis diligently. If not, you move on. ANA negative might also have uveitis, but the risk is not that high. Rheumatoid factor, do it twice, 3 months apart. And negative rheumatoid factor does not mean that the child does not have JIA. Inflammatory markers can be normal. Don't rely solely on the inflammatory markers. If there is very obvious inflammation with ESR, CRP, platelets all being high, that's a good sign. You can treat the child with steroids and anti-inflammatory and immunomodulators and the child will be better. If the child looks sick but the investigations are normal, that's when you will be super careful. So, when to refer? If there is a joint swelling and pain which has persisted for more than 6 weeks after the treatment has begun, do send across to a rheumatologist and take an opinion. If morning stiffness has remained persistent for more than 15 minutes after the treatment has begun, and if there is a regression of a motor milestone, the child was walking but now prefers to crawl, or there is change in dexterity, then definitely take a referral. If there is asymmetry in limb length or muscle bulk which is obviously visible, do refer. Most importantly, if there is a systemic feature like fever, rash, or like I already told, oligoarthritis, ophthalmology referral. So how do we treat? Treatment is quite simple when it comes to JIA. Not all JIA will eventually require DMRs. So when a child is presenting to you with joint pain and you have classified as JIA, first you will treat with a good dose of NSAID. Naproxen is usually the choice. Like I already mentioned, pediatrics is not miniature internal medicine. So don't say 250 mg, half 125 g. It is 5 milligrams per kg per dose. You can repeat it twice. Can go up to 7.5 milligrams per kg. Give a good dose of NSAID before saying that it is not responsive. In oligoarthritis, if it is just 2 joints or 1 joint, you would rather prefer to provide an intra-articular steroid with triamcinolone with 1 milligram per kg body weight of steroid. That usually takes care of the inflammation for about 3 months, roughly about 6 to 8 weeks at least. If the child again has inflammation in the same joint and you have repeated the intra-articular steroid as well, that's when you will try to think of adding disease-modifying agents. The most anchor drug for disease-modifying agents in children is methotrexate. It is very easy. If the child is not able to take tablet, we have subcutaneous injections available. So you're pretty sure that you have provided the injection. With oral medication, they tend to have, they are quite worried about the growth and development and nutrition. So if GI side effects are a concern, switch to subcutaneous injections. With all these, if you are not able to get it under control, then, or if the patient has required like more than 3 intra-articular injections in a year, then you would think of escalating to biologics. The biologic options are anti-TNF, anti-IL-1 and IL-6. Of late, the tofacitinib has also been approved for the use in GIA. The order in which the treatment has evolved is initially it was just symptomatic control. Later we added DMRs like methotrexate. Then one after the other biologics were approved like etanercept and adalimumab, anakinra, canakinumab. And of late in 2020, tofacitinib was approved. Now we have biosimilars available for tofacitinib. It's very easily available at much cheaper rate than before. And children tend to respond very well if they are not very keen on injections. Again, IL-6, IL-1 are quite expensive compared to tofacitinib. Most importantly, if there is an uncontrolled disease, a child is going to have a totally different life than when an adult does not have a controlled disease. The child will not be able to tell you. You need to identify. You are responsible for the child's diagnosis, treatment, as well as how the rest of the life will pan out. So, rule out chronic anterior uveitis. Make sure that there are no growth disturbances. Very diligently look for it. And prevent flexion contractures from occurring. If the joint is persistently in flexion, have a word with the family about physical therapy, how to help the child learn to walk better, regular exercises. Sometimes even if there is inflammation of the TMJ, it can lead to facial deformation in the form of microgramnia as well. So JIA needs to be controlled very strictly. So follow-up happens in 3 categories. One with the rheumatology team, and then ophthalmology team to rule out uveitis, and growth. Always monitor the growth, height as well as weight, and monitor for steroid impacts as well. With that said, we'll go to a case. This is a case-oriented approach. So till now, you've heard about whatever JI is and its subclassification. So we have a 4-year-old girl presenting to you with history of pain in both knees for the past 4 months. So I have already answered one question that it is chronic. Next. The child had a minor fall while playing according to her mother, and the joint symptoms started after that. The mother informs that the child has been crying due to pain in the knees. And she has noted that she walks like an old woman in the morning. What does that mean? Early morning stiffness is present. So is it inflammatory? Yes, we have answered 2 questions. Child has not been walking and running like before, prefers to sit and play. There are no history of fever, rashes or night pains. No associated features. So for children, there is always an additional step in history. Talk about their general habits as well as developmental milestones. Whether all developmental milestones have reached appropriately or if there has been any regression. So what is this now? Chronic, symmetric, oligo, inflammatory arthritis without any clinical features. Correct? So on examination, she's a well child, interactive. In children, we do musculoskeletal examination a little differently. It is called as PGAS, Pediatric Gait, Arms, Legs and Spine. Here, there are screening questions, whether you have pain or not, and whether you find it difficult to dress yourself or not, whether it is difficult to climb up and down the stairs or not. This much a child will be able to answer. So if it is yes for any of that, then you will look for the gait, then you ask the child to walk on the heels, then walk on the tiptoes. It takes hardly 3 minutes, so you have to do this every time the child comes to you. And arms, spread out the hand, turn it upside down, make a fist and touch each finger with the thumb. If the child is able to do this comfortably, then there is no musculoskeletal involvement at that point. But if the child is limping or on what side the child is preferring, based on that you can identify if there is synovitis or not. So this child had synovitis of both knee joints with restriction of full range of extension. Along with musculoskeletal examination, we always want to do systemic examination, particularly in children. Look for a cardiac murmur if it is there or not, and abdominal examination to rule out hepatosplenomegaly, respiratory examination, as well as lymphadenopathy. Okay, so you have the examination findings. What do you want to do next? Investigate. So these are the investigations. The routine things are fairly normal except for ESR being 38, rheumatoid factor negative, anti-CCP negative, but the child has a positive ANA. Do you want to do an ANA profile? No. What class subtype does this child belong to now? Oligoarthritis with ANA. So we already have our diagnosis. What is your treatment plan? Okay, one, he is referring to ophthalmology. Very good. Next. You can provide NSAIDs and also try to provide intra-articular steroids to both the knees. If the child comes back to you with pain and swelling again in the knee joints, you can repeat one more injection. Or if the child now next comes to you within 3 months with polyarticular involvement, you are upfront starting disease modifying agents, which is methotrexate. In children, remember one thing, you are treating the child, not the anxious parent in the room. Also, be very mindful about what you are discussing in front of the child. How you interact with the child, how the parents behave after your interaction or the consultation matters a lot. Not just to the physical development, but also for the emotional and psychosocial development of the child. You could wreck a child's life just by the way you're behaving when the child is coming to you. Be very, very mindful of that. With that said, thank you for listening to me patiently. These are my references. I've used notebook for my infographics. I truly believe in this. Children are the best thing that have happened to the world, and it is our responsibility as adults to make this world a safe place for them. Thank you. I'll be happy to do questions.
That is a confident looking Dr. Prakruthi delivering their lecture. Though it is not a subject of interest, may I do that? She always fascinated me because she was very objective, very focused. I told her to linger on in our college with January. Because she was really bright, very focused. People should be like her. The way of, the whole presentation was so good. I think she deserves a round of applause. With that, maybe there may be one or two questions because we are running short of time. Otherwise, we may have to extend for tomorrow also. If you are busy, we can do that as well. But I think we have to celebrate the Republic Day as well. So, if there are any questions, we can. She will be able to address them. If not, anything? I think. Thank you very much, Dr. Prakruthi.
Thank you so much.
Nice.
Thank you, everyone.
And close the session.
Excellent session. We truly appreciate your time and expertise. Now we request Dr. Lokesh AJ, Dean and Director Koims, Dr. Abhinandan, RMO Koims, and chairpersons to please present our speaker with a token of appreciation. clinicians often guide or misguide a diagnosis. To throw light on interpreting lab data effectively, we have Dr. Sangeetha K N, consultant rheumatologist, Manipal Hospital, Mysuru. Chairpersons for this session are Dr. Prasad B N, Associate Professor, Department of Rheumatology, JSS Academy of Higher Education and Research, Dr. Sudhendra Rao, Professor and Head, Department of Medicine, KS Hegde Medical Academy, Bangalore, Dr. Mukhya Prana Prabhu, Professor and Head, KMC, Manipal. We now request the chairpersons to please invite and introduce our speaker.
In a case of rheumatological disease, we have got Dr. Sangeetha, who is DNB General Medicine and Fellowship in Clinical Immunology. She is presently working as Assistant Professor in Adi Chichagi Institute of Medical Sciences. Her interests are SLE, inflammatory myositis and vasculitis, and she will give us insights into when to ask, looking at the labs.
To be a part of the CME in Madikeri, there are two important reasons for happiness to be in Madikeri. So very first thing is, I'm a big fan of Vishnuvardhan, and Madikeri Sipari song you all will be knowing, evergreen, and that is one thing. The other thing is, my junior works here in Kodagu Institute of Medical Sciences. She's Priyadarshini Monnappa in Department of Pathology. So just hoping to see her here. Anyway, without taking much time, let us start off my talk. I'll be talking about analyzing the lab reports in a patient with rheumatological disease. So one disclaimer, I'm not a pathologist, I'm not a microbiologist here. I will be talking in the perspective of a rheumatologist. I just start off my presentation with gratitude to my teachers and parents and Almighty, my patients who've been a constant source of knowledge to us, my KRA family, Kodagu Institute of Medical Sciences, and organizers of today's CME and IPCA. Now, what is autoimmunity? It is a condition in which the immune system mistakenly attacks host tissues, normal healthy tissues, and start destroying it. So, what are the causes of autoimmunity? So, there is no one cause that can be pointed at when you come across an autoimmune disease. It is postulated that it could be environmental factors, it could be hormones like estrogen, it could be smoking, genetics. There are various causes like this, along with infections, especially the viral infections that are known to be responsible for many autoimmune diseases. Fortunately or unfortunately, patients with rheumatological diseases, we can arrive at almost 90% of the diagnosis by good clinical history and good clinical examination. So the lab investigations play a very small role, but a vital role, I must tell. Now, coming to the tests, I can broadly categorize them as lab investigations and radiological investigations. Among the lab investigations, I will be mainly talking about the serological tests, and I will not be touching upon other investigative modalities for want of time. Having said that, this is one representation stating that a detailed clinical history and examination is close to 90% we are accurate in forming a diagnosis of a rheumatological disease, and lab investigations give us 5% of the support that is necessary to make an accurate diagnosis. It is also important for monitoring the disease activity, looking for complications, treating the patient, modifying medications, etc. Now, last two speakers, Dr. Chengappa and Prakruthi, have already spoken very much in detail about inflammatory arthritis. So this slide is telling the spectrum of symptomatology in patients with rheumatological disease. So rheumatology means not arthritis. However, joint pain is one of the common feature in most of the autoimmune diseases in association with other organ system involvement. Okay, like for example, it can also affect the musculocutaneous in the form of muscle weakness. It can affect mucocutaneous system or the skin and oral mucosa. It can cause alopecia, it can cause blistering lesions, photosensitive lesions, vasculitic lesions. Sometimes people come to us with pulselessness. It can cause renal impairment, recurrent pregnancy losses. It can present as serositis, so on and so forth. We should not forget the neuropsychiatric involvement that patients can have in patients with autoimmune rheumatic diseases. Now, this slide is just a pictorial representation of whatever I have told. So the very first slide this picture. So if you look at it, it is very kind of very obvious that this patient has inflammatory polyarthritis. Just with one hand, a picture of one hand, you can come to a conclusion that it is inflammatory polyarthritis. So likewise, there is a calcinosis here. We have mechanics hands. I don't know how clear it is to the audience here. There is a vasculitic lesions, blistering lesions, scleritis over here, Raynaud's, skin tightening. I could not actually make this photo a bit enlarged to make the salt pepper pigmentation much obvious in this picture. So also here in this patient you can make out the malar rash. This is calcinosis in patient with scleroderma. So all of these manifestations can have one thing in common, that is joint pain, and more specifically inflammatory joint pain. I will not go into the details of it because Dr. Chengappa and Prakruthi have already dealt with this inflammatory joint pain very much in detail. Coming to objectives of investigations in autoimmune rheumatic disease, one is to confirm the inflammatory nature of the disease, to form an accurate diagnosis for associated conditions, like already Dr. Chengappa spoke in one of the cases. He spoke about one patient who had rheumatoid arthritis with secondary Sjogren's with interstitial lung disease. So to make a diagnosis of secondary Sjogren's and ILD, we will need obviously chest X-ray, HRCT thorax, minor salivary gland biopsy, Schirmer's test. Not all of them are really required though, right? Next, to monitor response to therapy or side effects. So I'm not going into many cases for want of time. So this is just one slide I wanted to make a mention because it is case-based, right? So this slide says that this is a picture of a 32-year-old female with history suggestive of inflammatory polyarthritis with early morning stiffness, so and so for 3 months. And the joints involved are also mentioned with no history of fever. This is all information that you are getting from any person. Supposing this patient does not have any other organ system involvement like cutaneous involvement, lacrimal gland or salivary gland involvement, neurological involvement. Supposing this patient has symptoms only confined to these joints. So now you already know that this patient has inflammatory polyarthritis. Any of these conditions without can give rise to this inflammatory polyarthritis. If you are not provided complete history with respect to if there are any skin lesions or if there is alopecia in this particular patient, if there are erythema nodosum nodules, you will not be able to make an accurate diagnosis in this particular patient because any of these can have a similar picture. So this is the big list of investigations that we come across in our routine clinical practice. Actually speaking, just the CBC, ESR, CRP, LFT and RFT are more than enough to start medications for this particular patient, right? However, there are few investigations like rheumatoid factor and a few other investigations. I will talk about it in the next few slides. So all of them are not required at once is what I'm trying to say. So let us have a systematic approach to any given patient. So first we need to ascertain the inflammatory nature of arthritis. For that you don't need everything else, alright? We get a battery of investigations in which patient has multiple files having the same report repeated, same test being repeated, though it is negative once or positive once it has been repeated. There are lots of things happening like this. So we need to know when to repeat, whether it is really necessary, why should we repeat if so, so on and so forth. Right? So these in everything under the sun is not required. Alright, so when patients come to a rheumatologist, they come with a heaviness in their head. Oh my God, they are going to ask for a very big list of investigations. That is not so. So first we need to put them at ease, saying that no, with basic investigations, we can come to a conclusion, we can start medications. However, to have an accurate diagnosis, we will need few other investigations, and it will be asked only if it is necessary. So you can know what is necessary only if you have taken a detailed clinical history and done a very good clinical examination. Now, clinically, how do you ascertain the inflammatory nature of the disease? You already know, right? I will only talk about the lab modalities, that is to look for the inflammatory markers. So often it is the ESR and CRP that we use in clinical practice for establishing the inflammatory nature of the disease. However, both of them are kind of non-specific, meaning both of them can be elevated in various other conditions, right? And there are various factors that can give rise to false positive and false negative values. So mainly only in the background history of inflammatory arthritis, whether it is monoarthritis, oligo or polyarthritis, with this particular background history, if ESR and CRP are elevated, it will potentiate your diagnosis. It will only add on to your diagnosis, right? So there are other various non-inflammatory conditions like infection, malignancy, which you will have to look for. Especially when ESR is elevated more than 100, there are few diseases that you have to keep in mind and look for it specifically. What are the other acute phase reactants that are checked? So one is ferritin, many times hypertriglyceridemia, thrombocytosis, hypoalbuminemia, so on and so forth. Right? Coming to ESR, it is a composite acute phase protein. Like it is an indirect measure of inflammation because it is dependent upon the fibrinogen that is secreted. Right? It is influenced by various factors, like for example the female gender, pregnancy, whether a patient is obese, whether he has come after fasting, exercise, after smoking. There are various factors that we have to consider when we encounter a patient with a raised ESR report, right? And every lab gives a range that is 0 to 20. So if it is 25, patients are alarmed. Why is my ESR so high? So you have to put that patient at ease. Many times it is elevated in pregnancy, and there has to be something called as a cutoff for the higher level or the maximum level of ESR. For males, it is age divided by 2, and for females, it is age plus 10 divided by 2. After having excluded various other factors which could influence, like these: hypergammaglobulinemia, elderly individuals, anemia, pregnancy, heparinized blood, hypoalbuminemia, etc., along with other conditions like infection, malignancy, etc. Alright, false reduction is also seen. Alright, so when you should, that is the reason Dr. Prakruthi also said you should treat the patient and not the investigation. So first it is a clinical acumen, clinical judgment that has to lead us to treat the patient. Alright, so you could be dealing with a patient with hepatic failure. Right, so in this particular patient ESR will not go up. So you should not come to a conclusion that there is no inflammation, so you are fine, alright. No. Alright, so it is a clinical judgment that becomes very, very important. Coming to CRP, relatively when compared to ESR, this is kind of a direct measure of inflammation. It increases, it is relatively much better when compared to ESR. It increases soon and comes back to normal soon. Once the stimulus is withdrawn, it increases within 4 to 6 hours and rises till the trigger is reduced, peaks in 36 to 48 hours and reduces within a week once the stimulus is withdrawn. Alright, so these are the different variables that can influence the rise in ESR and CRP. So that is gender, age, pregnancy, smoking, so on and so forth. But CRP is relatively not affected by most of these factors. Now, coming to confirmation of the diagnosis. Now you know that you have ascertained the inflammatory nature of the disease. Confirmation of diagnosis. There are various other tests, that is basic investigations like complete blood count, liver function test. These, I want you all to know a bit about this. Okay, and rheumatoid factor anti-CCP. These are the 4 very important ones that I will be going much in detail. When we start analyzing the complete blood count, all the 3 cell lines have to be considered. So one is RBCs, WBCs and platelets. So when you look at analyzing the hemoglobin, you can come across most of the patients have anemia, patients with autoimmune rheumatic diseases. Most of them have anemia and often it is normocytic normochromic anemia. So sometimes it can be drug induced or nutritional iron deficiency causing microcytic hypochromic anemia. Very rarely we can come across macrocytic anemia as well, and in patients with lupus specifically, if there is hemolysis, we can have hemolytic. We can see a picture with hemolytic anemia. So also when it comes to WBC count, often when there is an inflammatory arthritis or any inflammatory rheumatic disease, they can have leukocytosis, usually a mild leukocytosis. Leukocytopenia also can be seen in patients with lupus. Sometimes it can be drug induced, like for example methotrexate overdose can cause leukocytopenia. There are few other medications which can cause leukocytopenia that we have to keep in mind. Otherwise, it is very difficult for the lab staff or the pathologist or the microbiologist to come to a conclusion as to what exactly it is. So that is the reason they write to correlate clinically. So they are also dependent upon the clinical history, right? So if we do not give them the adequate history, they also will be confused what to give, right? In patients with vasculitis, especially with a background history of asthma, allergy, in whom there is an ENT involvement, who is also having hematuria or proteinuria. Sometimes in patients with suspected EGPA, eosinophilic granulomatosis with polyangiitis, we can expect eosinophilia. Coming to platelet count, thrombocytosis is very often seen in patients with inflammatory arthritis, and thrombocytopenia also can be seen in patients with ITP, especially when it is associated with lupus. Alright. Also, it again can be drug induced. So, if there is doubt in any of the above investigations, you can go ahead and look for the peripheral smear and bone marrow examination. Urine routine also becomes very important. You need to know whether this particular patient has active urine sediments or not. If there is proteinuria, if at all if there is proteinuria, whether it is because of the connective tissue disease or the underlying other comorbid conditions like diabetes or any other comorbid condition which could be affecting the kidney. So that discretion we need to have. Alright, and CAS in the urine are also very important, especially in patients with suspected lupus nephritis. Thyroid function test, why is it important here? Yes, autoimmune diseases, most of them are associated with thyroid dysfunction as well, especially autoimmune hypothyroidism. So that is the reason almost all of our patients in rheumatology clinics, all of them almost will have a baseline thyroid tested. Coming to liver function test. So here it is analyzing the bilirubin levels, transaminases and hypoalbuminemia. So bilirubin often it is normal, especially except in patients with hemolytic anemias. Transaminases, if they are elevated, you need to know whether it is real hepatic dysfunction or is it because of drugs that is administered to the patient. Their SGOT, SGPT can go up. So till how long can you wait? So sometimes it is said that we can wait if the SGOT, SGPT levels are less than 3 times upper limit of normal. Only in these cases, we generally tend to repeat the test in a week's time or 10 days time to make sure that it is not rising further. Generally, it reverts back to normal. If it is persistently elevated or increasing, we need to address to that particular condition. Sometimes, if there is a background history of muscle weakness, a patient having difficulty to raise his or her hands above shoulders, difficulty to raise from sitting or squatting position, it could point at presence of proximal myopathy in that particular patient. So this becomes very, very important. Hypoalbuminemia, actually it is one of the acute phase reactants. The other thing is in patients with lupus nephritis, because of proteinuria, they can have hypoalbuminemia. Coming to rheumatoid factor. Now, so rheumatoid factor is one of the most commonly ordered investigations. So we need to know who we should order rheumatoid factor, how to analyze it, whether it is really relevant or not. If rheumatoid factor is positive, is this patient having rheumatoid arthritis or not? So I'm not going into the details about what is rheumatoid factor and things like that and the different methods of testing it. Alright. All that we should know practically, that is what I'm going to talk about now. So it is positive in as less as 60% of cases with early rheumatoid arthritis. However, as the disease advances, the positivity can go up to 80%. So for all practical purposes, 20% of patients with rheumatoid arthritis can have rheumatoid factor negativity. Having said that, it is also important for us to know that it is positive in normal healthy individuals, whether a patient has rheumatoid arthritis or not. If a rheumatoid factor is ordered and if it comes positive, what will you do next? How will you convince the patient? Patient may be smoking, or they could be having a family history of rheumatoid arthritis, because of which he also is having rheumatoid factor positivity. That does not make him a patient of rheumatoid arthritis, right? So the rheumatoid factor positivity increases with advanced age. So if we consider rheumatoid factor positivity as rheumatoid arthritis, we will be doing something very wrong. So we will be unnecessarily treating almost 5% of normal healthy individuals with unnecessary drugs. So that is absolutely wrong. right? So it is a clinical judgment. We should not treat the investigation, we should treat the patient and the clinical condition, right? There are various other conditions in which rheumatoid factor is positive. So one is rheumatic or autoimmune rheumatic diseases or non-rheumatic diseases. So this slide tells us that it can be positive in infections. It can be viral infection, bacterial, parasitic infections. After chemotherapy, in patients with COPD, in smokers, this is kind of a big list in which rheumatoid factor can be positive. So don't jump to conclusion. Mere presence of rheumatoid factor does not indicate rheumatoid arthritis. So also at this point in time, I would also want to point, by asking for rheumatoid factor, please do not write RA. It is RF, it is rheumatoid factor, not RA factor, right? So that has to be mentioned. The other thing is clinical history has to be mentioned in every requisition. At least from now on, I want it to be a practice, right? So these are the different autoimmune rheumatic diseases which can have rheumatoid factor positivity. So what do we do if we get a patient with a report of rheumatoid factor positivity? Now we need to think whether it is really positive, relevant or not. Right now, at least you all will analyze. Anybody? Everybody? Nobody? Wake up. Okay. So coming to anti-CCP, again it is yet another antibody to antibody again, which when there is inflammation-induced apoptosis, there is deamination of arginine residues, and this is called citrullinated. Anti-CCP is an anti-citrullinated peptide antibody. So what is the significance of these two antibodies in a patient with rheumatoid arthritis? If these are positive, especially in high titer, if they are positive, these patients are known to have a severe erosive disease. They also are known to have extra-articular disease or extra-articular manifestations. They are known to respond to higher dose of the conventional medications or would require an add-on or a biologic for the disease control. So except for this, it does not carry a major role in diagnosing a patient with rheumatoid arthritis. So you should know how much is too much. You know the rheumatoid factor titers when it has to be considered very significantly positive. Do we have to repeat a rheumatoid factor or anti-CCP? No, it is not really required. Whether a patient with RF positivity or seropositive rheumatoid factor, if he comes with a negative report again, are you daring enough to stop the medications? No. Because this patient clinically has to be in remission. There are few criteria for us to taper down the medications or stop the medication or an add-on or hike up the medication. So it is only the clinical judgment, clinical discretion. So we don't have to keep repeating these investigations, alright? Importance of rheumatoid factor positivity or ACPA positivity in patients with RA, I just mentioned. Now, rheumatoid factor positive or negative, along with anti-CCP positive or negative, patient with rheumatoid arthritis has rheumatoid arthritis, whether you want it or not, whether you want to repeat the test or not. It is not going to change the medication. Coming to the next most commonly ordered investigation, that is anti-streptolysin or ASLO titer. So any patient with midfoot pain, thumb pain are also ordered ASLO titer. No, that is wrong. So it has to be, there has to be a clinical acumen which should direct you towards ordering ASLO, right? So Dr. Chengappa has already beautifully explained about what is rheumatic fever, when to suspect and things like that. So having said that, just like I told, rheumatoid factor positivity is not rheumatoid arthritis. Just like that, ASLO positivity does not mean rheumatic fever. As clear, as good as that. Now, this picture is showing that almost 50% of children harbor streptococci in their throat. So anybody with throat infection or skin infection can have ASLO positivity. Anti-streptolysin O. Out of that, 0.08% of them can develop rheumatic fever. So you know how significant, how small significance it carries, right? So you should have a clinical judgment first. Clinically, if you suspect, you are justified in ordering ASLO, otherwise not. Please do not order unless there is a strong clinical suspicion. Coming to ANA, here this actually will take a long time. I do not want to go into the details. So one thing is, it is anti-nuclear antibodies. Again, if there is a strong clinical suspicion along with inflammatory arthritis, if there is any other extraarticular involvement, please order for it. Otherwise, if there is a pregnant woman who has had a lot of pregnancy losses, you can order. If there is a malar rash, there are few other things. You know about lupus, you know about scleroderma, MCTD. If there is something off, only then, if you are suspecting an autoimmune rheumatic disease, only then please order ANA, not otherwise. So it can be tested by indirect immunofluorescence method and ELISA method, but the gold standard is indirect immunofluorescence method. And here what you should consider is the method used, the dilution used, pattern and intensity. So I'm not going into the details about the intensity and patterns of antinuclear antibodies for want of time. ANA is an entry criteria to make a diagnosis of SLE. Okay, there is a very small subset of patient with ANA negative lupus that let us not talk about right now. Alright, again that is a clinical judgment. If I keep telling every slide will have the same disclaimer, right? Now, so ANA is also diagnostic criteria in patients with MCTD and autoimmune hepatitis. If it is positive in significant titers, in significant dilutions and a specific pattern, you are supposed to go ahead and look for specific antibodies. Alright, so that is done by immunoblot method or ENA. These are the different patterns. I am not going into the details of the different patterns and how significant it is in making a clinical diagnosis. Alright. Again, ANA can be positive in autoimmune rheumatic diseases and rheumatic diseases as well, like hematologic diseases, in malignancies, in type 1 diabetics, in autoimmune hypothyroidism. So in these conditions also ANA can be positive. Immunological test can only support a clinically suspected diagnosis. So these are the different patterns and different disease associations with ANA positivity. So this is a correlation of if you happen to see a homogeneous pattern, you can suspect these particular diseases, or speckled pattern, these, so on and so forth. This I am not going into the details. This is immunoblot paper, in which, so earlier there were very few antibodies that we were able to test at one go, but now we have immunoblot strip which tests 15 antibodies, 15 autoantibodies at a time. Okay, so based on this, again, any antibody being positive does not conclude that this patient has a specific disease. Like if SSA is positive, you cannot clearly tell that this patient has Sjogren's or not. SSA, SSB positivity will be of any value only in clinical suspicion of or a patient having Sjogren's or Zika symptoms, oral Zika or ocular Zika, or if she has been having recurrent pregnancy loss because of CHBs, etc. So this is one such demo paper. APLA workup. In whom will we order antiphospholipid antibodies? So if there is an obstetric complication or a non-obstetric thrombosis, right? So what are the three antibodies which are checked in routine clinical practice? Lupus anticoagulant, anticardiolipin antibody, and beta-2 GP, right? So I'm not going to go into the details of APLA workup. Coming to complements. So complements generally tested in a routine clinical lab are C3 and C4. If these values are low, it indicates that there is a consumption coagulopathy that's happening. And specifically, it indicates a disease activity in patients with lupus, especially lupus nephritis it is used. It is also made use of to differentiate between lupus nephritis and eclampsia, which also will have proteinuria in that particular patient. So for differentiation, to make a diagnosis of lupus nephritis or active disease in patients with lupus. ANCA is yet another investigation which is tested in patients with suspected vasculitis. So these are antibodies formed against PRP or MPO myeloperoxidase. It is detected by IF method and confirmed by ELISA method. So there are two different patterns, that is perinuclear pattern and perinuclear staining pattern and coarse granular pattern. Clinical utility of ANCA. Now you know you have a patient with suspected vasculitis in whom ANA is positive. So what do? You have a patient with, so the first case scenario is negative ANCA with no vasculitis. I'm very sorry. So if you have a patient with clinically suspected vasculitis but ANCA is negative, that does not rule out that this patient has vasculitis at all. The next one, persistence of ANCA. Now for example, a patient has ANCA associated vasculitis. If this patient's ANCA is tested again by ELISA method and if it is detected still positive, but patient has clinical remission, what do? Do you still call that this patient is active disease? No, this patient is under clinical remission. So you continue with medications, you can taper down the steroids, taper down the immunosuppression if necessary. Likewise, if ANCA is positive in ANCA-associated vasculitis, persistence of ANCA, if you just have to reassure the patient, okay, because the disease is inactive, you don't have to worry about the patient. So reassurance becomes very important in these patients. If ANCA is negative with clinical quiescence, but eventually, because of some symptom, if patient gets ANCA tested and it turns out to be positive, but clinically your judgment says it is not active, you just have to keep monitoring this patient closely because this patient is at risk of flare of vasculitis, right? However, ANCA is not the gold standard. It is the histopathological examination that is a gold standard to make a diagnosis of vasculitis. These are the various disease association with ANCA. Sometimes we come across reports like atypical ANCA positivity. So we don't know what is this atypical ANCA positivity. It is seen in patients with rheumatoid arthritis very often, in lupus, Sjogren's, giant cell arthritis, etc. So these are the various other antibodies which we do not really check often in the clinical labs. Coming to myositis specific antibodies, so these are tested only in patients with inflammatory myositis, especially when patients have difficulty to get up from sitting or squatting position, difficulty to raise their hands, difficulty to get up from lying down position, who are needing assistance to make all these movements. So these patients are the ones, if the preliminary investigations show that there is raised inflammatory markers, if there are transaminases that are elevated, we have to go ahead with few other investigations like this. Okay, so there are 8 very well-known myositis specific antibodies which are listed there. So here I want to bring in antisynthetase syndrome. So it is a constellation of symptoms of arthritis, mechanics hands, interstitial lung disease, myositis, Raynaud's and fever. So any patient walks in with inflammatory ILDs. Okay, you just cannot just discard saying that it is only ILD. No, you should know if there is anything else into it. Whether this patient has mechanics hands. If you all have seen a mechanics hand, only then you can know what to look for, right? So likewise, you are supposed to ask for history of Raynaud's. Okay, so these are the myositis specific antibodies, and these are myositis associated antibodies which are seen in around 50%, as less as 50% of patients with inflammatory myositis. They can have coexistent other diseases as well. Okay, coming to uric acid. So who should we test uric acid for? If there is a history of podagra, Dr. Chengappa already spoke about gout very much in detail. I will not go into the details of it. So ideally, it becomes very irrational if you ask for a uric acid in a prepubertal male or a young menstruating female, right? It is always supposed to be checked in postmenopausal women and pubertal or after 16 years, right? So there are few patients who say, "Illa doctor, I am taking tablets." So most of the time you cannot rely on whatever they've been telling. So who you should check with? You should ask for their dietary habits, their alcohol intake. There are few patients who say, "No, I took alcohol along with one colchicine yesterday." So it becomes like a prescription. Alcohol along with the other anti-inflammatory drug or colchicine or allopurinol, they take as and when they want. So that has to be disciplined. It has to be explained very properly to patients when they come to our clinic, right? The gold standard for making a diagnosis of gout is demonstration of uric acid crystals under a polarized microscope. Okay, not all patients with high uric acid levels have gout. Likewise, all gout patients do not have raised uric acid levels, right? That has to be kept in mind. Now, HLA. Again, when is HLA B27 supposed to be ordered? If you encounter a young patient, young male specifically, so young male as in less than 40 years, if they have history such as of inflammatory low back pain, with psoriasis, with or without, I mean to say, or associated with inflammatory bowel diseases or enthesitis, any of these, you are supposed to order. Otherwise, it is not supposed to be ordered. Okay, one thing is clinical judgment, history. When you examine the patient, if you are able to demonstrate Schober's positive, Faber's positive, then go ahead with X-ray. If X-ray is showing something, sacroiliitis. If you are in doubt, go ahead with MRI. If MRI is also saying that there is acroolitis, that is when you need to. But then will HLA-B27 guide you through anything? No, it is not going to guide your treatment. It will only make you accurate with respect to your diagnosis. So if you see the prevalence of HLA-B27 in North India, it is as high as 2.7 to 29%. Whereas in South India, it is 0.9 to just 2.1%. So just starting HLA-B27 it becomes really meaningless if you just like that order. Okay, so its positivity in various other conditions I have mentioned here. So like I already told, RF positivity is not rheumatoid arthritis. Likewise, HLA-B27 positivity is not equal to spondyloarthropathy. So it is seen in various other conditions as well. Okay, to monitor response to therapy, again, when we initiate a medication to look for the side effect or to see the improvement in clinical condition. Routinely we use complete blood count, ESR, CRP, that is inflammatory markers, along with liver enzymes and creatinine to monitor for side effects. But otherwise, dsDNA is used only to see if there is a response or clinical remission in patients with lupus nephritis and similarly with complements. Now, this is the last slide. I have just run through most of my slides for want of time. So these are my take-home messages. Rheumatology is not joint disease or arthritis. Battery of investigations. Almost all of the investigations. So here I have just mentioned one or two here, but no. Almost all of the investigations you have to use very, very judiciously. Do not burden the patient and the lab and yourself with unnecessary tests and unnecessary medications. Seek help whenever it is required. Thank you.
Thank you, Dr. Sangeetha. Please look into those things. And so RFANA is not like the diagnostic test. So we have to all put together and then make a diagnosis. So I think many people will have lots of questions, but at present I will hold up for all the questions because of the time. We can discuss individually. So many of us are rheumatologists, we can catch up one of us, so and then ask the questions. So for the lack of time, I would not allow any questions at present.
An extremely relevant topic in the era of immunosuppression. We invite Dr. Vikram Raj Jain, consultant rheumatologist, Bhagwan Mahavir Jain Hospital, strategies and vaccination. Before that, I would like the chairperson to hand over the token of appreciation to Dr. Sangeetha K N. Please.
Vikram Jain, who is MD Medicine and DM in Clinical Immunology, ultrasound in musculoskeletal diseases, and also vaccination in rheumatological diseases. And he has multiple papers and publications and presentations.
And hi-fi tests, biologics, latest targeted therapies. So my talk today is about the other side, the sobering reality of treatment of autoimmune disease, where one part which we always come across is infections. So before I start, I just show you a few glimpses of a few cases just to illustrate my point, and we'll come back to these cases at the end. So this is a patient I saw recently. This is after treatment. Actually he came. He's a known case of rheumatoid arthritis, and he was started on the targeted therapy called as JAK inhibitors, or tofacitinib is one of the medication. And he came with swelling, first discharge from his little finger, and as I got the history, I knew what was happening, so I asked the surgeon to see. They aspirated the pus. It turned out to be tuberculosis. So this is, what is this? Can any of the students answer? What do you see? It's very straightforward. This is like herpes. So this is a couple of patients of the one on the left is lupus, coming with herpes zoster, and the third patient on high dose steroids for myositis developed this complication of pneumocystis infection and eventually succumb. So why I am talking about this is we should understand why patients of rheumatic disease are infection prone. What are the common and serious infections in these patients? How can we use strategies to prevent these infections? And a most important component of this talk is going to be vaccination. So if you ask any rheumatologist, they will tell you that there is a big burden of infection, and these infections can cause not only morbidity but also mortality. So we lose many patients because of infections. We are managing the disease, but they succumb to infections. Infections not only cause increased hospitalization rate, they also patient needs IV antibiotics, increased costs. Opportunistic infections are very common, and the problem is many times it's difficult to differentiate whether this is disease or infection because they can mimic each other very closely. And for us, a dictum is always, before we escalate, when we think the disease activity is there, we need to be sure whether this is disease or infection, because if you're going to give immunosuppression, it can work the other way. So ask any rheumatologist, the biggest nightmare is, just as this meme says, "Tappad se dar nahi lagta, pyar se lagta hai." Rheumatologists, we are not worried about complicated diseases, we are many times worried about infections. So, but why patients of autoimmune disease have high infection? So it's not just the drugs, the disease itself. So patients of lupus, rheumatoid, or any other autoimmune disease have an underlying genetic susceptibility which predispose again to a lot of infections. They have complement deficiencies, they have innate and adaptive immunity issues which can predispose to infections. Then obviously the major risk is obviously because of the medications, steroids, the most notorious of them. It is dependent on the dose and the duration. Conventional DMARDs, targeted DMARDs, biologic DMARDs, we'll get into this. But the important point is many of these targeted therapies act in certain ways and they have very peculiar infections which they can cause. And last but not the least, it is patient factors. So blame it on the patient also, because elderly, again with age, your immune system ability to respond to infections get lower. Comorbidities like diabetes, CKD, lung diseases also predispose you to more infections, nutrition status. So an amalgamation of all these causes, the disease itself, the medications and also patient factors all together make these patients at high risk of infections. Just to illustrate a point, this is a data, patients of lupus and rheumatoid have almost equal risk of infection compared to patients of transplant for herpes zoster. So this is just an illustration how the disease itself can predispose to infections. 4 times, and though no dose of steroids is safe, but we say more than 7.5 milligram per day increases infection risk. So if you see, steroids can cause very widespread infections, bacterial, fungal, tuberculosis, herpes, etc. So because the mechanism of action is so widespread, it attacks, it's not a targeted therapy. But other targeted therapy like biologics, especially like TNF inhibitors, we know specific infections are more common. Like tuberculosis reactivation is very common with TNF inhibitors, especially extrapulmonary tuberculosis. Rituximab can cause reactivation of hepatitis B or some rarer infections like PMLE. JAK inhibitors, the newest kid on the block, is associated with a lot of atypical infections. Tuberculosis is common, herpes zoster is common. So what is the immunosuppressive dose? Is any medication which we use immunosuppressive? So there is a certain definition. So the Center for Disease Control defines immunosuppressive therapy as steroid use of more than 2 weeks in dosage equivalent to prednisolone of 20 milligram per day. So 20 milligram per day for more than 2 weeks would be considered immunosuppressive. Or if your weight is less, maybe 2 milligram per kg body weight. Methotrexate more than 0.4 milligram per kg per week. Azathioprine more than 3 milligram per kg per day. Biological DMARDs, all of them, targeted synthetic DMARDs, are also defined as immunosuppressive therapy. So just any dose is not, so there are specific dosage. So steroids, if you are using more than 20 mg per day for more than 2 weeks, you are getting into an immunosuppressive dosage and likely to cause more infections. steroids, just to illustrate again, herpes infection is common. Almost 3% increased risk of herpes zoster with more than every 100 milligram cumulative dose, and more than 60% increased risk of herpes zoster in those using high dose of steroids. But among the biologics and the targeted DMARDs, one drug stands out, and that is the JAK inhibitors. So you must have heard about tofacitinib, upadacitinib, and newer medications, and these drugs specifically have an increased risk of herpes zoster. So just to demonstrate that certain drugs have specific infection risk, and this is something to be kept in mind when we start these patients on these medications. So among the conventional DMARDs, so we were using previously methotrexate, leflunomide, sulfasalazine, and now more and more we are using targeted DMARDs and biological DMARDs. If you compare the patients, say on rheumatoid having on biologics, say anti-TNF, has a 2 to 6 serious infection per 100 patient years compared to a 1.5 to 1.8 serious infections for traditional DMARDs. So the more targeted therapy, more specific therapy we are using, though we are getting very excellent results, but the sobering reality is also an increased risk of infections. So now you may ask, sir, our patient, obviously well-read patients and many times other people would have told them, sir, you're going to start me on steroids or you're going to start me on specific medications. There is a big risk of infections. Isn't it a problem? Should I take them? Can I avoid these medications? So it's very difficult to answer. So I always tell them that, so if you're going, just an analogy that if you're going on or traveling in the road, there is a risk of accident. But that doesn't mean we don't go on the road. We need to travel, we need to go. But how do we reduce the risk of accidents? By following certain precautions. So you wear the seat belt, you follow traffic signals. So you make ways or devise ways to reduce the risk of infection. So similarly, risk of accident. So similarly, to prevent infections, there are 4 pillars, and I'll just take you through all these 4 pillars. And the first and the most important is patient education. So we need to explain the patient what you are getting into and how we can reduce risk of infection by some very simple techniques. We also, as doctors, would want to do some pre-treatment screening. Vaccination is a very, very important and probably the most important component of this infection prevention strategy. And last but not the least is prophylaxis and timely management. So now this has become easy, patient education, because we have gone through this COVID pandemic and many of us know hand sanitization, masking, and etc. So whenever patient is on high dose immunosuppression, very simple technique I tell them is what you followed in COVID. So hand sanitization, avoid going into crowded places, use mask, try to be good ventilation, etc. should be there. So these are some of the simple techniques which people already know thanks to COVID. Now, other simple things like early reporting of fever, cough to your doctor, avoiding self-medication with antibiotics, some precautions when traveling with food, respect to food and water, because if patient gets infection like diarrhea or some LRTI, you are invariably trying to reduce your medication, risking a flare, and they are likely to have longer and more severe infections. So simple advice like this is a very most important, the first pillar of preventing infection. Next is going on to pre-treatment screening, and all of us as rheumatologists, if you see, we would always advise, apart from the routine investigations, certain tests like viral serology or a chest X-ray, apart from the history, to look for any underlying latent infections. Tuberculosis in our country is endemic, so screening for tuberculosis, especially before starting biologics and JAK inhibitors, is mandatory, and screening followed by prophylactic treatment if required in case of positive test has shown to reduce the risk of TB reactivation to the same level as a patient not receiving a biologic. So this is it's a game changer. The screening test has been a game changer, especially in TNF inhibitors. Like before TB screening was started, there were a lot of patients developing TB with TNF inhibitors, and once we have started using the screening techniques, risk has reduced significantly. So what algorithm we follow is very simple. In a patient you are considering starting a biologic DMARD or targeted synthetic DMARD or a high dose of steroids, we screen for symptoms. If there are no symptoms like cough, fever, weight loss, where active TB is considered, we do something called latent TB testing, which is now called as TB infection testing, TBI, where you use a combination of tests like your MAN2, tuberculin skin test, or a TB gold and chest X-ray. And in case the patient is positive, we treat them for LTBI or TB infection, defer the biologic or demand, and then start so that you reduce your risk of TB. If it is negative, it proceed directly to the medications. So this is a very simple and useful technique to prevent risk of tuberculosis. So there are a lot of guidelines. This is the latest paper. I would suggest all of you to go through this, published right now in 2026, where screening of TB infection in rheumatology practice, where various guidelines by WHO, NTP, CDC have given according to the local scenario and the burden of tuberculosis. So what is the proposed algorithm in our setting is, in a resource limited setting, if you don't have access or it takes expensive to do a TB gold, maybe a tuberculin skin test with chest X-ray is enough. In a moderate resource setting, probably do a TB gold with chest X-ray and treat if the TB gold is positive. But a high risk tertiary care setting like how most of us are practicing, dual testing with both the tuberculin skin test and the chest X-ray and treat with any of either is positive is probably the way to go for most of us. There are certain scores also as apps which is available. So suppose you're starting a patient on biological demand, you can use this infection, rapid infection, this score, where it takes into account their age, their health assessment, past history of infection, CKD, COPD history, what are the demands used, and based on that it gives you a risk assessment score and you can take the respective measures. Certain medications we use specific testing, further testing, like suppose I'm starting a patient rituximab, I'll probably also look at their immunoglobulin profile to see any pre-existing immunoglobulin deficiency for me to start, apart from the routine other screening for infections. So screening has been a very effective way to reduce the risk of infection, but what has really changed the game is obviously vaccination. So in vaccination, still most of the people are not aware that adult vaccination is an important component of treatment, and in rheumatic disease we strongly recommend flu and pneumococcal vaccine, certain situations herpes zoster, hepatitis B, tetanus, etc. But these are the three main vaccinations, and I'll just take you through all of them. So general principle of vaccination is, in all our patients, we assess yearly vaccination status. This vaccination should be ideally done when the disease is quiet and preferably before starting immunomodulating therapy. And non-live vaccines can be safely given to all patients with immunomodulating therapy. Live vaccination, you have to be cautious, and there has to be certain gap which I'll discuss. Coming to the most important, the flu vaccine. Patients of autoimmune disease have a high risk of contracting flu, and for us it is so important that any flu vaccine is preferred over no flu vaccine, and vaccination today is preferred over any delay. So patient comes to you, he's on immunomodulating therapy, you need not wait for a specific time to give him vaccination, you have to vaccinate today. And these patients have shown to have adequate antibody response. Adverse events are comparable to healthy controls. So flu vaccination is strongly considered in majority of patients. Going on to the next one, that is pneumococcal vaccination. Again, risk of pneumococcal infection is very high. In patients with rheumatoid, they have a high risk of hospitalization with pneumonia. Invasive pneumococcal infection is 13 times more higher in SLE than general population. Previously, which we were using is the polysaccharide vaccine followed by the conjugate vaccine. Now we have the conjugate PCV20 also available, which is a once in a lifetime vaccination. Very good efficacy and safety in autoimmune patients. So it should also be strongly considered in majority of your patients. Herpes zoster, again as I said, certain drugs like JAK inhibitors have a high risk of herpes infection. Approved in patients more than 50 years of age, found safe to be in this setting. Certain recommendations also said to start in more than 18 years of age, you can use this vaccination safely. But what about drugs? So if you may ask, sir, patient autoimmune disease, they are on medications, will the vaccines be effective? Certain medications may dampen the response, especially methotrexate, rituximab. So what we suggest is usually to hold, if possible, medications for 2 weeks after the vaccine to have a better response. However, if patient is not able to stop, like because of eye disease activity, you can as well continue. Rituximab is one setting where if you are going to give a rituximab to a patient, ideally we should vaccinate before starting rituximab, or if it's already on rituximab, wait for at least 6 months after the last dose. In patients of JAK inhibitors, herpes zoster you have to consider, that is the recombinant vaccine. Other biologics other than rituximab, the vaccination may not have a major effect, so you can vaccinate during the treatment itself. What about steroids? Now steroids, as I said, more than 20 mg is going to be immunosuppressive. So apart from influenza, other vaccines usually they tend to differ unless once they start coming below say 20 mg per day, you can vaccinate them. So to have an adequate immune response. Live vaccines usually we tend to avoid, but if you have to use live vaccines, hold your medications, usually steroids, DMARDs, at least 4 weeks prior to the live vaccine, and after vaccination, at least 4 weeks you wait till you restart the medication to reduce the risk of infections. Moving down to the last pillar, that is prophylaxis. So we discussed about patient education, screening, vaccination. The last pillar is prophylaxis. Suppose you had a patient whom you screened for tuberculosis and his MAN2 or his TB gold was tend to be positive. You wanted to start him on TNF inhibitors or you want to start him on JAK inhibitors. So what do? We treat something called as latent TB infection treatment, where there are different regimens suggested. One of the regimens is like using 6 months of isoniazid or 3 to 4 months of rifampicin or 4 months of isoniazid with rifampicin. So you can use various regimens. You start your TB treatment at least 4 weeks prior to your biological DMARD, and once after 4 weeks you can use the medication and continue the therapy for the remaining part. So usually most commonly used is isoniazid 6 monthly or 3 to 4 months of rifampicin. Other prophylaxis, as I showed, is one is using of Septran prophylaxis or trimethoprim sulfamethoxazole prophylaxis, especially in those on high dose of steroids, cyclophosphamide, rituximab. This is something which we do as default. So any patients on these medications, we use these unless the patient is allergic to sulfa, either as alternate day or double strength therapy. Patients, I would just want your feedback. So this was a patient of rheumatoid arthritis. He was started on JAK inhibitors. So the issue was TB screening was not done. So if TB screening had been done or if we had evidence of tuberculosis, probably starting him on latent TB infection would have prevented a TB tenosynovitis. Similarly, in this patient on JAK inhibitors, probably a herpes vaccination prior to the treatment initiation would have prevented herpes infection. Similarly, in this patient on high dose steroids, if a Septran prophylaxis would have been initiated, probably would have prevented infection and would have the mortality could have been avoided. So these simple measures probably would have made a big difference to these patients. So before I end, just few take-home messages. Infections are a major cause of morbidity and mortality in autoimmune patients. This is a sobering reality. Disease, drugs and comorbid factors are responsible. It's not just the steroids. The disease itself as well as comorbids also are, put the patients at increased risk. First and foremost, patient education is the most important. Screen patients for relevant infections. Use vaccinations, respective prophylaxis. These are the pillars of infection prevention. Vaccinations are safe and effective in autoimmune patients, even adult patients. Flu and pneumococcal vaccinations are strongly recommended. Zoster vaccination in patients more than 18 years, especially on taking immunosuppressive medications like JAK inhibitors, methotrexate and rituximab. Some of these medications may need a modification schedule, but most other drugs need not make a huge change in the therapy schedule. Steroids, dose and duration will decide if they need vaccination, if it needs to be deferred. So with this, I would like to end and happy to answer questions. Thank you.
Diseases, and he has elaborated on the 4 pillars you should all be interested on or focused on. Present, we will close the session. So we can take, as I told in the last one, so we can take the questions individually. So thank you, Dr. Vikram.
Thank you. Thank you.
We would also like to present our chairpersons with a token of appreciation. We would like to request all the chairpersons, that is Dr. Sidney D'Souza, Dr. Manjunath A, Dr. Purushottam DR, Dr. Prasad B N, Dr. Sudhindra Rao and Dr. Mukhyaprana Prabhu to please come on to the dais.
May call upon stage the Dean and Director of the Koims, Professor Lokesh Jain, please on the dais, please. Dr. Somshankar HK, Medical Superintendent of Koims. Dr. Vinod Ravindran sir, President-elect of the Indian Rheumatology Association. Dr. Vinod sir. Dr. Ramesh Jois, President of Karnataka Rheumatology Association. Dr. Subramanian, Vice President of KRE. Dr. Vikram Jain, Secretary of KRE, Medical College. Dr. MC Karyappa sir. And Dr. Mukhyaprana Prabhu sir. And Dr. Shiva Prasad, the Organizing Secretary of the CLB, to be on the dais.
Program, it gives us immense pleasure to invite the backbone of today's event, our respected Dean and Director, Dr. Lokesh AJ sir, to deliver the welcome address and set the tone for this gathering.
Today's speakers, my dear colleagues and esteemed delegates, students to this beautiful CME. This is the second CME being held in association with Indian Rheumatology Association. We have today eminent speakers among us to address all of us. All of you should learn not only in classroom, outside the classroom, library, interaction, symposium, and even CME is important. And this I'm telling it to students and our junior colleagues. And also, this CME is possible because of our IRA Karnataka chapter, and especially thanks to Dr. Shiva Prasad sir. And this is the second time we are organizing CME along with Shiva Prasad sir only. That is the love and affection we have got towards institution. Welcome sir. I also welcome our medical superintendent Somshankar sir to this CME. I welcome IRA President-elect Dr. Vinod Ravindran sir, who is from Calicut, in hospice in so many years. Yesterday also I met him. He wants to be associated with our college also. I welcome him sir. I also welcome Dr. Ramesh Jois sir, senior rheumatologist from Bangalore and also President of KRE Karnataka, CME of Kodagu. I welcome Dr. Sidney D'Souza sir. He is coming as a teacher as well as examiner to this college since 4 years. And he happily agreed to be part of the CME. I welcome sir. Department of Rheumatology, Medical College. Sir is also coming for the second time. I also welcome Dr. Prabhu, post-graduation. I welcome Vikram Raj Jain. He is a senior consultant. Speakers, Dr. Nagaraj sir and Dr. Nagaraj sir, Dr. Gangarathna, Dr. Chengappa, who is also from, he is a native of this Coorg, and he spoke very well also. And I also welcome Dr. Suman, Dr. Sangeetha to the CME. I welcome Dr. Satish Rao, KMC Medicine HOD. I welcome Dr. Prakruthi Jahadev. She is from rheumatologist from Mysore to the CME. His office. Okay, she's not outside. I also welcome Sudhir Rao, sir. He is from Shema. He is a medicine HOD from Shema. Hope. What's my best? Yes, sir. I also welcome Mahabaleshwar. He is my Austin Medical College student. I don't know when. Yes. He is a rheumatologist. He is an assistant professor in rheumatology, Department of Rheumatology, Medical College. And this recent case presentation is all because of him. And also, I welcome Rashmit U, clinical rheumatologist from Mysore. Okay, sir. And then I welcome Dr. Sumant Madan, consultant rheumatologist, KMC Bangalore. I once again welcome Dr. Prakruthi Jahadev to the CME. We hope to continue similar CMEs because this medical college is since 10 years now. We are improving academics, non-academics, infrastructure and other facilities with the help of academicians, with the help of government, with the help of you also, friends and relatives, whoever cooperates with the medical college. And government is planning to bring up this institution as super specialty institution shortly. We are planning to have 5 super specialist consultants from next month onwards. And by May, we are going to have cath lab in this institution. With this, I hope the CMA. Thank you one and all, especially IRA President Dr. Vinod Ravindran, Dr. Prasad and other dignitaries on the dais and other office bearers of the IRA. Thank you once again for attending the CME. Thank you.
Shubham karoti kalyanam, arogyam dhana sampada, shatru buddhi vinashaya, deepa jyoti namosate. Salutations to the flame, which brings auspiciousness, prosperity, health, and destroys negativity. I request all the dignitaries on the dais to please come forward and light the lamp. We request all to raise for the prayer. Neene vinayaka, ni faladayaka, ni sukadayaka, ni faladayaka, ni sukadayaka, faladayaka neene vinayaka, vidyarambhadi paliso namage vinayaka, bhajanarambhadi bhajisuve ninnanu.
Dignitaries in the dais and off the dais, my friends, my students, my colleagues. Today, actually, in spite of the long leave, all dedicated speakers have come all the way to present the beautiful topic, rheumatology. It will not leave anyone. So it is also called a crippling disease. It will never the person to free movably. So today I congratulate everyone to participate in this program, beautiful topic. Make use of these CME programs and thank you one and all. Thank you.
I'd like to invite Dr. Vinod Ravindran sir, President of Indian Rheumatology Association and Senior Consultant Rheumatologist, Center of Rheumatology, Koims, to speak few words.
Good afternoon, everyone. I would like to start by thanking the senior leadership of the Kodagu Institute of Medical Sciences, led by Dr. Lokesh sir, and all the other senior faculty who are here. Dr. Lokesh sir is actually a very senior member of the Indian Rheumatology Association, and I've been really honored and privileged to have known him for the last 11 years. But I met him only yesterday night. And I think, as I was discussing with the medical students here just now, this type of CMEs have far-reaching effect and impact beyond what you will feel being present in the hall today. The deliberations, the pictures, the knowledge will stay with you. And when you see a patient, when you come across those scenarios, we sincerely hope that it would help you remembering those scenarios and whatever teaching we could impart. So I would like to thank all my colleagues from all across Karnataka who are here under the banner of Karnataka Rheumatology Association, led by my dear friend Dr. Ramesh Jois. And thank you, students and faculty, for making this CME a success. Thank you.
Lokesh, dignitaries on the dais, faculty of Kodagu Institute of Medical Sciences, all the invited speakers and my young friends. They say connective tissue is the largest tissue in the body, but the amount of attention and teaching which is done in the medical colleges is the smallest. If I am right, I think the rheumatologists will agree with me. When you are in practice, and I can vouch for it because I have only been doing it for the last 41 years, in practice, the commonest symptom you will hear is pain. And every young individual, every young doctor should understand that this pain is not something which can be flipped aside. Just say, as one of the speakers said, growing pains you get in a child or in an elderly person. Oh, you are too old, no, you are having arthritis. You cannot brush it aside. They need relief. And for you to give relief, you must understand what is the underlying problem. You have to make a correct diagnosis and you treat. And believe me, your patients will be eternally grateful to you. And again, Dr. Ravindran very specifically mentioned about CME, attending CMEs. These programs are the ones where you young students learn a lot. The classroom teaching is not enough. It is interacting with people with a lot of experience. Today you have some wonderful speakers from the Rheumatology Association. Please make use of it, and I would encourage Dr. Lokesh to have more such programs, because it is an institution cannot teach everything to the students. You have to get faculty from outside. You have to expose the children to those faculties. Only then will your knowledge of medicine improve. So I congratulate Dr. Lokesh and also the staff of and I wish you young people a very bright future. I'm sure you will learn more and more in the years to come, and then you will become excellent doctors, excellent citizens of India. I thank the Karnataka Rheumatology Association for inviting me to be a part of this. I'm still learning. Please remember, learning is never over. And thank you very much for having me here. God bless you.
Dr. Ramesh Jois sir, Senior Consultant Rheumatologist, Rheuma Care, Bangalore, to speak few words.
Thank you, Lokesh sir. On behalf of Karnataka Rheumatology Association and my colleagues, it's very important to have an interaction with non-rheumatologists. We all attend our own specialty meetings, but meeting physicians, meeting orthopedic surgeons, having interactions with non-rheumatologists is very important, because rheumatology or rheumatological diseases are not diseases restricted to single organs. They are multi-organ diseases. So
as we go on in today's talks, you will notice that rheumatology patients don't come to a rheumatologist, they go to everybody else other than a rheumatologist. So an important an interaction between specialists is very important, and hence a multidisciplinary approach is very important. So educating and learning from each other, from with other specialities is very important for rheumatologists as well as for others. So with this, Dr. Shiv Prasad and his team have formed an array of topics today to cover as many aspects of rheumatology that a physician or other specialties should know. It gives me a great pleasure in attending this CME and being a part of this lovely meeting. The Karnataka Rheumatology Association is also encouraging students to take up rheumatology as a career and also to get into a little bit of rheumatology research. So as a president of the KRA, I want to let you know that there are some travel grants available from the Karnataka Rheumatology Association for students who are doing small projects on rheumatological diseases and wanting to present it in conferences within India. So we are giving travel grants also. So if anybody, any one of you, even if it's a case report, rheumatological disease and a case report, we want to encourage you. You can always apply. We have a KRA website and you have all the rules there, and we will help you out also with travel grants. So with these few words, thank you once again for asking KRA to be part of this wonderful CME. We want to plan this more in other districts of Karnataka, pairing with other medical colleges and IMA branches. Thank you.
Thank you, Chairs. To start. Yeah, okay. So, greetings from Calicut in Kerala. You can see that not very far from you, just 6 hours of travel yesterday. But as Dr. Jois said, lovely to be here among you. So, the brief I have is to discuss pregnancy in the context of rheumatic diseases, avoiding troubles, and achieving goals. I missed Dr. Shiv Prasad's brief that it has to be a case-based discussion. So I think I got maybe 1 or 2 cases inserted somewhere. Apologies for that. So I would like to start with a question that what do you think in a typical rheumatology clinic would be the proportion of women? So 50%, 30%, 100%, 70%? 70%. Okay, so we see only 30% less than obstetricians in our clinic. Okay, so the number of women. So there are a variety of reasons why rheumatic diseases are common in women. It could be hormonal, it could be genetic, it could be environmental factors, it could be the inherent aberrations in the immune system. But discussing that is beyond the scope of my topic. But of course, there are a lot of material available. So what I have done is, I have divided the talk sort of, what we must know. Whether we are medical students, any stage, postgraduates, physicians, obstetricians, what should we know? So the first thing is that we should know what are the burden and what are the intricacies of this sort of dynamics between the pregnancy and the autoimmune rheumatic diseases. So you can appreciate from this figure that in the pregnancy, like in any other scenario of our life, there could be non-autoimmune rheumatic conditions developing. There can be known rheumatic conditions such as rheumatoid arthritis, could be developing, which is more or less, fairly benign and stable during the pregnancy, or there could be development of far more sort of serious disorders such as lupus or antiphospholipid antibody syndrome. So when you consider the non-rheumatological conditions causing musculoskeletal pain during pregnancy, you have a lot of reasons to contemplate. It could be because of the hormones which will make the ligaments loose so that the growing fetus can be accommodated. Okay. And there could be water retention, soft tissue edema, there could be, so there is a massive and rapid weight gain during the second and onto the third trimester of the pregnancy. The center of gravity could be altered because of the growing fetus, okay, and because of the weight and the shifted dynamics, the medial arch of the foot would be collapsed. So this can lead to low back pain, knee pain, carpal tunnel syndrome, plantar fasciitis, and so on and so forth. Okay, so a lot of non-autoimmune rheumatological conditions can also happen. But what is important, though the list is long of the non-autoimmune rheumatic diseases, only couple needs to be, keeping in mind, because they are quite sort of serious. And I have listed them here. One is the transient osteoporosis of the hip, and the second is the avascular necrosis of the hip. Okay, but we should not be worried about that. What I mean to emphasize is that in all these non-autoimmune musculoskeletal conditions happening during the pregnancy, reassurance, appropriate counseling, rest, splintage, topical or oral anti-inflammatory agents, physiotherapy alone is sufficient. Okay, no need to panic. As the pregnancy gets over, these things will resolve. So it's a question of balancing the women's problem versus the outcome. Okay. In terms of your history taking, it is important to ask the women that in the previous pregnancy, did you have any problem? Because the problems have the tendency to recur during the subsequent pregnancy. Okay. So nothing to be worried about here. When you come to the autoimmune rheumatic diseases in pregnancy, there are a lot of other issues you have to consider. One is what is happening to the disease. Is the disease active, stable, or sort of, still sort of, evolving? What drugs would you use? Okay. Are the drugs you are using, are they safe for pregnancy? Are they safe for lactation, breastfeeding? What about the specific autoantibodies? Because we know that certain autoantibodies can actually affect the fetus, right? And then with all these things happening, multiple interventions, multiple testing, and the medications, what is happening to the psychological status of the mother, again, are the questions which you have to consider. And these can affect all the three phases of pregnancy: preconception, during pregnancy, and in the postpartum phase, lactational phase, breastfeeding. Then what happens to these women when they try to conceive again? There is subfertility. There could be increased disease activity because you would have stopped certain medications in the context of pregnancy. And then could they breastfeed? Could they not breastfeed? Till what extent? How many months they can breastfeed? So these are all important issues. So in this single slide, you can see, as opposed to the non-autoimmune rheumatic musculoskeletal manifestations during pregnancy, autoimmune diseases can cause lots of problems. Okay. Previously, we used to think that rheumatoid arthritis behaves quite benignly during pregnancy. It is not the case. About 50% would likely to flare. In fact, psoriatic arthritis is only an autoimmune rheumatic condition which actually does dampen down during the pregnancy. Then lupus is going to be the main focus of my talk, and scleroderma can also per se would not affect, but of course, if there is fluid overload and somebody has already got pulmonary arterial hypertension or a renal involvement, that could be a problem. APS, I am going to leave to my dear friend Dr. Nagaraj. He looks happy. Thank you. Okay. Now, this is a very important slide for you. So what it tells you that even for a disease such as rheumatoid arthritis, if the disease is well controlled during the preconception phase, 3 out of 4 women will successfully conceive. Okay? If the disease is not well under control during the preconception phase, only 1 out of 4 would conceive. So that is the importance of bringing the disease right under control in the preconception phase. Okay. And in lupus, we know that our patients actually drop out. We want them to come at 3 months, but they never come. They come at 6 months or a year later. So a lot of pregnancies can happen, what we label as, unplanned pregnancy. So if a pregnancy is unplanned, you don't know, patient has become pregnant, most likely they are not well controlled. It is quite likely that they are not on the drugs you wish them to be. Okay? And then you can see in this slide that if the pregnancy is unplanned, there are actually far more complications. Okay? Then if the patient if everything is all right, okay, you put them on good medications, during the pregnancy their disease is fine, why you want to stop the medication? Okay? If the drug is safe and if it is working during the pregnancy, there is no need to stop the medication. Because if you do, you will see that in the postpartum phase, during the lactational phase, almost all the diseases are going to flare up. Okay. Now, lupus is, one of the most sort of serious disorder impacting on the pregnancy. So if you know lupus, you know everything. That is what I would also say in the context of pregnancy. So if you consider the impact of lupus on pregnancy outcomes, both maternal and fetal, you can see that they are actually quite worrisome. The maternal mortality rate is increased by 20-fold. Okay. And the rates of preeclampsia, other pregnancy-related hypertensive disorders, serious infections, all are much more in lupus. And if you look at the fetal outcome, preterm birth, intrauterine fetal, growth restriction, low birth weight, instrumentation delivery, they are all higher compared to normal women who do not have lupus. Okay. Now, the question you want to ask is, why does that happen? So what we have to consider is that the placenta is absolutely the key in terms of how the fetus is going to do. Okay. So if the placenta is compromised because of any reasons, the fetus is not going to do well. So having realized that, now all these sort of adverse pregnancy outcomes you see here, preeclampsia, intrauterine fetal growth restriction, small for gestational age, placental abruption and stillbirth, they are all clubbed under what is called the maternal placental syndrome. Okay, so a group of diseases where the placenta is the key. And this would be a postgraduate question, so I will leave that. But in the black boxes, you can see that there are biomarkers available which can tell that which patient with lupus is not going to do well, which patient is more likely to have the development of preeclampsia. Now, a very old slide, but I think one of the most beautiful slides to explain this. So what happens in a normal pregnancy? See, the fetus is a semi-allograft. Half of the genetic material comes from the father and half comes from the mother. What comes from the mother is not at all a problem. What comes from the father is considered as, alien by the mother's immune system. And in a normal pregnancy, the fetus is rejected. The immunological process starts which actually rejects the fetus. But in the normal women who do not have lupus, this mechanism of rejection fails because there are enough immunological inherent mechanisms available to counter that. In lupus, what happens? Those mechanisms fail. So what happens? There is pregnancy loss. Okay, to put it very simply, right? And if you look at this slide, there are multiple things happening immunologically during the pregnancy. You can see some levels are going up, some levels are coming down. And you make out, but for you what is important is if you look at the T regulator cells during a normal pregnancy, actually the circulating T regulator cells are higher in normal women who do not have lupus compared to lower what is seen in the lupus pregnancies. Okay, and all these features actually also contribute. Right. I mentioned about the specific antibodies, so you know that the anti-Rho or La antibodies are present in women who have lupus, and they can be present without lupus also. The neonatal cutaneous lupus is not that serious, so are the transient hematological or elevated liver enzymes. But what is serious is the development of the congenital heart block. The risk is 1 to 2%, but if it happens in one pregnancy, the risk goes up 15 to 20% in the subsequent pregnancies. Okay. Now, if your lady had lupus nephritis, active lupus nephritis, absolutely no. Okay, you had to tell the mother that you cannot become pregnant now. Okay, you get her on pregnancy safe medications, you bring the lupus nephritis activity right down, wait for 6 months, then the conception should happen. Because lupus nephritis can also happen, it can flare up during the pregnancy. Whatever was quiescent, it can become active, and sometimes it can develop de novo during the pregnancy. So the trick here is, whatever is the condition you are dealing with, make sure that pre-conception it is right down. Okay. Then you want to ask the questions, doctor, if that's the case, are there any real contraindications for pregnancy? Yes, there are. If somebody had in the previous pregnancy severe preeclampsia or HELLP syndrome, if they have severe pulmonary arterial hypertension because they have systemic sclerosis or other conditions, if they have severe restrictive lung disease, if they have chronic renal failure because of the lupus or scleroderma, if they have heart failure because of a combination of inherent cardiovascular risk factors or because of the rheumatic diseases. If any of these are present, clearly the risk to the mother far outweighs than any tangible benefit. So this is where you have to say that, you are sorry, but you cannot become pregnant, and that is absolutely fine. Because when it comes to pregnancy-related counseling, you have to remember that the mother is your patient. The fetus is not your patient. Okay? So everything you do would be actually in consideration of mother's health, not the fetus health, because you have limited control. Okay. These are certain scenarios which are considered high risk, but are manageable. Like somebody had previous pregnancy loss. Fine, you manage those factors, it is possible. If they had thrombosis during the previous pregnancy, you can consider putting them on aspirin and heparin. If they had lupus nephritis, as long as you have got the disease right under control in the preconception period, waited for 6 months, it is fine. And if they had infections because of the immunosuppression, immunomodulation or other factors, that also is not an absolute contraindication. Okay? So the second thing is, how do you differentiate from a pregnancy-related symptom or sign to a flare of an autoimmune disease? So you can see in this slide that there are a lot of things happening during the pregnancy, the arthralgia, the anemia, low platelets, hypertension, the malar rash and all that. They can also be seen during the normal pregnancy. But same things can be seen during autoimmune rheumatic diseases also. So as opposed to joint tenderness, if you have synovitis, if the inflammatory markers are high, particularly the CRP, instead of generalized hair loss, if they have patchy hair loss, okay. So those are, and then of course in the blood test, if you have sort of rising titers of double stranded DNA antibodies, the complement levels are getting down, then you have to think that this is not the normal pregnancy related symptoms and signs. This is actually the features of activity of the known autoimmune rheumatic conditions. And then of course you have to modify your treatment accordingly. This is a classical confusion, but I don't think if you look at this slide there should be any confusion. So you have preeclampsia on one side, you have HELLP syndrome. So when do they happen? Also is a big sort of pointer. After 20 weeks, but this can happen at any time. So somebody who has these features in 15th week of gestation, you can't think of these two conditions. Okay. Then if somebody has active urinary sediment, it is not a feature of HELLP syndrome. It is not a feature of preeclampsia. So there are a lot of clinical things which can tell you that actually it is active lupus nephritis, it is not preeclampsia, and it is not HELLP syndrome. Sometimes you come across this type of scenario. So this was a 33 weeks pregnant lady with lupus, of course. She came in with this swinging pyrexia. You can see very high sort of spiking fevers, went on and on. And we investigated her for everything we knew that should be tested. And we tested, nothing worked. And then we thought, this probably is actually lupus pyrexia. So a fever of 38.2 degree, no obvious cause, and you strongly suspect that this is lupus. So lupus pyrexia, we stopped all the antibiotics and everything, gave her 500 milligram of methylprednisolone, and she became afebrile, remained so, and delivered a healthy baby at the completion of the term. Okay. So the next question we need to answer is what drugs to consider. This is fairly long sort of discussion, but I got this summary slide for you from the American College of Rheumatology. You can see that hydroxychloroquine, sulfasalazine, colchicine, azathioprine are all safe during any phase of the pregnancy. If you use the steroids, do use them, but try to keep the dose as low as possible. If it is 5 milligram or less, the better. But sometimes during the pregnancy, you may have to use high dose intravenous methylprednisolone. You can do that. Then when it comes to drugs which should not be used, of course, they are mycophenolate mofetil, leflunomide, and methotrexate. Okay, and tofacitinib, like JAK inhibitors. So you stop them, several weeks before their half-life. So tofacitinib you stop 2 weeks before they are trying to conceive. Methotrexate you will stop 2 to 3 months before they are trying to conceive. Now actually it's brought down to 1 to 2 months. And mycophenolate also 2 to 3 months. And leflunomide 3.5 months. Okay, or you give a cholesterol washout. So these 4 drugs you have to be very careful, otherwise fine. If you are using biological agents, go for anti-TNF, biological agents which are etanercept and sleeping. Okay. So all the sort of, the biological agents, anti-TNF agents, infliximab, etanercept, golimumab, citrizumab, they are all fine during the pregnancy. If you have to use non-anti-TNF biological agents such as rituximab, you have to be careful that you time it fairly early during the pregnancy rather than late, because that might impact on the immunological status of the infant, and it will interfere in the way you want to give them the vaccination. Okay. Hydroxychloroquine, very commonly used drug, and there is absolutely no confusion about hydroxychloroquine's usage during pregnancy. It is absolutely safe, and it has got far more beneficial effects on a lot of other immunological mechanisms which is happening during the pregnancy, to be advocated for all the women unless contraindicated during pregnancy if they have autoimmune rheumatic diseases. Okay. I'll skip this too. Okay, so now we know that what drugs should not be used during the pregnancy. This is MD medicine. So ACE inhibitors and ARBs should not be used. But if your lady has scleroderma renal crisis, then you are bound to use it, right? And again, this is to highlight that you are placing the mother's health at a higher priority than fetus. Okay, because you know that it is not good for the fetus, but it is really bad for the mother, so you are going to use this drug. Lactation also, the same principles apply. The drugs which are safe during the pregnancy, they are safe during the lactation. So if you recall the slide I have shown you, the same thing here. And then of course, avoid high dose of steroids in any situation. Okay. So one question which is often asked is, if the relationship between the pregnancy and autoimmune rheumatic disease is so complex, can we actually identify a person who is at risk of developing problems in the future pregnancies? It is possible, and it's a conceptual thing, so I want to give you a taste of that. So see, what happens is when the autoimmune rheumatic conditions are developing, so there is a phase which is a preclinical phase, where the person hasn't got any symptoms at all. Okay, there are no signs. The autoantibodies may be positive and low titer, but sort of they might actually disappear. There might be a long delay between these type of slight symptoms and signs and some antibodies before the disease actually stops. Now the key thing for you to understand is that it is known and appreciated now that a lot of these adverse pregnancy outcomes, whether it is maternal or fetal, they could be the harbinger of autoimmune rheumatic diseases in future. So if you ask the mother, what type of adverse pregnancy outcomes you have? What happened during your previous pregnancy? That has to be absolutely key question, because autoimmune rheumatic diseases, low back pain and all that you can pick up, and also you can pick up whether you need to be careful about the subsequent pregnancies. Okay. Now, in the topic of pregnancy and rheumatic diseases, it should not all be about women, because men are also 50%. Remember, I told you that the fetus is a semi-allograft. So 50% is men. Now, this is a quiz here. Can you anybody recognize what is the condition? And what's the diagnosis? SLE. So the point here is that men also get lupus. Okay, so they don't get pregnant, but they can get lupus. Right. Okay, and this was the first sort of example where chloroquine was used to treat the skin lesions in lupus by way of protrate. Okay, so apart from cyclophosphamide and thalidomide, all the other drugs can be used safely in a man who has autoimmune rheumatic conditions and the partner is trying to conceive. Okay, so and then if they are trying to conceive and if they happen to be on sulfasalazine, then you have to think that because sulfasalazine can cause reversible problems with the sperm count and the motility. Okay, so these three drugs you have to be careful, otherwise all safe. Question comes that so mother is fine, okay, the woman is fine, woman partner is fine, man partner has autoimmune rheumatic disease. Would that impact on the couple's ability to conceive, and what will happen to such sort of pregnancy? Okay, so 2 slides to show that. You can see that the rates of miscarriages are actually high in different type of autoimmune rheumatic diseases when the male partner has got the disease and female partner is absolutely fine. So there is an impact. So that is why it is important now to realize that the male partner's disease also should be well controlled before the couple is trying to conceive. Okay, and then so question asked is how many children you wanted to have? So the person says, I wanted to have 4 kids. And how many kids you ended to have? And the person says, I had only 2. So that reduction happens if the male partners develops the disease, autoimmune rheumatic disease. Okay? So these 2 slides tell you that there are actually direct or maybe indirect influence of the paternal disease on maternal outcome of pregnancy. Okay? In terms of both miscarriages and also the reduced family size. Right? Now, there are a lot of other aspects related to the male contribution of reproductive health which we don't know. And I think what we know I have highlighted here, we know that smoking is bad, alcohol is bad, and obesity is bad. Genetic factors you can't control, age you cannot control. But sperm quality is something sexual dysfunction, medications use, I have discussed, and mental health. These are some other factors which we need to consider. Then throughout the talk I have said this should not be done, this should be done, this medication should be stopped. You know, any idea from where this idea has come? Why I have told like that? They are not based on any randomized control trials. They are not based on any control trials, clinical trials. They all come from the registries. Okay? Because you know that pregnant women and children are excluded from all the randomized control trials. So the information comes about a lot of things I have discussed from these pregnancy registries, which look at preconception, during pregnancy and the post-conception phase, what medication was started, what was the diagnosis, when the medication was discontinued, why it was discontinued, what was the dose of the medication, okay? And similarly covering all the phases. So this type of registries gives us a real-time idea about what is good in the context of pregnancy for a woman who has autoimmune rheumatic disease, not any randomized control trial. So that is why you see that when people talk about guidelines, they say that there is lack of evidence or the evidence is not robust enough. Okay? But it does not mean that we have to stop treating the patient. We have to treat the patient based on what is available. A good judgment. Okay. And final few slides. So in India, there is a decision for all of you to consider rheumatology as a future career. We have very few dedicated units looking at the pregnancy in the context of rheumatological diseases. And our patients also, there is lack of follow-up is there, unplanned pregnancy is there, they have poor adherence not only to the follow-up but also to the medications. Okay. So with that what happens, you have lots and lots of problems, which infections are there, drug-related issues are there. Sometimes you often find, you speak to rheumatology colleagues, they must have seen one or two every year people who became pregnant whilst on being methotrexate and the pregnancy had to be terminated. This is all because of not only the lack of access but also to the lack of access to the education and the awareness related to this aspect of care. Okay? And okay, so I'll come to the Calicut experience. This is just to show that it is actually quite possible to manage patients who have previously bad obstetric outcomes related to lupus. So in this 13-year of study, what we did is we included patients who had at least one poor adverse pregnancy outcome, whether maternal or fetal. Okay, and we subjected them to a protocolized treatment. And what were the components of the protocol? Same I have told you. Before the conception, making sure the disease is absolutely well controlled, making sure that the medicines are pregnancy compatible, monitor them frequently during the pregnancy, ensure that they adhere to the medication which is good for them, and treat the flare as appropriate, and monitor the fetal growth. Okay, and so if you can see that out of 226 pregnancies, live birth rate was 86%, which is fantastic if you consider their compound adverse pregnancy outcomes, which were not just related to the maternal and fetal traditional, but also other things. Okay, you had lupus flare. Okay, most of them were actually quite mild to moderate. Okay, then if you look at the mode of deliveries, I said that because once somebody has lost a child, miscarriage, then the subsequent pregnancy is basically a precious pregnancy. Okay, so we don't know. And then, so there might be a tendency to go for an early instrumentation delivery, which is seen here. You can see that fairly high rate of cesarean section, 45%, and also the ventouse and forceps. Okay. So the conclusion from this experience at Calicut was that it is important to focus on the pre-pregnancy counseling and assessment. Okay, you counsel the mother of the risk and benefits of pregnancy. You counsel the mother about the safe medication. You make sure in your assessment that you know what is the baseline damage to the organs related to that particular autoimmune rheumatic disease. You formulate a plan how to deal with that. And if you do all that, I would say that in today's day and age, pregnancy in women who have autoimmune rheumatic diseases is not at all a difficult thing. It just needs slightly more extra care. And this is something to inspire you. Some awards we got because of this work. This work I was mentioning last year. Okay, so some again cases. So you can see that after 7 pregnancy losses, a lady in the protocol has showed you a successful outcome. Here also after 2 losses, and here after also 2 losses. Okay, so successful outcomes of the women who had previous 2, 3, up to 7 adverse pregnancy outcomes. And this is the baby. When she was in the tummy, the mother developed this swinging paraxia. Okay. And then 2 years down the line, they had another baby. Okay, so that is possible. And twin pregnancy, they represent the active member of reproductive rheumatology specialist in this group. Okay, so this is just to show you that in the Indian Rheumatology Association, we have a group who are focused in dealing with these issues in terms of basically advocacy and education. Okay. And some of the works I just skipped. And also the same work goes on for the APLAR countries. You can see that even if you are out of 37 countries, you have only a handful of countries represented here. But that is also something which goes on. So I would like to conclude that any women who comes to you with musculoskeletal pains, you should consider there being a possibility of non-autoimmune musculoskeletal manifestation, which is actually far more common, simpler to treat, and there is no alarm required either on your or in the family side. Okay? And whatever is the disease, it has to be well controlled during the preconception phase before you allow, counsel them to become pregnant. And whatever you do, whatever challenges you face in your life, clinical practice, remember that teamwork always delivers. Thank you.
Thank you, sir, for that presenting on the spectrum of APLA. Dr. Nagaraj is a senior consultant rheumatologist from Bangalore.
So for the second edition of this Kodagu CME, we had in 2018 the first edition. So I've been very clearly interested by Dr. of antiphospholipid syndrome, which is a very, and Dr. Vinod was very graceful enough to kind of leave this topic to me without covering that. So it's a very kind of relatively rare autoimmune disorder which characterized by the vascular thrombosis and very well-known pregnancy morbidity. And very clearly when you come to think of IPS, we think of 3 antibodies, which is these 3: anti-caudolipin antibody, anti-glycoprotein 1 antibody, anti-beta-2 glycoprotein 1 antibody, and the lupus antibody. As these 3 are very well known, the APLA antibodies. It's a unique pro-thrombotic condition which has a lot of thrombotic events occurring both in the arterial as well as in the venous system. And symptoms can be really very heterogeneous, from neurological involvement to the nephrological involvement and many more. Most of the thrombotic events are DVTs, pulmonary embolisms, and strokes and TAs constitute 50% of the cases. The overall prevalence is just about 50 patients to 1 lakh incidence, and with a high incidence of 5:1. It was its first description in 1970s. It has come to be known as, in fact, this the version of Professor Hughes, which has been named as Hughes syndrome as well. He alluded to the skin involvement of APLA syndrome, EPS, that time, in addition to the pregnancy. So that's how we come to think of it, that in addition to the recurrent pregnancy losses, which is very characteristically described as the pH and other things in addition to the recurrent pregnancy losses. So The importance of taking a detailed history is one case I want to mention here. When about a 45-year-old lady presented with generalized body pains and progressive weight loss of about 4-5 kgs, and on evaluation had a very high creatinine of 4.5 or something, and on labeling as CKD, when they went for biopsy, it was actually APS nephropathy, and on bringing back the history, she did have a high BP documented in her in the second pregnancy, which was probably had gone unnoticed, and it was only evident on the records. So Dr. Prasad mentioned this, and I want to just highlight that one of the famous novels of Dr. Chengappa, this particular character, the female lead in this, could be having a APLA, as we can know in any medical doctors when you read this book. I'll straight away come to this, I'll be rushing through some of them. These are the old criteria of antiphospholipid syndrome, and this has been very recently elaborated in 2023 ACR-ULAR criteria, wherein they have clearly mentioned as an entry criteria, and 6 domains they have kept, both clinical as well as lab domains. A score of 3 points from clinical domains and a score of 3 points from the lab domains, that is a score of 6, classifies it as IPS. So domain 1 is the macrovascular incidents, that venous embolism. Any patient, we have to think of these presence of, we should always rule out the presence of any active malignancy, long hospitalization, bedridden patient, major trauma, or a long surgery of more than 30 profile, CKD, diabetes, and hyperlipidemia. The microvascular focuses more on the skin in the form of the livedoid vasculopathy. These are the conditions ranging from the livedoid verticularis to livedoid acidosa. And presence of these kind of typical ulcers, which progress in these 4 stages, typically restricted to the ankle areas, and they are slow healing and recurrent non-healing ulcers sometimes. Then they typically heal with this kind of a atrophy planchia presentation. So, we know it can also have a cardiac valve thickening and valve vegetation. Sometimes it can typically mimic even infective endocarditis in these patients, and after even instance evaluation, repeated cultures will be negative. So one should suspect this in isolated cardiac valve vegetations or valve thickening in patients with this APS. So this is a very important criteria which has been given a separate domain of hematology, that is thrombocytopenia of 20,000 to 1.3 lakhs. Is an important point to be considered. In isolated presentation, ITP can be a pointer towards future APS. So as you can see, the extent of involvement of APS is from neurological involvement to the nephrology to skin manifestations. It's a very, very wide range. So I will now touch upon the 3 typical antibodies, that is anti-cardiolipin, anti-beta-2, and lupus anticoagulant. Traditionally, these are done by the ELISA methods and on automated platforms. There are also measurement methods such as chemiluminescence, flow cytometry, and multiplex systems. When you are testing for the lupus coagulant, one should make sure that there are no acute phase responses, and as there can be a false positive or negative results. And when the patients are on already warfarin kind of medicines, one should to take a gap of 1 to 2 weeks before we request the test. And in this duration, one can be switched over to low molecular heparins. If the patient is already on low molecular heparin, a gap of 12 hours should be there between taking between 2 doses before when you take the sample. Ideally, the sample should be taken before the next dose of the low molecular heparin. And if the patient is on newer anticoagulants, there should be a gap of 48 hours before we take this test for lupus anticoagulant. Otherwise, there can be false positives. So seronegative APS, as Dr. Chengappa mentioned in the morning, whenever this term, the seronegative arises, it doesn't mean there is no rheumatoid disease. It means that we have not gone deeper into investigating that patient, either due to financial constraints or more of reluctance, thinking that it could be due to alternative causes or belief in alternative medicines, those kind of beliefs. So we have seronegative APLA manifestations, which are very classical of them, but there are all these 3 antibodies are missing. So those things have to be kept in mind. So to address this, there was one score called as GAP score, Global Antiphospholipid Syndrome score, in 2014 it was published, wherein they included hyperlipidemia and arterial hypertension as the clinical pointers, and the anti-prothrombin and phosphatidylserine, that is anti-PS, PhD antibodies as well. In this, they give a weightage of 3 points for these things. So, very brief overview of the conditions, that is, when there is a venous thrombosis, we can usually we start the patient on the warfarin kind of medicines, and if it's a recurrent thrombosis, we usually start the antiplatelet therapies, and as Dr. Vinod mentioned, the group of immunomodulators from hydroxychloroquine to azacitidine, cyclophosphamide, etc. So this is the wider spectrum of the anti-APLA syndrome from cerebrovascular, pulmonary hemorrhage, musculoskeletal, and dermatological and neurological manifestations. So it is important for us to understand that the spectrum is beyond that. So considering geopolitics, I thought this cartoon was very apt. So it's just not about the pregnancy losses and also beyond that. A brief word about the catastrophic apula, which is just 1% of the cases, and here the mortality is very high, 50 to 75% of these patients eventually succumb. And we try to use all the possible methodologies, and it's a really great teamwork business at this. So let's keep all these things. So we need a really good guidance is what I wanted to tell here. So I hope I not touched too much, and so to summarize, APS is an autoimmune disease with very serious manifestations, and meant to have a good suspicion, a great suspicion before we think of this. As even a Guillain-Barré syndrome, a patient with stroke, a patient with epilepsy, seizures, recurrent seizures can be probably having APS. A patient with uncontrolled BP despite requiring multiple, this one patient having cardiac valves and vegetations can be an apula patient. So these are things I want to you to highlight upon. So managing these patients is actually a multidisciplinary task, but we should have a hematologist on team as well, a good physician, hematologist as a team, and depending on the organ involvement, the respective specialists will be there. So with good attention to detail, morbidity related to this complex and severe thrombotic conditions can be well contained. Thank you.
Dr. Mukya Prana Prabhu sir, Dr. Pavan sir, Dr. Abhinandan sir, Dr. Dhananjay sir to come on stage and give token of appreciation.
From JSSMC, Dr. Shreya Benita from Koims, Mangalore, and Dr. Sharmila and Pallavi from BMC.
The quiz will be conducted in the lecture hall number 1. That is just next to this hall, and there are other two sessions which are regularly parallelly. So the presentation, there is a case presentation session after the lunch. So we will be starting around 2:30, 2:45. Sessions are over at that time. Okay, so that is one thing. Second thing, there is a poster presentation also that will be in the lecture hall number 2. All of things are arranged. So please, the presenters be ready with all the presentations at that time.
As clinical masquerade, where early recognition can be the difference between reversible disease and irreversible organ damage. A structured approach to timely identification and evaluation is therefore critical in everyday practice. With this perspective, we now move on to the session on vasculitis, recognition and evaluation. It's a pleasure to invite our speaker, Dr. Ramesh Jois, Senior Consultant Rheumatologist, Rheumacare, Bangalore. This session will be chaired by Dr. Subramanian R, Professor and Head, Department of Rheumatology, JSS Mysore. Dr. Atish, Consultant Nephrologist, Assistant Professor, Department of Medicine, Koims. Dr. Harshvardhan, Professor and Head, Department of Dermatology, Koims. We request our chairpersons to please invite and introduce the speaker.
Sincere apologies to holding you all from lunch. I'm sure lunch would have been more interesting than vasculitis, but there we go. We have to do certain things, so we do. Vasculitis is a very advanced part of medicine and rheumatology. So I'm sure whatever I show you, a lot of things will be Greek and Latin for most of you. So I try to keep it as simple. I just want you to understand rheumatoid arthritis when you go out of this hall today, about the lab investigations. Even if you forget what I told you in the next 20 minutes, that's perfectly fine. I won't mind. But if you understand that there is a condition called vasculitis and how tricky patients can come to the OPD and why we should keep our antennas up, why our eyes and ears should be open. That is the only reason why this topic is included, because by no means do we expect vasculitis to be practiced by anybody else other than rheumatologists, because it's one of the most complicated areas of rheumatology. So what is vasculitis? Vasculitis means an immune-mediated inflammation and necrosis of blood vessels. Where are blood vessels in the body? Every bit of the body has blood vessels. So where can you get vasculitis? Every part of the body can be affected by vasculitis. So it's a multi-system disease. You have to have a high index of suspicion to suspect this disease. So generally we get referrals from physicians when they have exhausted all infections, when they have exhausted all diagnoses, and then they say, is this immune mediated, is this vasculitis, trying to look for something that nobody can explain. A delay in diagnosis can cause morbidity and even many a times death to the patient, because a lot of these diseases affect vital organs of the body, so the patient might die very soon. So hence one has to be aware of this disease. Even if you don't manage, at least be aware that there is a disease like this. And finally, these are diseases which relapses frequently. So if it relapses frequently, obviously you should know how to pick it up and how to diagnose and how to prevent these relapses, and hence make an early and appropriate referral. So this, whatever I have shown you, this is a blood vessel which has been necrosed, and you see a clot inside, lot of neutrophilic infiltration, and this is how vasculitis actually happens in various organs of the body. To understand vasculitis in a very simple way, we divide it into 3 groups depending on the size of the blood vessel that is affected. If the aorta or its large branches are affected, it is called large vessel vasculitis. And the typical large vessel vasculitis we see in India is something called Takayasu arteritis. I don't know how many of you have heard about it. The next, and the other one is called giant cell arteritis. The next one is medium-sized muscular arteries. This is your typical polyarteritis nodosa in adults and Kawasaki disease in children. Concentrate on something that is more common, that is small vessel vasculitis, which probably all of you need to know, because medium vessel vasculitis like polyarteritis nodosa is extremely rare, and large vessel vasculitis some other day we can speak. So what we call a small vessel vasculitis is called ANCA-associated vasculitis, because they are mediated by one antibody called ANCA, which Dr. Sangeetha briefly mentioned today morning. And this is a multi-organ disease and a potentially life-threatening disease. There are 3 types of these diseases. One is called GPA. Previously it used to be called Wegener's. The other one is called microscopic polyangiitis. And the third one previously was called Church-Strauss. Now it is called by a different name. The reason why all the scientist names came out of this classification was for 2 reasons. One, they wanted to recognize disease by the main pathological process that happens. So in the last disease, eosinophilic infiltration is more, so it got this name. In this disease, granulomatous formation is more, it got that name. And these are all, some of them were Germans. And they were all involved in dubious scientific research during World War II. So obviously their names had to be removed from history. So vasculitis can present to any specialty in medicine, in ophthalmology, ENT, obstetrics, you name it, anyone can see vasculitis. So I'll just show you, now what you're going to see is going to be a color atlas of rheumatology. That is what I'm going to show you. A lot of pictures about how vasculitis can present to each OPD. And that is all I want to show you today. So the skin, when you say vasculitis, when it affects the skin, the commonest presentation is that of petechiae, purpurae or red spots on the legs, something like this. Or it could be a bigger spots like this, and they are called palpable purpura. You can see here, most of these are my patients, so I have not taken it from any internet, most of them, otherwise I would have referenced it. Sometimes vasculitis can be very subtle, like what you see here as splinter hemorrhages, whereas sometimes vasculitis can be as gross as this, which is digital gangrene or non-healing, very bad ulcers. So these are some of the skin manifestations. So the dermatologist could be the first person who might, where the patient goes. So if there are any dermatologists in this crowd, I'm sure they would have seen this, but what is important is, one thing I always see, people write it as cutaneous vasculitis, do 1 or 2 blood tests, ANA, ANCA, negative, cutaneous vasculitis, treat them. That is wrong. Because the skin can be a mirror to an underlying disease that is going to happen, or it could be an indicator to say there is an underlying bomb that's going to explode from inside. So hence it's very important. The other common area where vasculitis is affected is the kidneys. And I'm sure the nephrologists will agree on that. And very important is kidneys do not give symptoms. So patients are asymptomatic. The only way to diagnose vasculitis in the kidney is by a very simple test called urine examination. So when I used to train in UK, I trained in a vasculitis center. My professor used to say, do a urine examination on a suspected vasculitis patient every day if they are admitted. That is because the labs do not take a urine specimen with seriousness. So many times you will find all sorts of reports when labs give out, but the patient might have urinary abnormalities. And what urinary abnormality? The abnormality could be as subtle as more than 10 RBCs per hyporphilia, proteinuria as less as 500 milligrams per day, presence of CAS. And it's important to understand that by the time you wait for the creatinine to go, many a times you would have lost half the kidney. So picking up these patients at a stage where creatinine is normal is important, and hence urine examination forms a very important part. And why is it so? Because in ANCA-associated vasculitis, the kidneys are commonly affected, and you get this condition called concentric glomerulonephritis. So there is this pathological hallmark called necrotizing crescents, which are there on a kidney biopsy, and it is important to pick it up on a renal biopsy, because if you don't do that, in a few weeks to months, the kidney is going to turn to this stage, which is called a sclerotic phase, where the kidney is already dead. And the nephrologist will tell you, once you reach the sclerotic phase, the kidney is gone. So many a times I see patients referred to me who had only skin rash many months ago, and they were treated by topical agents or a short course of steroids. Nobody bothered to do their urine examination. They would have done their creatinine or blood count, but by the time they come to us, the creatinine is 3, 4, and they're slowly inching towards dialysis dependency. So kidney is a very important organ, so urine examination is a very important test. The other presentation is that to the eye specialist. And one of the commonest eye presentations is something called scleritis. So you can see a painful red eye in this man. This man had scleritis. He also had mononeuritis multiplex and leg ulcers. He was taken to an Ayurvedic hospital, and he had a portcullis put on his leg for 3 months in an Ayurvedic hospital, and they very kindly gave him a bilateral foot drop by the time he came to me. So when I saw him, he had non-healing ulcers on the legs, bilateral foot drop, in a wheelchair, with this and a kidney involvement. So this is how vasculitis is neglected purely by not knowing what these conditions are. This is called nodular scleritis. You can see a nodule there. And if you don't pick these up, you land into this stage, which is called necrotizing scleritis. Normally you don't see this black thing in the normal eye. That is because the sclera has gone and the iris has prolapsed anteriorly. So this is very important to understand. This was a lady recently that I saw. Can you see these 2 yellow arrows? This lady has bilateral lacrimal gland enlargement, and she had a bilateral scleritis. And in fact, I'll show another important photograph of hers, because she had multiple organ involvement when she came to. So this is another presentation. Can you spot anything in this lady? Any of the students, even though you are hungry, can you see what is wrong with this photograph? Anybody can pick up this clinical sign?
No, Ptosis on the right side.
Sorry, say again. I can't hear. So, what is important in this lady is she's got a proptosis in this, not a ptosis in this leg. There's a proptosis. You can see that the white portion of the eye is more seen. That lady had a subtle proptosis. Then once I sent her to the ophthalmologist, we confirmed it, and then we did a CT scan. She had a retroorbital mass. So this lady had a retroorbital mass, And when we were talking to her, taking a history, I'll show you her scans in the next few slides later on, she had something else. So eye can be a window to saying that there is a systemic disease, and these are some of the examples. The GI tract is another area. This is one of my patients who had lung involvement in the past, adequately treated for a good few years with rituximab, was doing very well. Then we switched her on to azathioprine because 4 or 5 years she didn't have any problem. And then she told me that she had very painful swollen gums. And what you see is what we call as typically strawberry gums. Strawberry gums or severe gingivitis. If you biopsy this, you will find granulomatoous vasculitis. So vasculitis in the gut can start from there right until the colon. And this is one of my patients with eosinophilic granulomatosis or EGPA who had GI bleed. She collapsed in the bathroom, brought to the casualty with a hemoglobin of 4 because of massive melena, and a colonoscopy revealed multiple aphthous like ulcers, bleeding ulcers, and a biopsy confirmed vasculitis. Certain types of vasculitis affect certain parts more. So Wegener's or GPA likes cartilaginous parts of the body, and what you see here is the pinna being affected. You can see that perichondritis. So vasculitis can go to ENT doctors also. This lady also had recurrent serous otitis media. She kept on having otitis again and again, and then she had nerve involvement. You can see the hearing aid, and she was only treated as deafness, antibiotics once for this, and treated as presbyocusis or age-related deafness, and nothing else was looked at. This lady had recurrent nasal epistaxis or nasal obstruction, and you can see the collapsed bridge of the nose, what we call a saddle nose deformity, and all these ladies had GPA. I had earlier shown you the photograph of the lady who had mild proptosis. This lady on detailed history taking had inspiratory stridor, and when we did CT of the airways, she had laryngeal involvement. This is called subglottic stenosis. Under the vocal cord, she had severe narrowing of her airways, which is what she had, and this is the demonstration of that. This is a bronchoscopy. Dr. Ravindran did it for me to estimate the severity of the problem, and you can see that there is severe airway narrowing. So once we treated her medically, fortunately she didn't need laryngeal dilatation, otherwise they will need steroid injections to the subglottic area, dilatation, so on and so forth. So, this is one of them. Airway involvement is also very common. This lady, once again, the one in the top photograph, had recurrent nasal problems, went to multiple ENT doctors, multiple biopsies, had demonstrated CT scans. You can see that all the sinuses have disappeared and there is a hollow cavity inside her nose. And in addition to that, one of the biopsies led to a collapse of the inner labrum, so the nasal bone, and you can see that she had an iatrogenic fistula that was created because of repeated biopsies, because people could not understand her diagnosis. And when we examined her more and probed, she had bilateral bronchial stenosis. So airway involvement is very common in GPA, and one has to be very meticulous when you see these patients to pick up these subtle manifestations. And we had to put in a stent. This is the wire what you see in the airway is a stent into the bronchi, one of the bronchi. So vasculitis can be as complicated as this. And eventually this lady died due to recurrent respiratory infections, because once you intervene the airway, put a lot of airway stents into her, the risk of infection is huge. Lung is another involvement. So obviously vasculitis patients can present to pulmonologists with multiple cavitary lesions, and in India the most important cause for cavitary lesion is tuberculosis, not vasculitis. So when you have a patient with or bacterial, whatever, depending on whether it's acute or subacute. So when you have a patient with multiple cavities, all precautions should be taken to exclude infections. So hence this patient had a bronchoscopy, a lavage, sputum examination, and the cavity there, a thick-walled cavity, a CT-guided biopsy was done because it was easily accessible. That demonstrated a necrotizing cavity, and she had GPA. So these are other patients who had either consolidation, non-healing consolidation, which would not respond to antibiotics. Patients were still sick and a biopsy confirmed. So here, these are various examples of lung involvement. Sometimes the patient who de novo, that is without anything, can come to the casualty completely breathless. Or you have a patient who already has vasculitis, you're on treatment, again comes to breathless, comes to the casualty breathless. And you see x-rays like this. This is one patient with diffuse lung shadows. This is another patient. This is third patient. I've had some of 3 or 4 of these till now. And these patients, obviously the first thing you think of is infection. You don't think of rare things first. You have to rule out an infection. And then when you start looking up deeply, then you look for vasculitis. Then you look. This condition is called diffuse alveolar hemorrhage. This is an emergency in rheumatology or in respiratory medicine. You will see this sometimes de novo or sometimes along with kidney involvement when it is called pulmonary renal syndrome. And this is the CT scan of one such patient demonstrating what we call as a whitewash lung, or complete lot of opacities in the lung. And obviously there is no characteristic CT scan features to say this is alveolar hemorrhage, but you have to exclude infection by all possible means. Sometimes that could be very difficult because these patients will be desaturating, and doing a bronchoscopy on a desaturated person is a real challenge. If they go on ventilator, it becomes easy for us because then you can do a bronchoscopy. Otherwise it becomes very difficult. So some of these are very difficult to manage. And this is one such patient of mine where fortunately we were able to do a bronchoscopy. The bronchoscopy showing a lot of blood in the airways. And this is called pearl stain, which shows hemosiderin-laden macrophages. This is called diffuse alveolar hemorrhage. And the same patient had a rapidly progressive glomerulonephritis, and the renal biopsy of this patient showing RPGN. So this is a classical pulmonary renal syndrome, but this is rare, fortunately rare, but you have to keep in mind in general medicine or in pulmonology or in nephrology, when you have a sick patient coming in with these lung shadows and they have proteinuria or hematuria on a urine examination. Neurologists should also be familiar with vasculitis. Why is it? Mononeuritis multiplex is a very common cause of neuropathy in vasculitis patients. What you see here is, anybody? What is this? Claw hand. It's an ulnar claw hand. What it shows is an ulnar nerve involvement. The same patient had a foot drop also. This is a patient who can dorsiflex this foot, cannot dorsiflex this foot. You can see a gangrenous wound in the tip. So this is a foot drop, a unilateral foot drop with a digital gangrene. This was a rheumatoid patient who had stopped treatment and developed rheumatoid vasculitis. This lady eventually found out to have a rare vasculitis called craglobulinic vasculitis. This is from the textbook, bilateral foot drop with digital gangrene. So mononeuritis multiplex, you have to very carefully examine a patient with vasculitis, pull off the bed sheet, ask them to at least move their hands and feet if you are not able to do a detailed neurological examination. This was the earlier lady that I showed you who had a bilateral lacrimal gland enlargement. Can any of the medicine final year PGs or MD students or house surgeons tell me what is wrong with her face? Bilateral element, seventh nerve palsy. You can see bilateral Bell's phenomenon. You can see that there is an expressionless face, and you can see she can't purse her lips. That lips is open all the time. So she had bilateral facial involvement. She was stone deaf, and she had that lacrimal gland involvement. That was her presentation to me. Once we gave her steroids and rituximab, her facial palsy is improving. Her lacrimal gland enlargement and scleritis is improving. Her hearing has also improved. So many things have improved. This is how she was brought to. Finally, rarer presentations in vasculitis. Vasculitis doesn't spare any part of the body. And this was one of our patients who presented with recurrent headaches, who went to the neurologist, and an MRI showed a contrast enhanced pachymeningitis, and this pachymeningitis has wide differential diagnosis, and this patient was ANCA positive, but anyway I'll show you the biopsy slides later on of this patient. So a biopsy was done to confirm, because pachymeningitis could be chronic infections like fungus, TB, sarcoid, malignancy. There is a wide range of differential diagnosis, and nowadays IgG4 disease, and last also comes, but not the least, vasculitis, because outcomes are completely different if you make a diagnosis. This is one patient who came to me from Mysore. Dr. Shiv Prasad remembers this lady. Thrombosis can be a presentation in vasculitis. Vasculitis patient can present with the DVT, this patient can present it with this unusual presentation. Can anybody spot what is there in this? There is a clot. There is a apical clot. So this lady actually died of a massive clot. She had an intracardiac clot. In addition to renal involvement, scleritis, vasculitic rash, a young girl. So this is a thrombosis here is not the typical thrombosis that you see. It is an inflammatory thrombus. So here the treatment differs because you have to immunosuppress this patient and not anticoagulate the patient. So this is one other one whom we lost. So the last two slides, I've just shown you a whole spectrum of presentation of vasculitis, starting from head to foot. But vasculitis continues to surprise us. There could be single organ back as vasculitis. I have seen patients presenting as single organ involvement, only one organ, nothing else. I have seen patients presenting with multiple organ involvement everywhere. So the patient can go to any of the specialties in medicine. So everybody has to be aware that if you don't understand what is going on, if you are not able to explain usual things, then start thinking of unusual things. So if there is somebody with recurrent scleritis, recurrent uveitis, recurrent otitis, recurrent sinusitis, recurrent nasal polyposis, recurrent rash, recurrent opacities in the lung, not responding to your antibiotics, unusual pneumonias, think of vasculitis. Okay? Investigation, we don't have too much to say. There's only one test called ANCA. I won't elaborate too much on this because Dr. Sangeetha already spoke about this briefly. But just there are two patterns based on immunofluorescence. One is called C, the other is called P. C ANCA has a stronger association with Wegener's or GPA. P ANCA has a stronger association with NPA and can be positive in about 40% of EGPA or Church-Strauss syndrome. When positive in the right clinical situation, who has severe scleritis not responding, and you have an ANCA positive, then the diagnosis of vasculitis is high. If you have somebody who went to some lab for routine blood test, they did a rheumatology profile, and you found that the ANCA is positive, but they don't have any major symptoms, then your probability of diagnosis of vasculitis is less. So, just mere presence of test does not give you diagnosis. But if I find somebody who has certain symptoms, but they are strongly positive for the antibody, then I will closely watch these patients. I will call them for regular follow-up. For the simple reason that whatever I showed you, people will not present with all this on the first day. These rheumatological diseases are evolving diseases. Today they will come with arthritis. In another 2 months the urine examination will show proteinuria. In another 2 months they will have a cavity in the lung. So just keep watching these patients for manifestations. And this statement was also made by Dr. Sangeetha that serological test is not a confirmatory test, it's a suggestive test. What you need is a biopsy. So as far as possible, the involved organ should be biopsy. Whether it's the nose, whether it's the kidney, whether it's the lung, whether it's the nerve. Because once you give a diagnosis of vasculitis, you put a stamp on his forehead, it's a dangerous diagnosis to give for somebody all their life. So histopathological proof is very important because there are a lot of infections that can mimic vasculitis. I won't go into the details of that, but these are some of my patients. This was a nasal biopsy showing necrotizing vasculitis. That was a kidney biopsy showing plesenteric. This is the bowel biopsy, the colonoscopy that I showed. The same person also had small bowel. This was eosinophilic enteritis, which is seen in Church-Strauss. So biopsy is important. This was the pachymeningitis patient that I told you. The patient underwent a dural biopsy which showed vasculitis. So based on all these things, sometimes we try to group them into these three clinical phenotypes, but many a times we may not be able to group them. There can be a considerable overlap. If there is upper airway, lower airway, kidney involvement, commonly it is GPA. Sometimes these patients will also have cutaneous, nerve and other things. If a patient has predominantly renal and pulmonary and neuropathy and skin, it is MPA. If a patient has a previous history of allergies, asthma, nasal polyp, but cardiac involvement along with pulmonary, it could be EGPA. Cardiac involvement is very rarely seen in these two, but more common in this type. Presence of eosinophilia. Eosinophils are very steroid responsive cells. So if somebody is already given even 20 milligrams of prednisolone before the patient sees you, the eosinophils disappear. You will not find the eosinophils. So you need to find a report which the general practitioner or a dermatologist might have done, which might show eosinophilia before the steroids were given. And biopsy is the key. So to sum up my presentation, vasculitis is a relatively rare disease. It's not so common compared to what you have heard throughout the morning, but once you see a patient of vasculitis, you will never forget, because it has huge implications in terms of morbidity, and many of these manifestations can be very destructive. I mean, I have loads of pictures of vasculitis. I can show you complete nose being completely destroyed, a big hole created here, mainly because of lack of awareness amongst specialists, because nobody would have thought of vasculitis as a diagnosis, or they would have pinched a biopsy and the biopsy would have been just reported as chronic inflammation. So even if the physician doesn't suspect vasculitis, the pathologist also does not suspect vasculitis. So when you send the specimen, you have to tell them look for vasculitis, because as much as you would not have seen vasculitis, the pathologist also would not have seen vasculitis. So because these are relatively rare diseases. So high index of suspicion, these patients would have high risk of relapses, multi-system involvement. Whichever specialty, at the end of all this, if you are bored of rheumatology and take up some other specialty after today's CME, still think of vasculitis, because you may be one of those patients who might see the eye, the ear or whatever. And ANCA is an important screening test, because if you get high titers, it is very suggestive. It makes you think of vasculitis, but if it is negative, it doesn't rule out the disease. But biopsy of the involved organ is crucial, and vasculitis patient, this is one disease where I say has to be referred to a rheumatologist. Nobody else should be looking after. Because today the presentation may be kidney. If you're not aware of airways, how to assess airways regularly, tomorrow it might shift to the airways, and that's silently good progress. Thank you very much for your patience.
Systemic lupus erythematosus demands a high index of suspicion, and timely evaluation is key to preventing long-term morbidity. Bringing us to this session on SLE, when to suspect and evaluate. This will be presented to us by Dr. Gangarathna, Consultant Rheumatologist, AJ Hospital, Bangalore. We request our chairpersons to please invite and introduce our speaker.
Neurological disease, vasculitis, and SLE, the heroine of the chapter, to begin.
As such, you know, it is how to evaluate lupus. It is mainly case-based, so I have put a lot of slides. We all know it's wolf. Dr. Kezinev in 1851 noticed patients with red rashes on face which looked like wolf bites. So he called it discoid lupus erythematosus. 3 decades later, Sir William Osler noticed patients with such rash developed multiple system involvement. So he rightly called it systemic lupus erythematosus. So it is since this we have been using the TAT. So I will not go in detail about the classification criteria. The first classification criteria that we used was ACR 1997 classification criteria. So if patients had 4 out of 11 criteria, which had skin criteria, systemic criteria, and laboratory criteria, they would be classified as systemic lupus erythematosus. Then came the slick revision of the ACR criteria in 2012, which was more specific, which had renal biopsy as a separate classification criteria for lupus, or the other clinical criteria were at least one clinical criteria with at least one laboratory criteria. So this included more laboratory tests, including antiphospholipid antibodies, complements. So the most latest that we all use, and you as PGs or interns should be aware of, is the EULAR ACR 2019 criteria. So all these, what they suggest is that lupus is a multi-system disease. So we as rheumatologists have a systematic approach. We know at the end of this session that all rheumatological conditions, especially vasculitis and lupus, are multi-system. So if we are suspecting, our history taking, that's where we all start. Has to be thorough and has to be systematic and has to be from head to toe. So quickly we have developed our own skills. So ask for hair loss, headache, oral ulcers, skin rash. I have named all of them mostly: arthralgias, arthritis, fever, which again is very important, and a loss of appetite, many cases of pyrexia of unknown origin, and other systems like lungs, eyes, kidney, you name it, it is possible. Patients with repeated recurrent DVTs, pulmonary embolisms, strokes, miscarriages, all these history is very important, because we can only investigate and prevent any future loss if we have done this job thoroughly. So based on what the patient presents, I am going to now only present slides of the patients that I have seen in my clinic. So this is a patient who is a case of SLE. Evaluation further, we came to know that they have had repeated, anemia episodes and so on and so forth. So same patients, after waiting for a long time in AC room, we can appreciate, that they have Raynaud's. So patients may not notice, we have to look for this. As sir previously said, lupus is not just about females. So this is a boy patient of mine who is 17-year-old who has had viscoid lupus erythematosus. You can see the scarring alopecia, non-scarring alopecia, and the rash, which is again in the photosensitive distribution, mainly covering the upper V and back of the neck. And sometimes the rare presentations do occur. This is a patient of mine who is 15-year-old girl. Her original presentation was more or less like a PEO, and then on treatment of low-dose Visolone and hydroxychloroquine, this patient started developing what we call angioedema features. So this is worrying. She had swelling of her lips, swelling of periorbital edema, but luckily no major stridor or all the the C1 esterase assays were done, they were all negative. So symptoms eventually settled after increasing her steroids, increasing her immunosuppression. So lupus is a great mimic. It can come as anything, and all these individual slides will represent a patient who is unique and rare. So this is again lupus presenting as a small vessel vasculitis. So the difference here was again a young girl with repeated episodes of what looked like enochiolin purpura, but afterwards we realized that it is a lupus after the kidney biopsy, etc. So this is again, I'm trying to involve my male patients as well to be gender equality and also to say that lupus does not affect only females. So this patient was already on dialysis when we saw him. Basically he came to AJ hospital because he developed significant petechiae, purpurae and all this blood in his mouth, and the counts were very worrying and platelets were in the region of 2000. So what has happened is he was a missed case of lupus to begin with. Ultimately we found that he is a lupus who has developed pancytopenia and ITP basically. So this is a patient of mine who's developed digital digital gangrene. So her first presentations were this, that she developed, not as severe as the previous pictures, but repeated episodes of digital gangrene, which responded to immunosuppression. So all these manifestations are also possible in lupus, not just the malar rash, discord rash, oral ulcers that we keep discussing about. So the tests are, because our most of the rheumatological conditions are multi-system. Tests are involving what the relevant organ of we are suspecting to be involved. So the routine test, CBC, liver function, creatinine, urine, everything is compulsory. Apart from which, if patients have developed loss of weight, loss of appetite, you do peripheral smear, you look for excluding malignancy. So many times we have ended up doing PET CT scans. Biopsy of course is mandatory for wherever we are suspecting lupus nephritis or vasculitis. Imaging is very useful. Sometimes we do, starting from the ultrasound of the joints, just to explain, is it just effusion, is it a tenosynovitis, or is it something else. And we also, this antibodies has been covered. So when we suspect lupus, without talking about ANA, it is like a half-done job. So ANA by indirect immunofluorescence is the first test that we do, followed by ANA profile and C3, C4, and also APLA test if relevant. For most of our patients are in the childbearing age group, so if required, we also do the other antibody test, even if we are suspecting the patient to be a lupus patient. So from simpler cases too, I want to highlight about 2-3 little more complicated cases. So this is a new diagnosis of lupus which I managed in a priming gravida patient. She was 28-year-old. When I saw her, she was 10 weeks pregnant, priming. Her features were mainly ongoing, tiredness, fever, joint pain, swelling, loss of weight, breathlessness. This is common in all pregnancies. But the thing that clinched was the test. She had severe pancytopenia, raised inflammatory markers. Urine analysis showed significant blood and protein. So whenever we have such patients, we have to exclude infection first. So in any patient that you are suspecting is to be a rheumatology patient, do a septic screen, blood cultures, urine cultures, chest X-ray quickly. She was transfused repeatedly, but the transfusions failed because she had ongoing hemolysis, and ultrasound showed bilateral pleural effusion. So that's when the diagnosis of lupus was thought, and she was a confirmed cases of SLE with lupus nephritis. We all give pulse steroid when we suspect such scenarios. As Sir said previously, the life of mother who is our patient is our first priority. So the focus was only to save her, and significant counseling was done because they were not rich enough to afford higher hospitals and higher treatment. So they opted for the MTP and cyclophosphamide. Then we started on mycophenolate and hydroxychloroquine. As you know, all these medicines are not suitable for pregnancy. So careful pregnancy planning is very much required. She continued on these medicines for 18 months, and then she decided that we have monitoring her complement levels, blood tests. When we felt that she is ready to conceive, she did after giving a rituximab, and she's had a successful male child delivered 6 months ago. This is a case of significant jaundice in a non-SLE pregnant patient. So the previous patient was a pregnant patient at 10 weeks of pregnancy, new diagnosis of SLE. This patient is already a 29-year-old known case of SLE. She developed jaundice at 29 weeks of her pregnancy. So we know when patients have had the diagnosis, we do the counseling, we start them on the medications that are suitable for pregnancy, and she does not take any other herbal medicines or anything to cause jaundice. So infection screen, virology screening, everything was negative. What signified was the significant low complement levels. So we also stopped her hydroxychloroquine and azathioprine, although they are not known to cause sudden sudden increase of bilirubin levels. To cover for drug-induced, the steroids were increased. Gastroenterologist gave her ursodeoxycholic acid. Luckily, it was decided as a team that we wouldn't, subject her for cesarean immediately. Just on tapering doses of steroid alone with all the teamwork, she improved, and at 40th week, the elective cesarean was done, and both did well, mother and baby. So, what I want to highlight is any patient can be a lupus patient if the symptoms, what Sir earlier said, if the symptoms are recurrent, if the symptoms are multi-system. So these are all the prevalence of different studies will quote different, but we all know nephritis is by far the largest, the complication or the manifestation, which is significant, serious risk to life. The other things are as explained here, vasculitis, myocarditis, mesenteric vasculitis, so on and so forth. So this is a slide of on management. What it highlights is basically we all aim at the remission of the condition that the patient is in. If remission is not possible, the lowest disease activity. So the SLEDAI score is one of them. If you want to, have a read about it. So management of lupus involves the management of comorbidities. These have been already covered. So if there was a previous history of miscarriage, we do for APLA testing, cover enoxaparin, ecospirin, etc. Cover for infections, which our colleagues talked about earlier, immunization, manage cardiovascular disease. So key point is, as I repeatedly told, lupus is a great mimic system. It is a multi-system involvement, condition. So suspect lupus whenever it is recurrent, multi-system, not responding to standard care of treatment. So the management has to be multidisciplinary. We all have to follow strictly the basic thorough history taking, thorough examination, and then relevant investigations. We have to screen them for early organ involvement, and we have to make sure that adherence is key, because I just can't change the treatment looking at the values. The values are flare up because the patient is not adherent to treatment. So we have to address their psychosocial issues. So this is again, better done by a specialist, and we have to all work in as a team. When in doubt, let's ask each other, let's help each other. Thank you very much. There is World Lupus Day on May 10th, just for quiz or any other thing that you are, appearing. This was when I came back from UK 4 years ago. The clinic had very few lupus patients, but still we did the Lupus Awareness Day. Thank you.
Dr. MC Karyappa sir, Dr. Somshekhar sir, Dr. Purushottam sir, Dr. Mohanappaji sir, and Dr. Lokesh sir to give away the token of appreciation to our speakers, Dr. Ramesh Jois sir and Dr. Gangarathna ma'am, as well as to our chairpersons, Dr. Harshvardhan sir, Dr. Atish sir, and Dr. Subramanian sir. Koims to please propose the vote of thanks.
Will be here only. The other poster presentations will be lecture hall number 2. Quiz will be in lecture hall number 1. So that is this one. We will start at 3 o'clock maybe.
Vote of thanks on behalf of the Department of General Medicine at Koims. So in his absence, I would like to extend my heartfelt gratitude for a guest of honor, Dr. Manta Gowda sir, Honorable MLA Madikeri, who could not be here today with us. We thank him for his support. My sincere thanks to our organizing chairman and the beloved Dean and Director, Dr. Lokesh AJ sir, for his visionary leadership, constant guidance and support. I also express my sincere appreciation to Dr. Somshekhar sir, Medical Superintendent and Professor and Head Department of OBG Koims, for his valuable presence and support. I would also like to thank Dr. Subramanian R, Professor and Head of Department of Clinical Immunology and Rheumatology, and Dr. Prasad B N, Associate Professor, Department of Rheumatology, for their planning and support for the success of this event. A special note of appreciation and gratitude to Dr. Vinod Ravindran sir, the President-elect Indian Rheumatology Association, for their education and enlightening us with these valuable inputs. I extend my sincere gratitude to all the esteemed speakers for sharing the valuable knowledge, clinical expertise, and wisdom. I'd also like to thank all the delegates who participated and all the postgraduates for the active participation. Furthermore, an event like this wouldn't be possible with a solo effort. I want to express my deepest gratitude to the people working behind the scenes, to all the dedicated volunteers, staff members, and entire organization.
My name is Dr. Vinod Ravindran from Organization of Medical Science. Listening twice, how reassessment unveiled a hidden systemic illness. Coming to patient particulars, 23-year-old female, Mr. XY, from Arsikere Assam. She is educated up to high school and homemaker by occupation. She first presented on June 25th due to fever since 1 month, which was low grade, intermittent, not associated with any chills or virus. She also presented with cough since 1 month, which was progressive, associated with the mucoid sputum, which is about 1 to 2 teaspoonful, and non-foul smelling and non-bedrest also since past 2 days. It used to relieve by rest and upright position. It is not associated with any orthopnea preventing. She also presented with facial puffiness since the past 15 days, which is more worsening in the morning with associated bilateral lower limb swelling. Coming to past history, she had no previous comorbidities. Her obstetric score was para-1, leaving 1 with 2 abortion. Her first pregnancy ended with a full-term normal vaginal delivery, followed by 2 spontaneous first trimester abortions. Coming to examination, our vitals were BP was 140 over 90 mmHg with a pulse rate of 106, saturation of 92% on room air with a respiratory rate of 24. On general physical examination, she had a pale facial puffiness with a bilateral pedal edema with ulcer over the buccal mucosa. Systemic examination was normal except for the bilateral basal crepitation, which was added in the respiratory examination. Coming to laboratory findings, our hemoglobin was 9.39%, platelet was 58,000 with elevated inflammatory markers with a BNP of 1,200. Our X-ray showed bilateral perihilar opacities and echo showed a global LV hypokinesia with the LV ejection fraction of 38%. And our kidneys are normal. To sum up, here is a 23-year-old female presented with fever, cough, breathlessness and pedal edema. On examination, she had a mild hypoxia, tachypneic with pallor and bilateral basal crepitations on systemic examination. And our laboratory examination showed a bicytopenia with elevated BNP and LV dysfunction. Based on all these findings, we can come to a provisional diagnosis of acute pulmonary edema with a heart failure with reduced ejection fraction. Now let's pause and think for a minute. Is this patient is really having a heart failure, or something else we are missing here? It is very unusual for a young female patient with no risk factors, no comorbidities and no significant problem that has brought the patient to us. But it has raised a suspicion that some chronic process might be going on in the background. So what we did was, we tried to work up further. Initially the patient was in emergency and we took a brief history from the patient. Later when we elicited a collateral history from the patient, husband and our mother, they told that she used to get arthralgia which was intermittent, symmetrical, mainly involved in the large joints. She also used to get a recurrent oral ulcers, facial rash and a diffuse hair loss. And when we again reviewed the investigation, it showed a bicytopenia with hypoalbuminemia and a urine analysis showed a albuminuria. So, by connecting all these missing points, we came to conclusion that the patient might be having a chronic systemic disorder which may be going on since the past few years. Since the patient had hypoalbuminemia and albuminuria, later we sent the ANA profile and the titer was elevated with a 1:100 ratio and the ANA pattern showed a nuclear homogeneous pattern. Patient later underwent a renal biopsy. This is the slide showing the biopsy. Here we can see the endocapillary hypercellularity with enlarged glomeruli. This is the another slide showing wire loop lesions and a segmental endocapillary hypercellularity. the slide the MAC and trichome strain. Here we can see the subendothelial hyaline deposits. After the biopsy, the final diagnosis is systemic lupus erythematosus with the class for lupus nephritis with associated lupus myocarditis, autoimmune hemolytic anemia, immune thrombocytopenia with the symmetrical polyarthritis with the mucocutaneous involvement. Later, the patient is induced with the steroids and cyclophosphamide, and the optimal response in proteinuria is achieved with the urine albumin creatine ratio at 3 months is 1.1. And later she maintained on the mycophenolate, ACE inhibitors and low dose steroids. This is the table showing the cumulative prevalence of SLE manifestations.
Anything else you want to tell? And we found that she had a low ejection fraction and urine protein was positive. What about C3, C4 levels?
C3, C4 level was low.
Was low. Complement levels were low. So history-wise, retrospectively, you got the history of joint pain.
Yes, sir. Initially, the patient presented like a heart failure symptoms. Initially, when we took the history in the...
Was it a heart failure or was it a fluid overload? X-ray you didn't show. X-ray was not there. Fluid effusion was there. Because you are
there was no feature suggested.
What about the cholesterol levels?
Normal, sir. Cholesterol level was normal.
Cholesterol was normal. So, kidney biopsy showed lupus grade 4.
Grade 4.
Nephritis. Okay.
The take-home point is the patient presented with the myocarditis, like heart failure symptoms, but this is the prevalence of major organ threatening involvement is very less.
What heart involvement is more common in this setting? Is it a myocarditis or is it something else?
It's endocarditis.
Endocarditis, what is it called? But what you tell here? Is it that common or more common than that?
She's fluid overloaded every time. So what do you expect in the heart?
After dysfunction.
Fluid around the heart.
Pericarditis.
Pericarditis is more common.
Did you just go back to the diagnosis slide? Did you miss anything here? You were taking something in the history. I think you missed it. 2 abortions you said. So, yeah, 2 history of spontaneous abortions.
So recurrent abortion.
What does it indicate?
Placenta.
May or may not be, but I think you have to bring it up because it's an association. So there is something. So never miss the whatever you have got historically. And it would be nice if you had got the oral ulcer photograph or something like that. And go back to your treatment you said. Next slide. Next. Management. Management slide. So, yeah, you have written optimal response. What would be the normal proteinuria? Or what is the normal level of protein that you would expect?
So less than 500.
So, do you think you have achieved an optimal response?
Sir, by the end of 3 months, there should be a 25% reduction in the during proteinuria. By the 6 months, it should be at least 50%. By the end of 3 months, she achieved more than 25%.
So at that point you changed it to maintenance, is it?
Yes, sir.
You should continue to induce for 6 months. Unless you have... What was the cyclophosphamide dose you used?
500 mg.
And how frequently did you give?
Monthly, sir.
500 mg monthly.
3 doses.
No, sir. She's receiving
Cyclophosphamide 3 doses.
6 doses given.
15 days apart. Okay. So when a young lady presents to you with fluid overload, what is your DD?
The most common is heart failure. Second, polycirrhosis.
Okay, anything else you want to give to this patient other than mycophenolate and or cyclophosphamide?
The presentations if you have attended, they would have told. And all patients with lupus should be in some
They should receive a vaccination.
No.
Vaccination anyway.
What other drugs do you use for lupus?
Immunosuppressants was glucocorticoids and can give mycophenolate or cyclophosphamide. And we can also use the triple therapy with bevacizumab.
What is the basic drug? So if you look around the banners that are displayed here.
Steroids.
Look at that banner, the first banner and the first drug.
Safest and
the take-home message should be all patients of lupus should be on hydroxychloroquine regardless of the next patient of lupus you do, whether you see the patient properly or not. If you're starting hydroxychloroquine, you've done some justice. That's what we think as importance. Anything else?
the heart failure. What was the question? Treatment was you have not written any treatment for heart failure. Was she on diuretic? AC inhibitors you have written.
Sir, initially we started on diuretics. Sir. Once she improved.
And the only other thing is PTA, PTT didn't show. Was she having a Apla syndrome or this thing, those things which are mixed because women, SLE, pregnancy loss, Apla, and she may be required to be on anticoagulation and aspirin. Okay, so always look for the one is Apla and we need aspirin and aspirin is difficult, but steroids, anticoagulation may be required.
Aspirin may be required because she looks like a high risk category, 2 abortions and all. Even if you don't have the APLA reports on hand right now, she's SLE, lupus nephritis, cardiac failure, so she might be a risk candidate for thrombosis. Even if you don't have a proven thrombosis, don't need to start anticoagulation. But antiplatelets, I don't think there is any contraindication. Nothing. Okay. Thank you so much. So just mark it out of 30. Can we have Dr. Karthik from KSA?
I am Karthik and I am from KSA Timecode. Today I am presenting a case, interesting case under the title Pericardial Tamponade as initial presentation of OCTD, a diagnostic pitfall. So on one fine night we have one 35 years old female arrived at our ER with progressive dyspnea and chest pain since 1 month, worsened since 4 days. She was diagnosed as the pericardial tamponade elsewhere and referred for further evaluation. On arrival, her vitals are like heart rate, she is tachycardic, tachypneic as well as almost borderline hypotensive. And she is very restless. Her heart sounds are muffled and JVP is elevated. So with 2D echo confirmation, we have diagnosed her as cardiac tamponade. Upon taking detailed history, she has amenorrhea since 9 months and hyperpigmented scaly plaque since 6 months, as well as constitutional symptoms along with dysphagia as well as weight loss since 3 months. On examination, we got paler cervical lymphadenopathy, which are form mobile, non-tender, and spindling type of CTD phenotype, as well as some intermittent emotional liabilities with the HMF intact, and distal wasting present in the lower limbs, as well as vibration being lost up to ankles and joint positions and lost up to toes. So, based upon the history as well as the presentation, our differentials would be as well as usually immune versus infection versus malignancy. In immune mediated, I would like to consider RA serositis, SLA serositis as well as overlap CTD, and infectious predominantly tuberculosis and malignancy any neoplastic effusion. So based upon this, we have worked up, and pericardial analysis showed exudative in nature with increased ADA. Initially we considered TB, but CBNAT was negative, which reduced the probability of TB, and malignant cells are absent. And protein electrophoresis was done to rule out any plasma cell dyscrasiasis since she has AG reversal as well as proteinuria, and followed by bone marrow, which showed only reactoplasmocytis and anemia of chronic disease. And CT chest showed pericardial and pleural effusions and lymphadenopathy and pulmonary artery dilation. And neuroconduction objectively showed she had sensory motor neuropathy, predominantly sensory. So serology, in view of multi-system, we did serology. Both complement levels are reduced. ANA is positive, greater than 1:80, as well as nucleus homogeneous pattern. And anti-CCP is highly positive. And the ANA profile revealed a lupus spectrum autoantibodies like double-stranded DNA / nucleosome and histone positivity. This is strong ROLA positivity, but U1 RNP is negative. So based upon this diagnostic integration by applying classification criteria of 2010 ACR and 2019 EULAR, the RA score will be around greater than 6. It is in this patient it is 8, and SLE classification criteria it is 22, greater than 10 is the, and disease activity score is very high, 28. She fulfills both RA and SLE classification with the double standard DNA positivity. But UL-RNP is negative, so we would like to consider it as overlap CTD. And my final diagnosis will be overlap CTD with polyserositis as well as neuropathy and other multiple systemic manifestations. Therapeutic approach is emergency. We tried pericardiocentesis with pectoral drainage and we have stabilized her. After diagnosis, after arriving at diagnosis, we have given her pulse therapy and we have stepped down to oral steroids followed by mycophenolate mofetil. And additionally, we have added HCQs once she tolerated well. After that, we have discharged her after stabilizing her and we have advised us to follow up for steroid tapering and further serial 2D echo monitoring. So the key learning outcomes here is cardiac tamponade is very rare in patients, but still it can occur. In India, we usually often label every effusion as TBR malignancy, but we should consider immune-mediated polyserositis also. Pericardiocentesis is life-saving, we should not delay it. But after doing the pericardiocentesis, we should work up for serology to prevent reoccurrence, and we should also start steroids if it is proven to reduce recurrence and organ progression. Lupus activity, because RO and LA are strongly positive.
RA is positive, can occur in lupus?
Sir?
It's only purely lupus. Why can't it be pure lupus?
Because we have anti-CCP also highly sensitive. I have said anti-CCP is highly positive.
In your neurological, okay. And what kind of connective tissue disease this neuropathy is common?
Sir,
that's what I thought. Is it SLE neuropathy is common, or is it MCTD, or is it scleroderma?
It's related to SLE.
SLE neuropathy is common, or what are the neurological manifestations of SLE?
Neurological manifestations usually some emotional liabilities as well as objective neuropathy.
Seizures, headache. Okay. Again, what you say, neuropathies are more common in scleroderma.
A couple of things. Did she have arthritis?
She specifically did say that she has generalized weakness and weight loss.
So why did you diagnose rheumatoid arthritis?
We initially didn't jump into it. After saying we worked up entire serology.
That's not how we work. You guys
Only you said, don't rely too much on
investigations. If there is no arthritis, why rheumatoid arthritis is coming up? Just because CCP is positive.
CCP is positive as well as...
No. It is SLE, looks like SLE.
SSA-ROS2 rapid positive. Lupus overlap is probably...
Lupus overlap is present. The DSDNA is there, low complement levels are also there. So,
that's it. And no overlap. How do you get a PCR score of more than...
Exactly. That was my next question. When she didn't have an arthritis, how did you...
No, she has joint involvement. Yes, sir. Arthritis is like multiple joint involvements. 4 to 6 joint involvements are there.
SLE can have arthritis?
No, sir, I'm talking about RE.
No, I'm asking SLE can have arthritis?
She can musculoskeletal.
Sir, what is the difference between SLE arthritis and RA arthritis?
RA arthritis is symmetric, sir, and
SLE?
and
erosive arthritis, deforming arthritis.
RA is...
What about SLE?
SLE can also. It's the long standing.
Usually not. Just another thing. When you are using a SLEDAI, it is only designed for SLE. When you have an overlap as a diagnosis, you can't use it. Okay? And the classification criteria is not meant for diagnosis. You can't use a classification criteria and tell that I have diagnosed this case. Because it is for research. If you are putting this patient for trial, then you use a classification criteria. Otherwise, anybody will satisfy a classification criteria. Even a TB would have this thing.
No questions from us, just one comment. Just make sure the CRC is removed from there. This is a different conference. You can't.
Yes, like
this is clinical Hyderabad you presented. Come on, we have also attended. Okay.
It was sent in the mail, so I played the same templates.
So whatever it is, you should not use the same thing and you're presenting somewhere else because
no, sir, it is sent in the mail to present in the same template. That's why patient. Yeah, they have sent it. Template was sent in the mail.
Because the previous person didn't have any weight.
So
case, the only thing is that as she told, classification criteria cannot be for the research purpose. RA is, it doesn't fit it. Maybe still I can say lupus overlap because RO, SSC.
We got carried away by CPC.
Joint
Joint involvement then SNE. You said CPD phenotype, no? Otherwise you should have said RA phenotype. Yes, CPD. I have not heard of
She had a predominantly pericardial effusion.
Yes.
More into SNE.
One more, what was that year? Photo year for what is it?
Sir, she was diagnosed with exfoliative dermatitis with very crystal.
What is that hyperpigmented pinna lesion? What is that?
What kind of rashes you get?
That lesion is there with SLE.
Was there?
Was this, but
don't think too many things. When you same thing, whatever you apply in medicine, same thing applies in rheumatology also. If there is a best fit into one diagnosis, keep it simple and keep it into one diagnosis. If there is a best fit into one diagnosis. When you're not able to explain certain things, fine, you can bring an alternative diagnosis or make it an overlap or something. But when there is a best fit,
I repeat that there is a difficulty in swallowing sclerodactyly and some other skin manifestation of scleroderma was there and pulmonary hypertension was there. Only odd thing of the SLE is I think neuropathy, vascular is more common in scleroderma. SLE also
they'll have more symptoms. Scleroderma, they'll have more symptoms because of all these things.
So
presenting a case of acute hyperkinetic movement disorder with seizures and psychiatric manifestations. For background, neuropsychiatric manifestations account to 30-40%.
Make the 4 points there.
30 to 40% of SLE patients and can affect central as well as peripheral nervous system. The American College of Rheumatology nomenclature mentions 12 central nervous and 7 peripheral nervous syndromes as part of neuropsychiatric SLE. Whereas movement disorders like chorea include only less than 1% of SLE cases. Chorea and SLE presents as acute unilateral hyperkinetic movements due to basal ganglia involvement, links to immune mechanisms like antiphospholipid antibodies and microvascular ischemia. Clinical presentation: a 17-year-old female known case of SLE. A 17-year-old female known case of SLE for the past 2 years presented with right-sided involuntary movements for 1 week, affecting her activities of daily living like eating, dressing, and bathing. Sleep was disturbed, delayed onset, intermittent awakening, and difficulty in awakening, sleeping after awakening for the past 1 month. Behavioral changes were seen with increased anger and crying for the past 1 year. Focal seizures, which were advertine, focal seizures of the right upper limb were seen once in a month for the past 2 years, and she's on medication for that. On examination, right-sided hemichorea was seen, difficulty in APLA panel came out negative at the interval of 12 weeks twice. Hematological indices showed there was no significant inflammatory markers. MRI brain showed prominent perivascular spaces in bilateral basal ganglia regions and bilateral frontal lobe and mild cerebral atrophy. The patient was started on oral hydrochloroquine 300 mg, oral prednisolone 20 mg, aspirin 75 mg, azathioprine 50 mg. She was also started on risperidone 0.5 OD and oral melatonin 3 mg. And she reported improvement in motor disturbances as well as behavioral disturbances after 1 month of follow-up.
Just show where is the chorea movement. Don't pause it.
This is the original.
Hey, you have to tell where is the chorea.
It's the right-sided.
Right where?
Right hands. And after treatment, this was the 1 month. Involuntary. Semi-purposeless, involuntary. Rapid semi-purposeless.
And what is non-repetitive associative hypothermia?
geriatric children from repetitive movement, from the deafness movement disorder. I'm not very sure is it chorea. Maybe it isn't chorea because movements are repetitive. Where is the lesion in chorea?
Basically,
So her MRI didn't show it.
MRI showed infarction in the PC.
Is there?
Yes.
That's very good. I'm not able to see that it's not a typical choreotic movement. Some extra movement possible.
Detailed mechanism, the exact pathogenesis of chorea and SAD can be multifactorial. It could be due to ischemia of small and large vessels.
What else do you have to say? Yeah, we'll ask. No, don't worry. Presentation was photo only. You should have made it in a slide form. You yourself are not able to
This
appreciate it.
media is good. So you should make it. Yeah. Okay. So SLE rarely causes chorea. SLE more commonly causes?
SAD more commonly causes disturbances, sleep disturbances.
Seizures can occur?
Seizures are also
Partial seizures.
partial. Like in this case, focal onset seizures are.
Focal seizures she had. She had seizures, she had this thing. So explanation is vasculatic infarct of the vessel ganglia. And it subsided after, and she was on risperidone on steroids. Jathioprin and equosprin. Okay.
Is chorea is a manifestation of what this thing in lupus? Can you answer? Because it has been mentioned in the previous presentations. There was a session exclusively on that.
Basically, there is
That is associated with what? Chorea.
I think you told us.
seizures.
You have told so many things are negative also. Apla.
But this is happening.
Doesn't matter.
Commonly assessed, see, endocarditis, chorea are commonly assessed after.
They are non-classical.
So a negative apla need not be repeated in 12 weeks. No. This you'll have to indefinitely repeat. So you said it is chorea, and we know it is autoantibody mediated, but you have demonstrated vasculitic lesions on MRI. So when we say autoantibody mediated, what we mean is an autoantibody goes, sits on a synapse and changes the way the synapse interact with each other. It is not a structural deformity that happens. But here you have demonstrated a structural deformity. So is there any other treatment that you would have wanted to do? Okay.
Further investigation, anti-MMPA bodies could be seen for the psychiatric manifestation.
Thank you. As an intern, you are presenting the case. Only thing is that you have to probably make it a PowerPoint with this video. Yeah, these are all rare manifestations.
To conclude the conference by my case, after very much discussions on vasculitis, because the case which I am going to present will help you know how the diagnosis of this patient evolved over time and how dangerous it is to miss a vasculitis diagnosis. So my case is today is a sequential multi-system ischemic involvement in Takayasu arthritis, having peripheral, cerebrovascular and cardiac manifestations. So before going to the case, just a background about Takayasu arthritis. It's a large vessel vasculitis and it involves multi-organs including brain, cardiac. So coming to my case, a 35-year-old woman from Chitradurga, she presented to YMCH with main complaint of left upper limb distal weakness for more than 10 days. So the evolution of the history or the history of presenting illness, the patient was apparently normal 6 months ago. So she used to carry her daughter to nearby home every day on holding her in the left hand. As days progressed, she noted out that she is not able to do even moderate activities like combing hair, even lifting vessels with the left hand. She went to a local hospital, gave there some NSAIDs, pain did not subsided. So one fine day, the pain got increased. She went to the local clinic. They told pulse is not palpable, patient is in shock, and pumped her with multiple amount of PRBCs. Patient landed up in pulmonary edema and became unconscious. And they went to other hospital. They told it's a stroke. MRI was done. MRI was normal. Finally, she came to YMCH in an altered sensorium. So when we received the patient's main complaint was left upper limb weakness, distal more than proximal, for more than 10 days. And also she is complaining of left eye visual loss, which is progressive over 6 months, and also complaining of EC fatigability. General examination findings, first thing we noticed was bilateral radial pulses were absent, and on fundoscopy we noted that left optic disc pallor was there, and also on motor examination we found out that left upper limb weakness was there, distal more than proximal, and reflexes are preserved and sensation was intact. So there are no any signs telling there is a pyramidal involvement of this patient. So with this in our mind, we formulated our differential diagnosis. First thing we thought was no UMN signs or symptoms. We never suspected it was a pyramidal weakness. So the differential diagnosis for her we kept was Takayasu. Directly we went because she is a 35-year-old female absent, which is fitting into the Euler criteria of 3 out of 6 criteria. So first differential diagnosis we kept as large vessel vasculitis, which is Takayasu. Other vascular causes, other differential diagnoses which are less unlikely in this patient was cardioembolic and hypercoagulable states. And other neurological mimics, cortical stroke is very unlikely because she doesn't have any pyramidal symptoms or UMN symptoms at the time of presentation. So with this differential diagnosis in mind, we went on to evaluate her. Before this evaluation, she had done an MRI outside. MRI is not showing any acute infarcts, just some chronic ischemic changes in the frontal lobes. So general blood investigation, we got our inflammatory markers elevated, autoimmune workup was negative, and we also did a thrombophilia screen, but she never had any obstetric history of abortions, but we did thrombophilia screen, PTFD was in the normal limits, and we did an autoimmune workup because in our mind we are thinking of vasculitis. So, but ANA was negative, ANCA was negative, infectious screening was negative. So, also we did a 2D echo. 2D echo is showing some global hypokinesia. I need to remind you that this patient had no prior comorbidities before this presentation. So, these investigations strengthened our differential diagnosis of Takayasu because of elevated inflammatory markers and other being normal. So then we went ahead with CT angiography. CT angiography showed classical appearance of, you see, the near total occlusion of left subclavian artery, which is more common in Takayasu arthritis. And also other findings we got to find that long segment subtle narrowing was there. This is in the first presentation. And also she has stenosis of the left subclavian artery. So our final diagnosis after all these investigations we arrived at as large vessel disease Takayasu arthritis. We gave methylprednisolone 500 mg OD for 5 days and we started on our MMF because given the condition of the patient and the progression of the disease, we thought that disease activity is very high because the progression was very rapid. So we counseled her regarding the IV tocilizumab. So we gave her IV tocilizumab, IV 400 mg 1 injection, and we continued the mycophenolate mofetil. We added antiplatelets, high intensity statins, and as previous 2D echo was, as I showed, it showed global hypokinesia. We want a full cardiac evaluation of the patient, thinking of cardiac involvement in the Takayasu arthritis. But unfortunately, the patient requested for discharge against advice and went. Now, that first presentation was on 19th of December. The first presentation was on 19th of December. The second presentation of this month, on 19th of January, patient came with altered sensorium, left upper limb and lower limb weakness. The discharge medication she is on was Visalon, mycophenolate mofetil, Epixaban. So this time we did an investigations, again elevated inflammatory markers, global hypokinesia. This time MRI brain showed an acute infarct. Fully, right MCA was fully gone. She had developed a stroke this time. So the patient finally succumbed to the cardiogenic shock. When we received the patient, the ejection fraction was 35%, she went into cardiogenic shock. So final diagnosis at the outcome was recurrent large vessel ischemic events, malignant triceps infarction, progressive cardiac involvement and cardiogenic shock. So when we evaluated this, it was looking like a Takayasu arthritis with rapid involvement of brain along with the cardiac and peripheral vessels. So the learning points, the first thing was ischemic limb weakness.
Prednisolone was given.
Methylprednisolone was given. We added an immunosuppressant and also because we want to add a methylprednisolone along with
That time that angiogram was done, na?
Angiogram was done. That angiogram was showing left occlusion of subclavian artery, mild occlusion.
Was there any attempt to stent or this thing?
The thing is, we discussed with the vascular surgeon that time for the revascularization. They opined that considering a given inflammatory condition, it's dangerous to do a procedure at that point of time. So they advised us to give a biologic and let the inflammation settle, and we can go ahead with revascularization.
So it was not attempted.
No, sir.
So she was put on antiplatelet.
Antiplatelet was kept, high dose statins were also kept. But that presentation we want to evaluate her cardiac status because given her no comorbidities, her rejection fraction is too much low, 35% with global hyperkinesia.
Rejection fraction was 35%.
35% with global hyperkinesia.
Okay, global. There was
No sir, no regional wall motion abnormality.
Since you have specifically mentioned that you are third year medicine postgraduate, your examination is definitely incomplete. In Takayasu's, without labeling or without a diagram of all the peripheral pulses and all 4-limb BP, I don't think you will be able to. And the PG examiner, if I don't know what Mukhyamantri Prabhu will say. Because you have said radial pulses absent and you
what about the other pulses?
The other pulses are felt, sir.
It's very unlikely that
No, sir.
the pulses are felt.
Carotid was not there. Radial.
You didn't mention.
Radial was not there.
Bruise you didn't mention.
No bruise, sir.
I don't think you would have seen, looked for it.
Yes, sir. No,
Because
for it.
had you drawn the diagram and then the BP, then I'll say, okay, you might have missed the Brui or you might have missed it, but you've not done that. So that is the first thing. I don't think as a medicine postgraduate that will be accepted. Though you're not into rheumatology,
Yes.
I don't think that will be accepted. So that is one part. Just go to your diagnosis part. No.
Before.
And initial presentation. Okay, in Takayasu's, pulses are absent.
Pulses are absent.
Why you didn't get ischemia in the limbs?
Because collateral circulation will be there.
Collateral circulation
Collateral
sort
circulation.
of open up.
Yes, sir.
Why the brain is sort of affected, collateral circulation will be so much, no?
No, sir. Initially, the thing is like if the occlusion is usually in Takayas when the subclavian artery is occluded, it will be post the vertebral artery. I mean, before the origin of vertebral artery. So usually brain will not be affected. But in this patient, the second time presentation was fully occluded subclavian artery. So that's why she had a massive.
They had carotid and involvement also. No?
Carotid also. Right carotid was initially mildly involved.
So, can you think of some condition where carotid is not affected, subclavian is affected, and yet the patient develops a stroke? What is that called? Some steel?
Subclavian steel.
So is it possible?
It's still possible.
So can there be myocardial involvement in Takayasu's?
Yes, sir. Actually, we suspecting from the starting. Actually, when the
there's no need to suspect. There is
there's a myocardial involvement, but to prove it, it is in a Takayasu's.
Pardon? There's no need to prove it.
Yes, sir.
Takayasu's
can cause myocarditis.
clinico-radiological diagnosis.
Yes.
You don't have to prove anything else.
She had a myocardial involvement.
So there is Takayasu's myocarditis.
Yes.
Right? So
Yes.
there is Takayasu's myocarditis and this
And with the cerebral involvement and also peripheral involvement.
So were these the only pulses? Only the upper side pulses were absent?
Yes,
lower side pulses?
lower side pulses are all there.
All there.
The problem is with the same condition, she was roaming around the hospital for 6 months. Every time only one pulse will be checked, and they'll tell it's a shock. They went to all the
Okay, that's okay. That's the usual standard. Since you have presented so much about Takayasu's, do you know what is the classification of Takayasu's?
Yeah, it comes under.
No, angiographic classification. What is it called? Or how many classes are there?
It's called Lumanos classification.
Okay, how many classes are there?
There are 5 classes in it.
Good.
So, is there a chance that this patient also could have had hypertension and you have not treated?
No, she had a hypertension. I mean, before coming to our hospital, it was documented that 200 by 110 was the BP. But we are confused because the documentation was, patient was in shock. BP was not mentioned. Inotrope they started and sent the patient to other hospital.
What could you have done differently to find if she had
Renal artery stenosis, I mean, for if you have hypertension.
to find if she had hypertension or not? How could you have measured BP?
The lower limb BP.
That's why we are so interested in the lower limb BP.
The BP was normal when she came to us.
What are the causes of hypertension in Takayasu's?
Renal artery stenosis is the one of the main causes. Renal artery, secondary hypertension.
Okay, you said there is a pallor in the optic disc.
Yes, sir.
Are you aware of some retinopathy that Takayasu's can
Ischemic
cause?
optic neuropathy, chronic ischemic optic neuropathy.
Retinopathy.
Retinopathy.
Do you know whom Takayasu is?
Yes, sir. Ophthalmologist, Japanese ophthalmologist.
Okay, good.
sex matters. However, you cannot confuse in all these things, specifically when you're in a competition. So, because all these things will be looked up when you're in a tie. So, the first prize winner for this is Dr. Shrikar from Yenapoya. Dr. Hemant from Hassan is second prize. And third we have a tie between there is Dr. Karthik. Thank you so much. I hand it over to Dr. Loki.
No, nothing to talk. They are best of the best or best among the lot.
Sir.
What, Prabhu?
No. In the sense, they are selected cases.
There were
All
15
cases are good.
abstracts were there. So
They are
we
selected.
can't present 15 abstracts.
So they have chosen the best cases.
Best cases from that.
And based on the performance only we have decided.
Thank you.
College, topics, and the chairpersons.
Good morning, myself Shashwat Gautam, finalist student, Koims Medicary. My electives posting was also orthopedics, and I saw 2 cases of rheumatoid arthritis. So I got to know how to take history, how you should ask about the morning stiffness. It should be more than 30 minutes. And in pediatric cases, how should you do that? And then how you should examine the small joints. It should be bilateral. Moreover, how you can correlate arthritis with SLE or vasculitis, and you should see whether anti-CCP is positive, ANCA. Then moreover, it was very good for me because I saw one case of sarcoidosis also. The patient was taking steroids, and it was an inflammatory case, and the patient was a chronic case. So you should know how to differentiate between sarcoidosis and TB also, because in both you will see hilar lymphadenopathy. Then the pregnancy with arthritis in pregnancy, that was also very good. Then the case presentations were also very good. And yeah, I would like to attend more CMAs in future. Thank you.
Good afternoon. Myself Sanjeev, postgraduate from General Surgery Department. So, rheumatological topics are basically less spoken and less teach. And from the CME, we are able to get exposed to various topics in the rheumatology field. And even in the entrance examinations, many questions do come from these topics of vasculitis and SLE. And the case presentations done by all the PGs were very informative, and less rare presentations were presented. And many more CMEs like this would be helpful for all the postgraduates and thank you.
So good evening, I am Vikram Raj Jain, I am final year student. So first of all, I would like to comment on the PPTs. I was really inspired by how the PPTs were made, and from that I learned that the more of you add your own experiences and your cases with the photos you took, the more interested you will be in teaching and others in learning and listening. And sir, I like this topic today a lot because just a few months back I was at my home and some neighbor told me that she was having chikungunya 6 months back, and from then till now she is having severe joint pain in her digits and shoulder and knee. And one sir said that the patient would come back to us. It was really true because she was changing her orthopedicians, but she was not getting any treatment. Till now she is telling that they are still searching for what's the problem in her. So from the discussions I got to know that if that's the case, then we give steroids, and still if not resolved, then we have to treat it as rheumatoid arthritis. So maybe that can be one of the diagnoses for her, or it might be a differential diagnosis. So I was happy that I attended this, and I would really like to attend more.
Distal and differential joint and spine. Okay, cervical spine involvement only in the later stages of rheumatoid arthritis. So chronic, symmetrical, inflammatory, polyarthritis, upper limb more than lower limb with relative sparing of DIP and spine. You can pick up all these things clinically. You have a diagnosis even without investigations. Yes. So this is what you should do at the primary and secondary care level. Primary and secondary care level. Of course, in tertiary care level, your demands will, your amount of investigation, the amount of thinking that you have to do will basically depend on the area where you're practicing. So that is the most important thing that you have to know. All of us will be practicing. It need not necessarily be so that all of us will be practicing in an urban area. Some of us will be semi-urban, some of us rural, some of us will be community-based. So if you are community-based and if you know chronic, symmetrical, inflammatory, polyarthritis with relative swelling, you should be able to pick up rheumatoid and you should be able to pick up or you should be able to start them on what? You tell me which drugs do you want to start them on? Steroids? Yes, no. What have you learned today? Steroids? Yes, no.
Yes.
Doubtful. Okay, steroids. Sir is saying yes.
Yes and no.
Okay, yes and no. NSAIDs? Yes, no.
Yes.
Yes. DMARDs? Yes, no.
Yes.
So DMARDs we have a definite yes. Okay. So NSAIDs is what? Non-steroidal anti-inflammatory drug. Steroid is what? Anti-inflammatory. Steroidal anti-inflammatory. So you've got only two classes of anti-inflammatory. So your treatment for rheumatoid should be based on presence or absence of inflammation or how much of the inflammation is there. And your disease modifying anti-rheumatic drugs are the ones that will modify the course of the disease. That is why they are called as disease modifying anti-rheumatic drugs. So in an acute phase or in a painful phase, to take care of the inflammation, either you give NSAIDs or steroids or in combination, but not on long-term basis. So this is what you have to remember. No harm in giving NSAIDs, no harm in giving steroids, but not long-term. And neither steroids nor NSAIDs will modify the course of the disease. Neither steroids nor NSAIDs will modify the course of the disease. So you have to have disease-modifying anti-rheumatic drugs. Right? So what are the disease-modifying anti-rheumatic drugs that you know? Methotrexate. Next. So let's not go, always start from basic, go to higher medicines. Don't start methotrexate, rituximab. Don't skip from A to D. Go A, B, C, D, you'll be in a more this thing. So methotrexate 1, hydroxychloroquine. Pardon? Azathioprine, not much in rheumatoid. Rheumatoid with vascular rheumatoid arthritis, it's a different thing altogether. Basic rheumatoid I'm talking about. Sulfasalazine, hydroxychloroquine. So these are the 4 first line DMARDs that we usually prefer in a patient with rheumatoid arthritis. These are the 4 first line DMARDs that we usually prefer in patients with rheumatoid arthritis. Okay, so in rheumatoid arthritis, 4 first line DMARDs you have to remember. You prefer combination or single? Who are for single, raise your hands. Who are for combination, raise your hands. Single. Who are for combination? Okay. Let me put it in a simpler way. How do you treat your diabetes? Single OED or combinations? Why? Same thing in rheumatoid also. You want combination DMARDs. Primarily, the target of each DMARDs will be different. So just like you manage your diabetes, you manage your rheumatoid. Right? So, how do you assess treatment for diabetes? What do you measure? HbA1c, because that tells you control of your glycemic problems over the last 3 months. Same thing rheumatoid, more clinical, last 3 months, what is the improvement? So you tend to change or adjust the doses of medicines, provided they are on full dose, at least for 3 to 6 months you have to wait before you get a response. So same thing, I'm just trying to make it simple so that our KRA president told that you all should be able to identify rheumatoid and at least know what to do once you get a patient with rheumatoid arthritis. Out of the 4 DMARDs, what are the DMARDs that are contraindicated in pregnancy? Methotrexate, definitely contraindicated. Then? Pardon? Leflunomide, definitely contraindicated. So sulfasalazine and hydroxychloroquine, relatively safe in the periconception, conception and lactating period. So these are the 2 points that you want to remember. So all pregnant women or all young ladies, you know that rheumatoid is a disease of a younger generation. Okay, 20, 30, 30, 40, like that, of a economically and a reproductively productive group. Okay, so methotrexate and leflunomide, even in the male sex you have to avoid or you don't have to avoid? Which one? Earlier they say that you have to avoid methotrexate. Nowadays methotrexate need not be avoided in male sex at all. Lefranamide no. So that is one thing. Second thing is sulfasalazine causes a little bit of oligozoospermia. Okay, but there is no contraindication. If they don't conceive or something like that, you may want to consider stopping sulfasalazine. So you know these few things, you know how to manage a rheumatoid. At least you know what to do and you know what not to do. Dosing will depend on each consultant who's practicing here or each of your colleagues who's practicing. Dosing will depend. Ideally, in diabetes, what do? You give full dose or you don't give full doses? Combination and you go up full dose. Same thing in rheumatoid also we do. Combination, full dose. Provided side effects are not there. What are the side effects they are looking for when you're giving DMARDs? Pardon?
Cytopenias.
Right. So most of the drugs that we give in rheumatoid, these are disease-modifying anti-rheumatic drugs, and these are all relatively cytotoxic. Relatively cytotoxic in inverted commas because we're not going up to the cancer dose per se. Okay. So methotrexate causes cytopenias. Your sulfasalazine can cause cytopenias. So you do look for cytopenias before giving DMARDs. What is the other thing that you want to look for? Hepatotoxicity. Which drugs are hepatotoxic? Lefranamide and methotrexate. So methotrexate and lefranamide both are hepatotoxic. Then you have looked at blood counts, you have looked at liver functions. What are the other functions that you want to look at? Pardon? Kidney, right. So you always look for basic blood count, kidney function, liver function. Blood count normal, kidney function normal, liver function normal. You can give DMARDs relatively safely in all these patients. Provided that pregnancy issue plus minus, that you have to decide, which you can decipher historically. What did we say? Combination DMARDs, hike up to the full doses. Right? So what is the maximum dose of methotrexate? 25 mg per week. Please finish it. It's not 25 and you stop it. 25 mg per week, not 25 mg daily. So methotrexate is given as a weekly one dose, and for a 60 kilogram adult, it should be up to 25 mg. Otherwise, for pediatric, we calculate in per meter square body surface area, 10 to 15 milligrams per meter square body surface area. I'm not talking about 0.5 mg per kg. I'm talking about meter square body surface area. So 10 to 15 milligrams per meter square body surface area in children in pediatric age group. So that's how we calculate doses. Maximum dose of lefranamide. Available as how many mg tablets? 10 mg and 20 mg. So maximum is 20 mg. Hydroxychloroquine maximum dose? Yes, 400 mg. So maximum dose is 400. That is, we say 5 to 7 mg per kg body weight. Sorry, 5 to 7 mg per kg. Correct. 5 to 7 mg per kg is the hydroxychloroquine dose. Sulfasalazine up to 3 grams per day in a 60 kilogram adult. Up to 3 grams per day in a 60 kilogram adult. Okay. So now you know how to identify rheumatoid without investigations. So rheumatoid is chronic. Tomorrow, one person comes to your OPD or your practice, doctor, joint pains for 15 days, 20 days, a lot of swelling and all those things. Though it may be evolving into a rheumatoid, you don't label them as a rheumatoid, you keep your mind open. But keeping your mind open and not diagnosing is fine. But you treat. And what does this patient have? Inflammation. You treat the inflammation. That is why Dr. Chengappa was saying, I'll give NSAIDs, I'll give one shot of steroid, I'll give this. Because your first, this thing is to bring down the amount of pain that the patient is actually having. Okay? Bring down the amount of pain that they actually have. And when a person with rheumatoid comes to you with pain, you have to address the pain. There is no chance of anyone being a superhero or a superheroine saying that I'll tolerate my pain. If you're tolerating your pain, why did you come to me? Yes or no? You have come for a problem that causes pain. You take care of the pain. Right? So this is what you have to remember. There's no question of tolerating the pain because your disease activity indices are all depend on how much pain a person is actually having. Okay? Pain determines the quality of life. I'm sure all of us would have experienced pain in one way or the other. If we have experienced pain in one way or the other, be it a dental pain, be it a headache, but that is the pain that you describe it as your worst pain. Correct? So pain is a very subjective thing. That is what you have to remember. The way I tolerate my pain, the way you tolerate your pain will be different. So don't disrespect any pain. At the same time, it is important to look for diffuse aches and pains in a patient with rheumatoid, which may not be limited to the joints, which may be beyond the joints, in the muscle belly and all those things. That says that there is some amount of a fibromyalgic component. It's not in the joint per se. Okay? That just says that it can be the fibromyalgia. Are everyone here or what is it? Some more are expected to come. No problem. I was just thinking whether to continue or stop. So name one investigations that now you know how to at least identify a rheumatoid, know what investigations to be done, and know what drugs to be given. Methotrexate, always weekly once. Always weekly once. You know which patients you should not give. Renal, you require dose adjustments. Those with cytopenia, this thing. Uneducated patients, you have to be very, very careful. Uneducated patients, you have to be very, very careful. Just like uneducated patients don't tell the history very properly, they don't take your advice also very sincerely. Right? But when you land up in problems, you are in soup. Okay? So just be very careful. Go. You want to tell something? So, uneducated patients, be careful. So that's why it's important to see what is the economic status of the patient. And I said don't go to biological straight away. You can't prescribe rituximab to a beggar. No one is exempt from developing rheumatoid arthritis. So you start with basic drugs in our level, primarily because most of the insurance companies or your governmental schemes do not support treatment of rheumatoid arthritis. Right? Do not support treatment of rheumatoid arthritis. So you start with basic. Not responding, you go to higher ones. So what you have to do, make sure you identify the disease properly, make sure you should know what not to give. Give the patient what is economically viable. Economically viable. Okay, give the patient something that is economically viable. That is also very, very important in our setting, primarily because right now you people are not spending out of your pocket. Once you start spending out of your pocket for health reason, you'll realize how much of a headache it is. Okay, let it be 10 rupees or 20 rupees or whatever it is. On a daily basis, it adds up. And these are all chronic diseases. You ask me when the disease will go away, I'll be looking up to God only. I don't know. It all depends on how well you control. And how well you control or how well you treat is dependent on how easily you identify the disease. Okay, how easily you identify the disease. So always make sure you keep the patient's economics into the hand because it matters in our country. Okay, it matters in our country. So, not responding, combination DMARDs, you add more and more drugs, you don't subtract. You subtract only if there are side effects of the drugs or if there is a contraindication. Okay, so idea is take care of inflammation, steroids, non-steroidal anti-inflammatory drug, not on long-term basis. Early institution of DMARDs will prevent deformities. Prevention of deformities will help you get back to your work. That is your whole idea. The idea of treating rheumatoid arthritis is not to increase the lifespan of the patient. You will be indirectly increasing the lifespan of the patient. Lifespan of the patient is not decided by us. It is decided by someone else. So that you have to improve the quality of life of the patient. Quality of life, now you saw in the first quiz session, no one is exempt from developing a disease. Imagine, God forbid one of us have rheumatoid arthritis and my ambition was to become a surgeon. Imagine my hand and imagine what you have done to my ambition and how you have shattered my ambition if you have not treated me adequately. Okay, so this is what, always keep yourself in that patient's shoes and think. You will be a better person and you will be able to identify the problems better. Okay, so that is about rheumatoid. Now SLE. How will you identify SLE? SLE, diseases of the young or old? So diseases of the young. So you will be more careful in diagnosing SLE in elderly age groups or too younger age group. So these are the two takeaway points for us. Don't diagnose SLE in a patient who is too elderly or too young. So that is point number one. Point number two. ANA is always required in a patient with SLE. Yes, no. How many for no? No. So ANA, the presence of ANA in a suspected patient of SLE is always diagnostic of SLE. So always clinical first, lab investigation next. Okay, that is point number one. Point number two, let's say there are 60 or 70 of us who are present here. I can bet you on my life that out of 60 or 70, 5 of us will be having rheumatoid factor, ANA, HLA, B27, one or the other autoantibody positive. Okay, so what does it mean? Presence of an autoantibody does not say that you have a disease. So you don't order any screening test for any connective tissue disorder. You order a diagnostic test. The diagnostic test for lupus is ANA. There is no screening test. Understood? You screen for pap smear. You do cervical cancer screening, pap smear. You random blood sugar. You screen for hypertension. Okay? Because if you are hypertensive, blood sugar is high, blood sugar is high. But if your autoantibody is positive without you having clinical symptoms, you can imagine the amount of anxiety you would have caused to the person in whom you have tested. I am not saying patient in whom, I am saying person in whom you have tested. So presence of an autoantibody in the absence of a disease does not necessarily mean that this thing. Okay, but can you write it off? It's not an ideal world, is it not? Once an autoantibody is positive, God knows when he or she will develop a disease. You will have to keep following up. So that's why don't test unnecessarily unless you are really clear on why you want to test. So that is why in rheumatology we say that there is no battery of tests that we do. There is no vasculitis profile, there is no SLE profile and all those things. You order the specific investigation in the clinical condition in which you feel this thing has to be done. Right? So that is about SLE. You diagnose SLE, clinical plus ANA. So can you have ANA negative lupus? Yes. You can have ANA negative lupus. Okay, I agree that you can have ANA negative lupus. But for all practical purposes, if I were to talk to the audience of this one, who I assume are not rheumatologists, I will say that ANA should be 100% positive in all patients with SLE. There are some exceptions. Let's leave those exceptions aside. That may not be required at your level. Okay, so all patients with SLE should have ANA positive. Do all ANA positive patients with certain symptoms of arthritis should really have SLE? Yes, no. Pardon? No. So ANA can be positive in many other connective tissue diseases besides SLE. Can you name some connective tissue diseases where ANA is positive? Sjogren's syndrome, MCTD, JIA, very good. Systemic sclerosis, dermatomyositis, pattern might be different. Even your rheumatoid ANA can be positive. Okay, even your rheumatoid ANA can be positive. Likewise, your rheumatoid factor can be positive in whatever the connective tissue diseases that you have mentioned. So this is what you have to know. So ANA positive does not necessarily mean that the patient has SLE. ANA positive does not necessarily mean that a normal person has got a disease. And ANA positive does not necessarily mean that you are excluded from having a disease. So all these 3 points you have to remember. Right? So next one is ANA profile. So ANA is what? ANA is a broad autoantibody. Right? ANA profile is like dissecting that autoantibody to say which nuclear component it is positive for. So that's what we mean by ANA profile. So we do ANA patterns are different and all those things, not required at your level. But we do ANA first. ANA is screening for SLE. ANA profile is a more specific test. Right? Cost for ANA in an ideal academic setting should be around 800 to 1000 rupees. Cost for ANA profile is 3000 to 5000 depending on wherever you. So best is do the ANA first in a suspected case of SLE. In a proven case of SLE, you can go ahead with ANA profile directly. That's not a problem because you have got nothing else to prove. Right? But you want to know why is it important to do the autoantibody, or why is it important to know? Because different autoantibodies that you demonstrate in the profile are specific for certain clinical manifestations of that particular disease. Now let's say dsDNA. More likely that the patient will have nephritis. Right? Now you have got Smith, very specific for lupus. Smith is supposed to be very specific for lupus. So same thing, there are 16 antibodies that are present. SSA, SSP antibody will say that the person is likely to be, or if it's a female who's planning a pregnancy, there can be neonatal complications associated with it, like congenital heart blocks and all those things. So the subset of autoantibody will determine the disease phenotype or the disease pattern in which the disease going, which may or may not be treated. That's not this thing. Your idea is assess the patient now. See what you can anticipate in future. Right? You don't treat future in anticipation. You don't treat future in anticipation, but you see what you can anticipate in future. There is a difference. Right? So we treat what we see. I don't treat the future. If I don't treat the future, what if anyone is treating the future, that means all of us should be on all drugs for all particular diseases. That's not science. Right? That's not what you are there for. So that's what you have to remember. So in lupus, symptoms, ANA positivity, either way I have told you, and why it is important to say this thing. And what drugs do you give in lupus? All patients of lupus should be on hydroxychloroquine. So that is the first thing that you will do in tomorrow's OPD if a patient of lupus comes to you. See whether the patient is on hydroxychloroquine, or what is the contraindication for hydroxychloroquine? Bullseye maculopathy and skin hyperpigmentation. Everyone is cosmetically worried. Is it not? Black is also beautiful. That's what you have to remember. Okay, black is also beautiful. The gods that we pray to are all black in color. Right? So that is how you have to convince your patient. Okay, so that's what you have to remember. Skin hyperpigmentation. But of course, if the skin hyperpigmentation is worrying, you respect the patient's this thing, and you have to say that I'm not giving hydroxychloroquine because of skin hyperpigmentation. Right? So that's what you have to remember. So hydroxychloroquine, it doesn't prevent any immediate this thing. It has got long-term implications in preventing complications of lupus. So that's why hydroxychloroquine all patients should be on. Can you use methotrexate in SLE? Yes, no, don't know. How many for yes? How many for no? How many for don't know? Yes, at least. Yes. No. Okay, rest I assume I don't know. Okay, so methotrexate also can be used in SLE. That is why the DMARDs are called as disease-modifying anti-rheumatic drugs and not disease-modifying anti-rheumatoid arthritis drugs. They are not specific for rheumatoid arthritis. They are disease-modifying anti-rheumatic drugs which can be used in many other clinical conditions other than lupus, other than rheumatoid, sorry. So, methotrexate you can use, leflunomide I have used, hydroxychloroquine is a disease-modifying anti-rheumatic drug. Sulfasalazine we don't use because it causes increased amount of reactions in the patient with lupus. It can precipitate a drug-induced lupus also. Sulfasalazine we don't use. Right? So these are whatever are the disease-modifying drugs. These are all not truly immunosuppressive. Not truly immunosuppressive because we are giving at low doses. That is why they are not called as immunosuppressive drugs. These are called as disease-modifying. Or they modify your immune system to a certain extent. So that means what? All these drugs can be given in milder manifestations of lupus. Milder manifestations of lupus. Whereas, once you go to renal involvement in lupus, pericardial tamponade, all those things, that requires much higher doses of medications. That's when you consider high dose steroids, cyclophosphamide, mycophenolate, azathioprine, so on and so forth. Right? So, more severe the organ involvement, more aggressive is going to be your therapy. That's what you have to remember. More aggressive is going to be your therapy. Right? So, lupus. So, once you start treating lupus, complications can occur in future. Yes, no. Yes. Okay. So, any complication can occur in future. Okay. Now, if I have an adequate control of the disease, like the person who has mentioned nephritis, the case that you saw, adequate control of the disease now, does it necessarily mean that I cannot develop a CNS lupus later? So, lupus is a polyheaded hydra, right? The disease changes just like your mood changes. Today you are happy, tomorrow you are not happy, tomorrow you are very sad, disease will change, right? So, lupus is one particular disease where the course is absolutely unpredictable. So, more you see the patient, more often you see the patient, better you monitor the patient, more confident you are on the way the disease will progress. It's not like RA. RA will be a progressive disease once you identify and controlling, you don't expect future complications. But lupus you don't know. Right? It's like a terrorist. You control Jammu and Kashmir, we don't know what is happening down south. You control Naxal, we don't know what is happening in west. Like that. So that's how lupus is. Right? So this is what you have to know about lupus. Right? Extremes of which be careful. two younger lupus, monogenic lupus. Lupus is a more genetic mediated and two younger lupus. But in elderly age group, all these diseases, whatever connective tissue diseases that we have, only a few of them have got a genetic basis. Only a few of them have got a genetic basis, not all. So these are all polygenic. Many genes will determine, or environmental factors will also determine on how the disease.
We have conducted quiz. We have conducted case presentation, poster. Poster do not have any prize. Case presentation has got 2 prizes, first prize and second prize. Quiz has got 3 prizes, first prize, second prize and third prize. Now sir is going to announce the prize and we are going to hand over. First is going to announce it.
Goes to Dr. Anand Nagesh Hegde and Dr. Shalaka.
I am from MCRI. We are third year medicine.
I am Dr. Anand.
Cash prize. Okay, on cash prize, maybe that 3,000 rupees is there.
Cash prize.
Okay.
Why is that?
It's not the amount is important. Winning is important.
So if it's less, please take contact with the organizing secretary. Okay.
See, he is close to you. JSS.
Okay. So, congratulations.
I am Dr. Shreya from KMC Bangalore. I am Dr. Benita from KMC Bangalore. We are second year PGs.
Easy weather.
He was the one who was answering the what I presented in the morning quiz also. So good. So I asked something else. This is something. So next presentation is for case presentation.
Dr. Raymond from Arts and Institute of Medical Science.
Is there? Ravi Chicken. Please. Congratulations.
No, very interestingly. Here in Bangalore for past 2.5 years. Very nice. Somebody has told him, go to bus stand. So he has gone to the bus stand. Then somebody said, and then he asked them, which bus goes to Madikeri? He has gone to private bus stand. He said, take a bus to Udupi. He has taken a bus to Udupi. From Udupi he has come back to Bangalore. And from Bangalore he has come back to Madikeri. You deserve that first prize, definitely.
Prizes also. There is no cash prize for this one. The second prize goes to Chandragit.
My name is Geeta. I am from JSS, Mysore. Second year, please.
Judges' choice. So now I should appreciate judges also.
And their mentor is announcing their names.
Oh, yeah.
One is there.
One second.
Yes.
Documentation.
So they have been our quiz masters and supporting us for all the CMAs conducting the quizzes.
Yes.
Institute of Medical Sciences. So he is the organizer, chairperson. I thank Kodagu Institute Medical College and in personally Director Sir, Dr. Lokesh AJ Sir, for providing us, providing the KRA as such and our team for us to conduct and bring out this CME. So I'm very happy. I think we have been able to present all the topics which have been discussed and other things. I hope so. Some of you will come to us at certain point of time with all your queries or whatever, or as students or joining the rheumatology as such. So it has been our plan for a long time. As Dr. Vinod Ravindran was saying, today we do something over here. So we will see the fruit after 10-15 years when you will be coming as consultants or some other and working on rheumatology as such over there. So I thank again Yogi Ajay Lokesh sir for his long association with KRA, and as sir said, he is one of the senior IRA member, so even senior to us, I think so. So as a senior from the IRA also, I thank Yogi Lokesh sir. So with the end, we conclude the CME, and we have we thank IPCA for sponsoring the CME, partial sponsoring of the CME, and coordinating the things for few things for us, will let us get together for a cup of tea and have a chit chat